Hi, my dear friends. So today we'll start up with the discussion of microbiology CBoT questions. And as usual, the questions are easy. And if you are focused upon your regular preparation, you must be able to do most of the questions here. And let's add some extra points from my side, which is there not in the explanation and all, which can play a very vital role up in the exam for you. Okay. So let's start up, guys, without wasting time. Yes, which of the following is not a beta hemolytic bacteria? Okay. So this particular one, which of the following is not a beta hemolytic bacteria? You know what is beta hemolysis, guys? Beta hemolysis is complete hemolysis that you already know. Okay. The Staph aureus shows up beta hemolysis. You know that. Mainly it shows beta hemolysis only. Streptococcus viridans is not a beta hemolytic strepto, it's a alpha hemolytic strepto. Alpha means incomplete hemolysis. Streptococcus pyogenes is a beta hemolytic strepto, and Streptococcus ehrlichia is also a beta hemolytic strepto. Means the answer to this question is what? B. Streptococcus viridans, which is the alpha hemolytic strepto, that is not a beta. Means it shows incomplete hemolysis, and this incomplete hemolysis along with the greenish discoloration is termed as the alpha hemolysis. So you know na, three things are there. One is alpha, one is beta, and one is gamma. So alpha is this, that is in the viridans. Beta is mostly seen up in them. Along with that, the gamma is no hemolysis, which is observed in the anterococcus. Okay. So if I like to tell you like this, these is the colony on the blood agar. The complete circle, a zone of hemolysis is formed up, that is termed as beta hemolysis. Is it fine? And if this circle is not complete and along with greenish discoloration, that is alpha. And if it is no hemolysis, then it is termed as gamma. So this is what is regarding the hemolysis stuff. And obviously hemolysis is seen on which particular media? That is the blood agar. And I suppose this is clear. And here the added point which I like to tell you, the Streptococcus pyogenes and ehrlichia, they both are what? Beta hemolytic strepto. And in between, you differentiate on the basis of three tests. One is, Hipurate hydrolysis test, which is positive in the case of group B. Another is CAMP test, which is, you already know CAMP, Christie Atkins Merge Peterson, enhanced beta hemolysis. And this is also positive in the GBS, and GBS stands for group B strepto. Is it fine? And the important question which can come in your exam is bacitracin sensitive and resistant. So remember this particular one, that which one is bacitracin resistant. So bacitracin resistant is again group B strepto, that is the Streptococcus ehrlichia. Is it fine? So these are the important ones which you need to know regarding the hemolysis stuff. Now, which of the following is the optochin sensitive and bile soluble? So here what you need to know, the mnemonic which I used to tell again and again, that is bio. And bio is positive in, the bio is positive in Streptococcus pneumoniae, okay, which is also termed as what? Pneumococcus. And if you remember of this particular thing, that bio stands for what? B is bile soluble, okay. So this particular pneumococcus is bile soluble. I is illulin fermenter, I is illulin fermenter, and O is optochin sensitive, okay. O is optochin sensitive, and you know that the other name of optochin is what? The other name is 2-ethyl hydrocuprin. So this is positive in the case of pneumo, and the same thing is negative in the case of this particular Streptococcus mutans. The bio is negative. Bio negative means bile insoluble, illulin non-fermenter, optochin resistant. That is not sensitive to the optochin. Optochin is a drug, 2-ethyl hydrocuprin. So you get this particular one also bio negative, and this is bio positive. Is it fine? Then afterwards, if you talk about these particular tests, and the extra point which I like to tell you here, the Streptococcus mutans, this particular one, it leads to what, guys? It leads to dental caries. It leads to dental caries, and obviously along with the Streptococcus sanguis, which also leads to dental caries. Both of them lead to dental caries, and they both are bio negative. This question was asked in your FMG exam, and again it can be coming. They can give this history of dental caries and all, and some surgical procedures is being held on, and after that they will tell that some high grade fever happened along with some murmur heard. So obviously they predispose to what? Infective endocarditis. And for the infective endocarditis, which criteria you go for? That is modified Duke's criteria, and which blood culture is in the major one, along with the echo findings of vegetations over the walls, so that you already know. Now, a patient with community acquired infection, okay, developed tissue necrosis. On examination, the causative organism was found to be MRSA. So obviously, you have done a lot of tests like PCR. You can do. You can go for cefoxitin test, screening test, or oxygen screening test. Along with that, latex card is also available. So they want to know that this is already is a known fact that MRSA is being isolated. Which of the following is responsible for the killing of leukocytes and the tissue necrosis as per the pathogenicity? So obviously you know that in the MRSA you will find the MAC gene. So yeah, first of all you try up for the answer. Let's see up what's the answer from your side. Is it MAC gene? Is it altered penicillin binding protein? Is it penton valentine leukocidin? Or all the above is the answer? Yes, please. So answer is, tell please, what is the answer? The answer is penton valentine toxin. Okay, or you can say leukocidin. Actually, this is the one which is there in a normal Staph aureus also, and in the MRSA also. Okay, and this is the one which leads to killing of leukocytes and it leads to tissue necrosis. Whereas this MAC gene and altered penicillin binding proteins, they are the predisposing factors to be a MRSA. That is a different thing. But the question is clear that they want killing of leukocytes and tissue necrosis. The answer goes in the favor of penton valentine leukocidin. And this is the one which kills the leukocytes. And along with that, I like to tell you, if it mixes up with the gamma hemolysin, okay, if it mixes up with the gamma hemolysin, you got to see an action, and that action is termed as synergo-immunotropic action. Synergo-immunotropic action. So that is what is termed as the enhanced virulence. Okay, this is what is termed as the enhanced virulence. Because when these two factors, they meet up, they produce a synergy. And because of the synergy, there is an enhanced virulence in this particular one. So answer is C in this particular. Which of the following is the correct combinations as per you? So obviously guys, we can find like that. Borrelia recurrentis does relapsing fever, everybody knows it, R4R. Okay, epidemic louse-borne, relapsing fever. Rickettsia rickettsii, that is Rocky Mountain spotted fever, again R4R. Rickettsia typhi, that leads to endemic typhus, that is ENT, endemic typhus. Rickettsia prowazekii, that leads to epidemic typhus. Prowazekii leads to what? Epidemic typhus. So that is there. So answer is what, sir? Guys, A is second, B is third, okay, C is 4, and D is 1. So answer is C. So like this, the combinations will be coming up in the exam. You should know regarding important ones at least. Okay. Now, identify the egg given in this particular image. So can you tell me the answer, guys? This is a repeat question of FMG exam only. And this egg is quite famous and most of you must be knowing also. Yes, the answer is very right. You all are right. Trichuris trichiura. The answer is Trichuris trichiura, which is also termed as whipworm. And this particular Trichuris trichiura does not come in the list of non-bile stained egg. That is the NEHA. So obviously it's a bile stained egg. And these particular things which are there at the corners, this is termed as mucus plugs. They are termed as what? Mucus plugs. Okay. So these are the mucus plugs there, and this is looks like a barrel. Okay, this looks like a barrel shape or dumbbell shape egg. And obviously, just now I told her, this is bile stained. This particular egg is what? Bile stained. And if we talk about the other things regarding it, it leads to what all other things? It can lead to coconut cake-like rectum if the infection happens to be in the children, and that can lead later to growth retardation. And this is the organism, Trichuris trichiura, which like sucks the blood, leads to iron deficiency anemia. And you know already what is whip. Whip is like hunter. In Hindi you call it na hunter. Trichinella spiralis, muscle worm. It loves to reside in the nerve cells of the muscles and stays there for the lifetime. So that is Trichinella spiralis. Ascaris lumbricoides. Ascaris lumbricoides is the one whose infection happens by eating the eggs, and this is the one which goes to the lungs for maturation. Okay, remember that. A square N is mnemonic. Another important thing regarding Ascaris is it leads to intussusception, means ilio-iliac, ileocolic, and that particular thing. That is termed as this intussusception done by this Ascaris. And along with that, another important terminology which you should know is that it leads to, what do you say, Loeffler's syndrome. Loeffler's syndrome is what? Massive eosinophilia is there, along with the, you observe the lung opacities and all. So that is important because it goes to the lungs for maturation. That's why it does this. Strongly associated, in fact, with the Loeffler syndrome. And this particular Ascaris lumbricoid, the other name is what? Roundworm. Necator americanus is the brother of Ankylostoma duodenale, and both of them, they leads to iron deficiency anemia. Okay. Now talking about this one, which is the incorrect regarding the measles. First of all, you tell me measles virus is also termed as rubeola. Okay, not rubella, rubeola. And Hindi, what do you call? Khasra. So let's see the first one. The lymphadenitis with Warden-Finkley giant cells in a background of paracortical hyperplasia. You can observe this under the microscope. Is it true? Yes, it's true. That's fine. Okay. So obviously, you should not be putting it here. You should be putting it in this side. That it's okay statement. Vitamin A supplementation can reduce the morbidity and mortality from the measles. Yes, it's a correct statement. The adding the vitamin A supplement definitely reduce the morbidity and mortality of measles. Encephalitis is the most common cause of measles-associated death in the children. This statement is wrong because it is not so. The answer is pneumonia, and it can be due to the measles virus. It can be secondary bacterial pneumonias, and the pneumonia which is done by the measles virus is termed as HS pneumonia, giant cell pneumonia. So that is also one of the points. The rash starts at the head and the neck side and spreads downwards, and that is also true. There is a centrifugal spread in this particular one which you observe up, and it starts from the head and the neck region. Okay, so this is there. That is also correct. So obviously the answer is what? C in this particular one. That is in the measles. Another important point which is important is what is the infectivity period? Rash 4 days before, 5 days after. So that is there important. Besides this, other ones important things are regarding measles, the chronic late complication which is being asked. That is SSPE, subacute sclerosing panencephalitis. That is also a very important statement. Besides that, what is the characteristic point what you observe, what pathognomic feature of measles? That is the complex spot which is observed opposite the lower second molar. Okay, lower second molar along with this particular rash. Mark the correct option regarding the MHC1. It is expressed by all nucleated cells. Yes, it is expressed by all nucleated cells, including the platelet and RBCs. Okay, including the platelet and RBCs. So this is not a correct statement. That is correct statement that is expressed by all nucleated cells, but obviously it is not being expressed by whom? Platelets and RBCs. It presents the endogenous antigens. That's a true statement because you know the endogenous antigens, they are being taken off by the MHC1 to whom? CD8 T cells. So this is the correct statement. Is present antigen to the CD4 helper T cells? No, it's wrong. The MHC2 on the antigen presenting cells, that is involved in presenting it to the CD4 T cells. And the structure includes 2 equal length chains, 2 alpha and 2 beta. No, it is not so. That is in the MHC2. In the MHC1, we have alpha 1, alpha 2, alpha 3 and beta. Okay. So like that we do on alpha 1, alpha 2, alpha 3 and beta. This is the structure of a MHC1. Whereas 2 alpha, 2 beta, they are observed in whom? They are observed in MHC2. So that you already know. Okay, so answer to this question is what? B. Which of the following is secreted from the T helper 1 cells? So T helper 1 cells, guys, secrete up interleukin 2. Okay, what they secrete up? Interleukin 2. And this particular interleukin 2, which is being secreted by T helper 1 cells, is not being given in the options. Then what else? So remember, guys, it also secrete up interferon gamma. And these two, okay, these two along with tumor necrosis factor and all, these two are responsible for what? That granuloma formation. G for gamma, G for granuloma. So answer is interferon gamma. Okay, so this is being secreted in T helper 1 cells, and this particular thing is observed in which hypersensitivity? Type 4. In the delayed type hypersensitivity, you get these particular interferon gamma release and interleukin 2, which helps in the formation of what? Granuloma. And that you already know, the granulomatous lesions, the granulomatous inflammations like TB and leprosy, they are being held up in the type 4 hypersensitivity. Now, regarding this one, the various steps of gene Nielsen staining or acid fast staining, what is the correct order? So first, can you tell me as such only directly we can say what you do in that and what's the mnemonic which I've told you. So guys, it's very simple that first of all you make a smear. If we take example TB smear you make, then heat fix it. Then what you do that over that you pour up what? Carbol fission, and after that particular one you intermittent heat it, okay, and after doing this intermittent heating 4 to 5 times, after that you put up 20% H2SO4, and after that you put methylene blue, and you know that mnemonic which I've told you, car inside se hai blue, okay, car inside se hai blue means carbon fission, intermittent heating, inside se hai, so H is H2SO4 20%, blue, that is methylene blue. And what you observe after seeing up this, you observe a particular slide under the microscope in which the background is what? The background is blue, and against this blue background you find pinkish to reddish color acid fast bacilli, okay, pinkish to reddish color acid fast bacilli. So this is there in that. So let's see the order first, guys. So C should be coming the first, okay, because you flood the slide with carbon fission, and after that you decolorize with acid alcohol. It is being given in this particular fashion here, so that is D. Then is it decolorization directly? So this statement is wrong. So let's see here. C, that is flood the slide with carbon fission. Then B, you have to heat fix the smear. That is what is the logic of what? Intermittent heating. Yes or no? That's why you do an intermittent heating na, to heat fix the smear. And then the D1, decolorize acid alcohol. And if you don't have 20% H2SO4, then you can use the mixture also of acid and alcohol. And A is the contour stain with methylene blue. So this you get that the background is blue, against that pinkish to reddish color acid fast bacilli, and this you observe under which power? 100x. And what is the 100x? Oil immersion lens. Why? Because this is having the maximum magnification. You can observe the proper bacteria under this. And how much bacteria should be there per ml sputum? More than 10,000. More than 10,000 bacilli per ml sputum should be there to be seen on Zn stain. Okay. And what is the modified method of Zn staining here? Quignon's method of staining, that you also know. Cold method of staining, Quignon's method of staining. Okay. Now coming to this, which of the following is not a diagnostic criteria for the suspected pseudomembranous colitis in a 58-year-old man on multiple antibiotics? So the firstly, identifying toxin A or B in the stool samples. So this is definitely there in the criteria. Using stool wet mount microscopy to observe the organism. I doubt this. Okay. Presence of diarrhea more than equal to 3 loose stools per 24 hours for at least more than equal to 2 days. Very right. Correctly written in the Harrison this thing. Observation pseudomembrane during colonoscopy, stomachoscopy. Very right. So basically you have to demonstrate the toxin. Okay. Toxin demonstration you need to do of this Clostridium difficile, that it is having this toxin A or B, that is anterior plus cytotoxin, along with the histopath. Along with the histopath, you can see that particular thing that yes, you are dealing up with the pseudomembrane formation and all. And obviously, you can observe the pseudomembrane also with the help of what? Colonoscopy or sigmoidoscopy. So all the statements are true except the B, because you do not go for stool mount microscopy to observe the organism. It will not be seen like that. Is it fine? Because even though if you are able to observe also, how you will know that it is toxigenic? Because it is a normal commensal. Along with that, what is the best ideal combination which should be done to diagnose of this particular condition? So that is, you already know guys, that you have to demonstrate the toxin by ELISA. Nowadays CAR test also comes. Along with it, GDH antigen CAR test, that is also there. For the other one, which is important, glutamate dehydrogenase, and this question is coming in your exam. Okay, so remember this particular one, that Clostridium difficile associated with all this stuff, and later on the diarrhea happens, and diarrhea happens, after that the ulcer formation happens, and this ulcer formation you can observe with the help of colonoscopy and those. You can go for histopath also, and along with that you can go for toxin demonstration. And this is also important, that there should be a diarrhea more than equal to 3 loose stools per 24 hours for at least more than equal to 2 days. That comes in the criteria for the diagnosis of pseudomembranous colitis. So remember this particular statement, important. Okay. Now coming to this particular one, that is a 2-year-old who has not received vaccinations, is displaying the symptoms like runny nose, conjunctivitis, bluish white spots. Now you know what we are talking about. Near the lower molar teeth in the mouth. A day later, the rash is flat and raised red areas appeared in the face and the neck. Describe the type of the virus causing this features. So obviously guys, we are talking about measles, and measles belongs to which family? Measles belongs to Paramyxovidae. Okay, it belongs to which family? It belongs to Paramyxovidae, and this Paramyxovidae obviously is a single-stranded RNA virus which is enveloped. Okay, so all the organisms which are there in this, they will be enveloped. Okay, single-stranded RNA enveloped. So answer of ours is D. And to avoid the confusion of yours, you should know that non-enveloped DNA mnemonic is what? That is PAP, Parvoadenopapoa. And in the papova comes the human papillomavirus. And the non-enveloped RNA viruses are whom? Non-enveloped RNA viruses are PARC. And PARC is the name of all the families. And what comes in the PARC? P is Picorna, A is Astro, R is Rio, C is Calci. Okay. Picorna, Astro, Rio, Calci. These are the non-enveloped RNA viruses which you should know. Okay. And to add to your knowledge, the hepatitis A belongs to Picorna. And to the Calci, what belongs is hepatitis E. Okay. What belongs to that? That is the hepatitis E. And this question came in the exam, that hepatitis A and E are enveloped or non-enveloped. So obviously they are what? Non-enveloped, and they are RNA. But here the answer is what? Enveloped and single-stranded RNA. So like that, the question definitely will be coming in your exam. So you should have an idea that which is enveloped, which is non-enveloped. Is it fine? Now, a 45-year-old immunocompromised patient with severe dysphagia, odynophagia, retinosternal chest pain. X-ray shows the following findings, which is seen up in this particular one, in which you see the plaques and all, and punctuate lesions they are observed in that. A biopsy of the affected tissue shows fungal hyphae invading the mucosal epithelium. And you know that fungal hyphae, they are talking about which fungus? They are talking about the Candida, because esophageal candidiasis in a immunocompromised person is very much observed, and it is one of the common infections, happens to be in HIV positive. This particular features, that odynophagia and all, it ought to happen up. So which of the following can be used to distinguish different species of the causative organism? So obviously we are talking about Candida. Mainly the Candida albicans does it, but it is not so always that fellow will does. Others can also do, like Candida tropicalis, Candida guillemondi, Candida kefir. All these can also do. And this differentiation can be done with the help of which particular test, guys? Chromogar, in which the color of the species is being written in the leaflet, and you will put that particular thing, the material on the culture media, and the color will come according to that. Okay, so that is termed as chromogar stuff. The germ tube test, culture on SDA, corn meal agar, they can be used, but this is used for what? This is used for speciation. Okay, this particular procedure is used for what? Speciation, guys. So remember this particular aspect also. Now coming to this, a 34-year-old male presents with a nodular ulcerative skin lesion on his forearm. He also gives a history of thorn prick. So your life becomes easy by this. The microscopic examination of the biceps specimen reveals the following findings as shown in the image below. That is a flower-like sporulation. Which the following is the most likely causative organism responsible for this? What is the appropriate treatment for this infection? So obviously we are talking about sporotrichosis, guys, and sporotrichosis is done by what? Sporothrix kinki, and the drug of choice for that is what? Itraconazole. So this is a straightforward one, in which thorn prick history is being given off, and nodular ulcerative skin lesion it is, and this you already know that which is the variety which is most common. Lymphocutaneous spread happens, and this is the most common spread which happens here, and this is having a pattern which is termed as sporotrichoid pattern. The pattern is sporotrichoid pattern which is observed in this particular one, means linear nodules are there in a linear fashion. So that is there in this particular one. Okay. So one extra point which I would like to tell you is, like in this, what can come is the question regarding the asteroid bodies. Okay. Asteroid bodies, and they are the features of sporotrichosis. This question can definitely come. Along with that, you will have a history of rose gardeners in this particular one, and then there is a rose gardener and all that. So that is also important point to be remembered. And these asteroid bodies which are there in this, they are basically by a phenomena termed as Splendor-Hopeley phenomena, in which in the center the basophilic material is there, which is being surrounded by eosinophilic material. So that is being observed in this asteroid bodies. Okay, so these are the features one, and along with this particular thorn prick and history, They can give the history of chromoblastomycosis also, which you termed as demoticus fungus. Now, in that also thorn prick can happen, but in that they will shift towards what? Varicose lesion, that is warty lesion, and when you go for the biopsy of it, you observe medullary bodies, that is MSC, sclerotic bodies, copper penny appearance, muriform cell appearance. They are observed in what? Chromoblastomycosis. And in that only the options they came like Phyllophora and all that. And the Phyllophora and the Cladosporium, they are also termed as dark pigmented fungus, also termed as black fungus. So that also needs to be observed. Okay. So guys, you already know that I think you must have done most of them correct. And obviously, the micro comes in this fashion only. That is, if you know it, then you score up full marks. And if you don't know, then you will lose up on simple marks. So my take on this particular one is that before going to the exam, at least see up the silent features of all the things at one go. Okay. And keep it before 2-3 days for a revision, because it's a volatile stuff. It will go away. Okay. So, but if you have these mnemonics at your end and in the last you revise them up, then definitely you can achieve up a very good rank. Because what I observed up in the last 3-4 years is that those who leave up any sort of subject like micro or forensic, anything, they tend to land up. They have a good preparation and all, but they mostly land up in which particular range? 145 and all that. So don't do this mistake. At least see up the silent features or PYQs of that same one. Don't go without seeing them up. Otherwise, you are doing a blunder. Okay. So very best of luck from my side. Thank you so much.
So hello everyone and welcome to this discussion on the subject of anatomy. I'm Dr. Ankit Khandelwal, anatomy faculty at LN. So here's the first question. The muscles of mastication, which is responsible for the depression of the mandible, is derived from. So we all know that there are various muscles of mastication. Specifically, they are saying that the muscle that is required for our depression of the mandible. So remember that for depression of the mandible, we have, out of all the masticatory muscles, mainly it is the lateral pterygoid muscle, right, which is responsible for depression of the mandible. Other masticatory muscles are also there, like the medial pterygoid, we have the temporalis, and we also have this masseter. Now they mainly help in elevation of the mandible or closing of the mouth. So this lateral pterygoid is what they are specifically asking for. Fine. But thing over here is, either it is lateral pterygoid, medial pterygoid, temporalis, masseter, be it any muscle, they are all derived from which arch? It is the first pharyngeal arch. It is the first pharyngeal arch. The first pharyngeal arch is also known as the mandibular arch. Okay. And not surprisingly, all these four muscles are supplied by the mandibular nerve. That is a branch of the trigemin, the V3 over here. So basically, they could have asked it in any way, but the answer would always have been the first pharyngeal arch, which over here we can see is our option number A. But here you might get slightly confused by looking at the other options, like first pharyngeal pouch. Remember, the pouches are on the inside and they're basically endodermal. And the first pouch basically gives rise to the structure that is the middle ear and the structure surrounding it, like the tympanic tube. The second pharyngeal arch and third pharyngeal arch, they are different arches. They derive different structures. That is the theory part. Let us see this with the help of a few images. So here is the image showing us all the different arches, and here you have this as the first arch. This blue color is the second arch, yellow is the third arch, the red is the fourth, and this green is the sixth arch. So here you can see that the first arch is the giving rise to the mandible and also these two bones of the middle ear, malleus and incus. If you look at another image, which is actually the coronal section, right? It's a coronal section. You start looking over here. These are the pharyngeal arches on the right side as well as the left side. On the inside, we have the endoderm. On the outside, the ectoderm, and the inside or between these two, we have the mesoderm or the bisca, basically the arch. Now, this whole first arch, if we say that this whole is the first arch, and the pouch is this junction between the first and the second arch on the inside. So this is the first pouch, which was basically giving rise to the middle ear. So the question was asked about this arch inside. And inside the arch, we have the nerve, the muscles, the skeletal elements, the cartilages, the vessels, all of that, right? So therefore, the muscle is coming from the arch, not the pouch. Okay, that is the point. Fair enough. Let us see the next question over here. The next question says that a 40-year-old female with breast cancer was taken for radical mastectomy, okay, and axillary lymph node dissection. A few weeks after surgery, she presents with a weakness in what? In overhead abduction and winging of the scapula. Which nerve is likely to be injured? Now, this is a very famous question, we all know about it, but the moment the winging of scapula comes, we know that they are talking of this long thoracic nerve, right? That leads to the paralysis of the serratus anterior muscle. Okay. Now, is there any connection between the long thoracic nerve and the operation done over here, the mastectomy and the axillary lymph node dissection? And the answer is yes, there is a connection. What is the connection? Connection is that this nerve is present in the axilla. So the moment the surgeon would have gone to the area of axilla, dissecting all the lymph nodes, this nerve could have been damaged. And if this nerve was damaged, this muscle would have been paralyzed. And this muscle is basically helps in the overhead abduction. Overhead abduction. So therefore, there is weakness in overhead abduction. Why weakness? Why not total lost? Because overhead abduction is not only done by the serratus anterior but also done by the trapezius. So trapezius must be working okay over here. So there is weakness. And winging of scapula is due to the paralysis of serratus anterior when the medial border of the scapula projects out. Remember that when we push against the wall, all that. Therefore, the answer over here is straightforward, the long thoracic nerve. Okay, but we should know that why this is the answer, why not others are the answer. And let's support this with the help of few images as well. Here is an image showing us few muscles, like for example, here you can see the deltoid over here. This you can see the P minor over here. Okay. But point out, this area is what we are normally seeing. This area is the axilla on the inside. And this muscle over here, it is the serratus anterior. Not shown over here, but we must be knowing that the nerve which is supplying the serratus anterior must be running like this over the serratus anterior. And that is a long thoracic nerve that could have been damaged while dissecting out the lymph nodes in this axillary region. Let us see another figure to show us all the axillary lymph nodes over here. You can see that the name itself is axillary lymph nodes, so most of the lymph nodes are there in the axilla. Like for example, we have this anterior group, we have this posterior group, we have the lateral group, the central group. All these are present in the axilla. And obviously, while doing dissection, we have to dissect them out, so that nerve could have been injured. That is the point over here. Here is the muscle and the nerve being shown separately, the long thoracic nerve. And here we have, and again, the same nerve, it's a long thoracic nerve. Because it's a long nerve. Why it's a long nerve? Because we all know that serratus anterior is attached to the upper 8 ribs. So there is a vast attachment of the serratus anterior. And therefore, to supply all the muscle fibers of serratus anterior, you need a long nerve. Therefore, the name is the long thoracic nerve. Understand that too. Okay. Other nerve that could also have been damaged is this intercostobrachial nerve, but that is actually our cutaneous nerve. So it would not lead to that weakness in abduction, overhead abduction and winging of scapula. Instead, if this intercostobrachial nerve would have been damaged, then what would have been the consequence? The consequence could have been decreased sensation or altered sensation, also known as paresthesia, which location? Around the floor of axilla, or in the upper arm region. That's it. So remember that point as well, right? Let's see the next one. 15-year-old boy presented with complaints of pain in the right iliac region. Now see guys, once the moment you see a question start diagnosing the differential diagnosis in your mind, they're saying a teenage boy having a pain in the right iliac region. Think about the right iliac region, what all structures are over there, fine. They initially started near the umbilicus, typically a picture of a case of appendicitis. The diagnosis of appendicitis was made, clinical diagnosis, right? And the patient was posted for appendectomy. During surgery, the appendix was found to be normal. Now, that's a bit surprising. But the surgeon has to look for the reason. The surgeon found, instead of appendix being inflamed, found a diverticulum, which was presented 2 inches before the ileocecal junction. So we all know that we have this ileum, the terminal part of the small intestine. We have this appendix and the cecum and the ascending colon over here, right? This is the ileum. That is the cecum below and the ascending colon above. So they found this diverticulum where around 2 inch before the ileocecal junction, somewhat around there, they found what? They found a diverticulum which was inflamed. So it was actually diverticulum inflamed, known as diverticulitis. Which of the following is false about this diverticulum? Now we all know about this, that the rule of 2 is applied over here. No, 2% population, 2 inches in length. Okay, 2 feet from the distal ileum and all that. So it is obviously they are referring to the Meckel's diverticulum. Okay, so they are asking what is false about the Meckel's diverticulum. Present in 2% of population, it is absolutely correct. The pain is referred to the umbilicus. The pain was referred, so there is no doubt. It's a false diverticulum. Now, what is false and true? If the diverticulum has all the layers, we call it as a true diverticulum. And if the layers are missing, then in that case we call it as a false diverticulum. Now, Meckel's diverticulum is actually a true diverticulum. It's not a false diverticulum. Therefore, we can easily go with this the answer. Can you name an example of a false diverticulum? Example of false diverticulum is normally considered as a diverticulum found in pharynx, known as Zenker's diverticulum. Zenker's diverticulum, right? In the Killian's dehiscence, in the inferior constrictor muscle between thyro and cricopharyngeus, we'll show in image. That is regarded as a false diverticulum, but this over here is a true diverticulum. Therefore, C would be the answer. It is due to persistent vitreointestinal tract. That is also correct statement. Right? Therefore, the answer over here is option number C, and let us see the Zenker's diverticulum. This is the Zenker's diverticulum, probably regarded as the false diverticulum from the Killian's dehiscence. Right? Fine. A known case of duodenal ulcer now presents with bleeding and hematemesis. So there was a known case of this ulcer. He now presents with hematemesis, that is vomiting of blood. Which artery labeled in the image is responsible for the bleeding in this case? Okay, so there's an image over here. Let us see this image. So first of all, let us recognize the structures. That is the liver, this is the stomach over here, that is the gallbladder over here, right? And they have labeled this question mark over here. They are asking us this vessel. Now we all can see that this is probably the aorta that is running down, and that is probably the CT, the celiac trunk over here. Now, celiac trunk mainly gives us 3 main branches. Let us see what are those 3 branches. One is the left gastric artery, one is this splenic artery going behind the stomach, and one is this hepatic artery, also known as common hepatic artery, going to the liver side, you can see. Now, from this common hepatic artery, normally it gives off this gastroduodenal artery, which divides into a pancreaticoduodenal branches. Pancreaticoduodenal branches, and this GD artery, if you look at my videos also in the abdomen, it's explained it in detail, that this GD artery, it runs actually just behind the first part of duodenum, and when the duodenal ulcer perforates, there are chances that this artery might be damaged, and that leads to severe bleeding. So that could be a cause, right? So we all know the basic anatomy. Therefore, we can go with the option number D, that is the gastroduodenal artery. If you look at the other options, the left gastric artery I already showed you, it goes in the lesser omentum and it goes to the lesser curvature of stomach, not going to the duodenum. The splenic artery runs behind the stomach and goes above the pancreas, and then finally it enters into the splenic hilum. The common hepatic artery is the beginning. This actually gives rise to the gastroduodenal artery, which is related to the first part of duodenum, and that is the one that is labeled over here, right? Okay, so let me show you an image over here. The same things. Try to identify the celiac trunk over here, and its 3 main branches: left gastric, splenic, and this your common hepatic artery. And here you have this gastroduodenal that was asked in the question. It is related to the first part of duodenum. Okay, fine. Let's see another one. Bit longer question, but don't worry. The more the length of the question, the more hints it provides us. 45-year-old diabetic and hypertensive male presents with a painful and red swollen right eye. So it's a middle-aged male with a swollen right eye. He also had a high grade of fever for the last 2 weeks. This in some history of infection probably. A day prior to the onset of symptoms, he had attempted to burst a furuncle in the outer margin of the right nostril. Now that should, the mind should run to the dangerous or the danger area of the face, which is the lower part of the nostril and the upper lip, and that area. Then what happens is, on examination, the eye movements were extremely painful. Okay, so eye movements are painful. It means that there is some involvement of the sensory nerve to the eye. Pain is from the sensory nerves. On observation, marked edema of the eyelid. So there is some venous congestion as well, right? That will lead to edema. Diagnosis of cavernous sinus thrombosis was made. So already they are telling that this diagnosis has already been made. We were also coming to that diagnosis only. It's cavernous sinus thrombosis, which does not pass through the lateral wall of cavernous sinus. This is why I always keep on telling, when you get a long question, if you want to save time, read the last couple of lines first of all. Now, instead of reading the whole 4 or 5 lines, if we could have simply read from diagnosis word to this cavernous sinus, we would have still reached the answer. Diagnosis of cavernous sinus thrombosis is made. Which of the following does not pass through the lateral wall? Now, what passes through the lateral wall are nerves number 3, 4, V1 and plus or minus V2. These are the nerves which pass through the lateral wall of cavernous sinus. So there is third nerve, there is V1, there is fourth nerve. Obviously, this is the answer. Option number D, abducens nerve. Is it not related to cavernous sinus? It is, but it goes from inside the cavernous sinus, not in the lateral wall. Therefore, our answer is obviously option number D over here. Let me show you a few images. This area is what is regarded as the dangerous area of face. And here there was a furuncle, and that the patient, this ruptured it or just squeezed it out. So the infection of the thrombus could have passed from this face part. Let me show you. It may have passed behind into the cavernous sinus. And when the thrombus would have passed, it may have blocked this cavernous sinus, leading to cavernous sinus thrombosis, right? And let me show you another image as a coronal section of the cavernous sinus. If you look at one cavernous sinus over here like this, you will realize that these all nerves are present laterally, 3, 4, V1 and V2. And where is abducens nerve? Right over here, that was asked. Okay. So remember, these 4 nerves lie on the lateral wall. Also remember, abducens nerve is very close to this internal carotid artery. That can also be asked. And here's an image with a patient of a cavernous sinus thrombosis. Very dreadful because all the veins are blocked, the nerves are being compressed, there is pain, there is ophthalmoplegia, there is pain in the movement of the eye and everything. Okay, 55-year-old female has been diagnosed with nasopharyngeal carcinoma. Remember, it's carcinoma which region? Nasopharynx. That is the area of pharynx behind the nose. That has spread to the sinus of Morgagni. What is sinus of Morgagni? It is the space between the upper margin of the muscle superior constrictor. I will show you an image as well, and the base of skull. So you have the base of skull, right? And then what happens is you have this muscle running down as a superior constrictor. Clear? And then you have this space between them, and this space is what is known as the sinus of Morgagni. So it is obviously lying where? Behind the nasopharynx, because base of skull is where? At the top. This is the muscle superior constrictor. In front of this, we will have the nasopharynx. So this tumor might have spread from here to the Morgagni space. Now they're asking you which structure will be affected due to the spread in the sinus of Morgagni. So is there any structure lying over here? The answer is yes, there are few structures lying over here. What are those structures? You have few branches of the ascending, what we can say is the ascending palatine artery. Then you have few branches from the ascending pharyngeal artery as well. You have over here the opening of the eustachian tube with the tensor or the levator palatini muscle, which are the muscles of soft palate. These are the major structures lying. I will show you an image as well. Now I'm asking you which of the following structure will be affected. So out of these 4, do we have any option? Let us see. Ascending palatine is obviously option number A should be the answer. Glossopharyngeal nerve, no, there's no. So answer is our option number A over here, ascending palatine branch of facial artery. Now let me show you few things over here. The 3 constrictors, superior, middle, inferior. The 3 constrictors, these muscles are of the topic pharynx. And the Morgagni must be lying where? The Morgagni must be lying above. So if we take a coronal section, over here, so we have the base of skull over here. On both the sides is superior, middle and inferior constrictor as well. This space is what is known as the Morgagni space. And the structures lying over here are eustachian tube, the levator, the ascending palatine artery, also the branches of ascending pharyngeal artery as well. Right? So when the tumor is coming over here, it might involve any of these structures. And therefore, that was the answer. Okay, fine. Let's see the another one. in a motorbike accident, the 45-year-old sustained injury to his right lower limb. He was then stabilized in a nearby hospital. Later, he is evaluated and a Wedling gait and a positive Trendelenburg sign was observed. Now, we all know what is Trendelenburg sign. It is when the muscles, basically the gluteus medius or gluteus minimus, are not working. So what happens that the pelvis will fall down. Pelvis will fall down on the normal side. Because these muscles are not working on the paralyzed side. But that side will not fall on walking. The pelvis will fall down on the normal side. That is, there's a right lower limb injury, the pelvis will fall down on which side? On the left side. Understand this part. Okay, pelvis will fall down on the left side. Which of the following is the most likely cause? So most likely cause is paralysis of gluteus medius minimus. But the options over here are something different. Now, which nerve supplies these two muscles? The nerve supplies these two muscles are the superior gluteal nerve. And therefore, we have option number B as the best answer over here. Injury to the superior gluteal nerve when the right lower limb was injured in a motorbike accident. Because this nerve supplies these two muscles. These muscles, if they don't work, pelvis will fall down on the normal side, on the contralateral side. And what is the function of these muscles? Think about it. They are the abductors. They are the abductors of the hip joint. Do remember it. Okay. Gluteus maximus is supplied by the inferior gluteal nerve. Remember this. Let us see a couple of images. So here we have the G-max, which covers all the deeper lying the mediuses, and deep to it will lie the minimus over here. And these are the abductors. And can you figure out what is the main function of the maximus? The main function of maximus is that it acts as the extensor of the hip joint. Right? Fair enough. Here you look at the Wedling gait. So you can see the typical picture, that is A is the person standing with both feet on the ground. This is a normal case with the right foot on the ground, the left foot is above. So here all the muscles are working fine. If we try to show the area of the gluteus medius, that is normal over here. So it lifts the pelvis on the opposite side. But here you have this Trendelenburg sign over here. So what is happening? This muscle over here is not working, or it is paralyzed. It is not working, or it is paralyzed. So what is happening when the right foot is on the ground? The left pelvis will tilt down. What I said, the normal side pelvis will tilt down. Okay, fair enough. Next question: the 28-year-old is brought to the hospital with a severe stab on the medial side of the distal forearm. So you have this as the arm, right? Then you have the elbow region over here, then you have this forearm, and you have this fingers over here. So injury was where? In the distal forearm. That too on the medial side, right? So injury was to the medial side of forearm, right over here. Then on examination it was found that he cannot grip a piece of paper among his fingers. He can't grip a piece of paper among his fingers. That means that the adduction of the fingers was weak. Which causes adduction of the fingers? Remember PAD. What is PAD? P for palmar interossei, AD for adduction. It means that the palmar interossei, they are not working. And has lost sensation on the medial side of his hand. Now this area on the medial side of hand, the sensory supply comes from a nerve that is known as the ulnar nerve. And the palmar interossei is supplied by the ulnar nerve. And this ulnar nerve present where? On the medial side of the distal forearm. I'll show you where. All of this tells us which nerve is likely to be injured. It's obviously the ulnar nerve. Now let us see a couple of images over here. Here is a anterior view of the wrist over here with the medial side over here, the lateral side over here. Try to see the ulnar nerve over here. Here you have the ulnar nerve, right? And here you have the median nerve, and these are the two main nerves. The radial nerve actually runs on the posterior aspect, right? And it supplies the skin over here, and the other branch goes in the extensor of forearm, that is the posterior interosseous nerve. So that radial nerve you don't see on the lateral side of forearm, on the wrist, right? So this is ulnar nerve, and injury was obviously located at this location. Another image will show us about the ulnar nerve in detail, and it shows us the location over here where the site of injury was over here, and you can see it is supplying the palmar interossei as well, right? The palmar even dorsal interossei. Remember, ulnar nerve is known as a musician nerve because it supplies the maximum muscles of the hand, which includes the palmar interossei. Okay, so remember these things about the learner. Next question, during our examination, you were asked about the triangles of the neck. So that is a good question. Which are the contents of carotid triangle? A carotid triangle is where you feel the carotid pulse, because there you have the carotid sheath in under which lies the carotid artery as well as the internal jugular vein with the vagus nerve lying in between. Major content of carotid sheath is this. But the carotid triangle, you have other things as well. Let us see. Is common carotid artery over there? Yes. Is this vein over there? Yes. Transcervical artery. Actually, this artery is actually a branch from the thyrocervical trunk of the subclavian artery. So it is lying a bit more, you can say, on the posterior side. You can say it's going towards the posterior triangle side behind the sternocleidomastoid. So this probably should not. External jugular vein lies superficial to the sternocleidomastoid. So this again will not lie inside the carotid triangle per se. So obviously option number 1 and 2 are the best bet. Here we have option number C over here as 1 and 2. Let us see with the help of image. This is the triangle they are asking us actually, and that is this carotid triangle. If I may show you like this, this is the triangle they are asking. The EJV, the external jugular vein, actually it runs over here like this, and then it ends below in the subclavian vein. That's the location of the external jugular vein, while the internal jugular vein lies over here with the artery lying medial to it and with the nerve lying in between, and the other structures are also there. Let me show you another image. This image shows us all the contents of what we normally call it as the carotid triangle. The major things you can see, if I may start to highlight, the internal jugular vein, right? And then you have the internal carotid with the common carotid and the external carotid, right? And between these two, you have the vagus nerve, right? Apart from these, you also get some of the branches of external carotid, like the lingual artery, the facial artery, behind goes the occipital artery. Okay, and also as you have the lingual artery, always remember lingual artery, the hypoglossal nerve, it goes around the lingual artery with the loop of the lingual artery. So this hypoglossal nerve, also do remember, it also lies in this area. Okay, and also the first branch of the ECA, the superior thyroid artery. So you have the ECA, you have its branches as well, the superior thyroid, the lingual, the facial, the occipital, these are lying in the carotid triangle. Okay, with the hypoglossal nerve over here as well, remember this star mark. Fair enough, right? So it was 1 and 2 only, not the transcervical artery, not the external jugular vein. Also do remember that if you see that internal jugular vein is over here, you might think EJV will drain over here, but remember EJV does not drain into internal jugular vein. EJV drains where? That's a good question. It drains into the subclavian vein. It drains into the subclavian vein. That is a separate good question in itself. Fair enough. Which of the following is or are incorrectly matched? So what is wrong over here? Let us see one by one. Sternoclavicular joint, plain sinus. Well, the sternoclavicular joint over here on the middle side of the clavicle is a saddle variety. It's a multi-axial joint. So this statement is wrong. Wrist and knuckle. Now wrist and knuckle. Wrist joint is which variety of joint? Wrist joint is basically our ellipsoid variety. Ellipsoid variety. And knuckles over here, metacarpophalangeal, they are also type of ellipsoid, or we can also call them as condylar joint. Hinge, no, they are not hinge. Hinge, we have what? Hinge, we have the elbows, the ankle, those are hinge. The plane over here are like intercarpal joints, those are the plane joints. Middle tibiofibular syndesmosis, yes, that is absolutely correct. The middle tibiofibular, that is what they are referring to, is the interosseous membrane. Okay, so that is in fact syndesmosis, right? Calcaneocuboid on the the tarsals, that is a variety of saddle variety, and yes, it is saddle. Yes, it is saddle. Elbow and ankle, as I told you, they are hinge variety, not ellipsoid. So again, this is wrong. So what is correct? 3 and 4 are correct. Therefore, 3 and 4 are correct. No, we have to identify the incorrect ones. 1, 2, and 5. So 1, 2, and 5, option number D. Identify the incorrect ones. So 1, 2, and 5 are the incorrect ones. Okay. So remember, the topic from here is general anatomy joints topic. Very important. Next question from the neuro, again long question. 40-year-old male presented to the emergency after trauma. Patient is conscious. After stabilizing the vitals, you perform a complete examination. Observe that he is unable to localize pain and temperature on the left lower limb, and there are no pressure proprioception on the right lower limb. Image given below shows a cut section of spinal cord representing various sensory tracts over here. Which of the following marked areas responsible for his symptoms on the left side of the body? So what happened to his left side? His left side had unable to localize pain temperature. So which pathway carries pain temperature? It's the spinothalamic tract. It is the spinothalamic tract which carries the pain temperature. So in this section, we will identify the spinothalamic tract. So if you look at the section, you know that this is the anterior side, that's the posterior side. Why? Because you can see the ventral gray horn over here and the dorsal root ganglion also over here, like that. So A and B would be what? A and B over here would be the dorsal column, which you have the fasciculus gracilis and fasciculus cuneatus. They carry the pressure and vibration, all that. C over here is not a sensory tract, it's a corticospinal tract. That's a descending motor tract, corticospinal tract. So therefore the answer is option number D over here. This over here, this is the spinothalamic tract. So answer is option number D. But don't go with this D option. Look over the trick over here is this is the answer D. Answer is option number B. Whose answer is option number D? That was a bit tricky over here. Don't rush to option number D. Go to option number B. Was that? Then that you have the answer option number D. Let us decode with this an image over here as well. This is the spinothalamic tract that was asked. That is fasciculus gracilis cuneatus, the dorsal column, and that is a motor tract over here. Motor tract. Okay, a 31-year-old lady visits her gynae with complaints of recurring UTI and vaginal pain. The patient feels a burning sensation during urination, an increase in the frequency of urination. A pelvic examination is conducted and a vaginal sample is taken for further assessment. What is normal lining epithelium? That is the whole question. Question is hardly of 6-7 words. What is the normal lining epithelium of vagina? Now, as vagina opens to the outside, the lining over here will be obviously be stratified squamous. But as it has a mucosa also, it will be non-keratinized, else it would have been keratinized like the skin. It's going to be a non-keratinized stratified squamous epithelium, which I guess we have the option number, last option over here would fulfill. Remember, the keratinized is where you have the dry area like the skin. And non-keratinized are normally where you have the mucosa, the wet areas. Those are non-keratinized. And as those areas in the body which are opening up to the outside, like the mouth over here, oral cavity, right? All these areas, the beginning will have the stratified squamous, right? So the answer is our option number D over here. Okay. So that's all. I hope you enjoyed. Thank you.
Hello, my dear friends. So let's have the discussion of biochemistry from your exams. Question number 1. Which of the following statement regarding the apolipoproteins is incorrect? So guys, the question is on apolipoproteins. So ApoA is found in HDL, yes, and activates the LCAT enzyme, correct. And LCAT enzyme deficiency causes fish eye disease. ApoB48 acts as structural protein for chylomicrons, correct, and it is made by RNA editing. Okay, RNA editing process. ApoC2 acts as a ligand for LDL receptor, no, right. So that is our answer actually, right. So this is our answer. So guys, which act as ApoB100? ApoB100 is a ligand for LDL receptors. ApoD is considered as a marker of androgen insensitivity syndrome, yes. So guys, these are the few, apoproteins. Next question. 5-month-old baby presented to the emergency with the complaints of progressive loss of vision and hearing. So guys, this is a long question and you might have read that in your exams, and the question basically says that very long chain fatty acids are accumulated in the tissues. Fine, and they're asking that what is the diagnosis. So guys, Zellweger syndrome. What are the things to remember in Zellweger syndrome? There is a deficient of peroxisome, no peroxisomes. You can say no peroxisomes are present. And because of this, very long chain fatty acid accumulates. So look for the hints only and nothing else, right? Infantile refsum disease is a disease which is due to accumulation of phytanic acid. That is a branch chain fatty acid. Okay, so remember these two lipid disorders. Fine guys. Now identify the false statement regarding the deficient vitamin. So guys, this is a case of which is vitamin A deficiency, but vitamin A deficiency should not be given in pregnancy. Why? Because guys, this is a teratogen, right? You all know that is a teratogen. Clear? It regulates the gene expression, especially in the embryos, right? Embryos. Name of the genes are known as homeobox, written as HOX, homeobox genes. Okay, ETO cells are found in the liver, which stores the vitamin A. Again, a MCQ separately asked in exams. Fine. Guys, vitamins are very important. Miss nothing in vitamins. Everything in the vitamin should be known. Their deficiency, their toxicity, and there is like how they are processed or how they are utilized in our body. Everything. 30-year-old farmer came with accidental herbal poisoning. So guys, the shown site is this, that is ATP ADP translocase. So guys, what is the inhibitor of translocase? Just remember this way, it has a TRA in the name. If I write like this, atra, right? Atractyloside, right? Atractyloside. So translocase is being inhibited. So option B is our correct answer. Fine. Oligomycin inhibits the ATP synthase, which is not shown here. Right guys, hydrogen sulfide inhibits the complex 4 of ETC. All of the following enzymes are dependent on copper except, so guys, copper enzymes except the A, that is enzyme of selenium. So guys, enzymes containing selenium is a PYQ, and selenium is found in glutathione peroxidase, not reductase. Okay, don't forget that, not the reductase. Glutathione reductase is riboflavin dependent, and that's a test for riboflavin also. So glutathione peroxidase. Then we have one more name that is called as D-iodinase, right? D-iodinase. And the number 3 is called as the thioredoxin reductase. Okay, thioredoxin reductase. So guys, these are the names that we should remember. Okay, so all of the following enzymes are dependent on copper except. Rest of the enzymes, see, superoxide dismutase, yes. Cytochrome oxidase complex 4 of ETC, yes. Tyrosinase makes a melanin, yes. Tyrosinase is deficient in albinism. See guys, this question you might have read, and in this question what they are saying is that there are 2 codons and both are coding for leucine only. So that is a case of, guys, redundancy or degeneracy of the codons. That is called as redundancy or degeneracy of the codons. Okay, fine. So guys, redundancy or degeneracy means for one amino acid we have multiple codons. Like for example, 64 codons are present for 20 amino acid. 64 codons, only for 20 amino acids. So one has multiple. That is called as degeneracy of the codons. Correct? A patient came to the emergency department with hypoglycemia, right? Has massive hepatomegaly and growth retardation. Lactate was high. TG was high, uric acid was high, USG shows hepatic adenoma. Which enzyme is deficient? So as looking at the 4 options, all the 4 options are of glycogen storage. So the question becomes easy, right? Because all the options are of glycogen storage disorders. So in this case, because there is a massive hepatomegaly with hypoglycemia and there is also increased uric acid levels, right? Okay. Uric acid levels. See, I can explain this. First of all, this is a case of von Gerke's disease. So, in the von Gerke's disease, when the glucose 6-phosphatase is absent, there is increase in glucose 6-phosphate. So, guys, glucose 6-phosphatase, when it is absent, fine, then what will happen? This glucose 6-phosphatase will be common enzyme of gluconeogenesis and glycogenolysis. So there will be severe hypoglycemia in the fasting state, right? That we all know. And high glucose 6-phosphate, guys, enters the HMP shunt, and HMP shunt makes nucleotides, right? Ultimately means from the sugar. First it makes sugar, pentose sugar. Then nucleotides, when they are degraded, they make uric acid. So that's why uric acid levels are also high. And guys, G6P itself stimulates the glycogen synthase, right? So what is the rate limiting enzyme of glycogen synthesis? Glycogen synthase will be activated, and this causes massive accumulation of glycogen or massive hepatomegaly, right? So massive hepatomegaly will be there. Am I clear? And guys, remember, von Gerke's disease doesn't affect the muscles, because glucose 6-phosphatase is naturally absent from the muscles. Correct? So easy one. Why it is easy one? I'm saying because all the 4 options were given and they were all from glycogen storage disorder. This may become difficult if the different options are given. So in that case, guys, remember that hypoglycemia and enlarged liver is characteristic of this case, that is von Gerke's disease. Hypoglycemia and enlarged liver. right? So this we can remember. Identify the compounds A and B in the images. So guys, again a very simple question. When you see cyclic AMP, so there are only two possibilities, epinephrine and the glucagon, right? So there is no option of epinephrine. So A is for sure glucagon. So B becomes insulin. Why? Because insulin causes dephosphorylation of the enzymes by activating protein phosphatase. So in this case, phosphatase is being activated by the, as you can see here, B activates the protein phosphatase. Fine guys. So remember always that glucagon causes phosphorylation and insulin causes dephosphorylation, right? Okay. The newborn baby is brought to the pediatrics OPD with vomiting after each breastfeeding. On examination, jaundice is present and the liver is found to be enlarged, and the following finding in the eyes observed. So which of the following is incorrect? So guys, this is a case of classical galactosemia because you can see the oil drop cataract, and vomiting after each breastfeed is also saying, the same thing. Fine. So enzyme deficient is Galliput, correct. Above notice finding in the accumulation of dulcitol, yes, that is galactitol's other name. The baby can be advised on soya milk, yes, soya milk is harmless in this baby. And the baby has preserved intelligence. No guys, this baby will later present with the mental retardation. Okay, mental retardation is present. So that is our answer, option number D. Guys, what are the other classical features? The jaundice and hepatomegaly, then E. coli sepsis and ovarian failure. Don't forget the ovarian failure, premature ovarian failure, jaundice and hepatomegaly, right? And mental retardation. So there are a few features that you should know apart from the general like this oil drop cataract, we all know, correct? Okay. Which of the following pathways is incorrectly matched with the location where they occur and the rate limiting enzyme? See guys, the answer of this question is bile acid synthesis, right? Because the enzyme is, the rate limiting enzyme is 7-alpha hydroxylase. So remember this name, this is the rate limiting enzyme. From the cholesterol, we can make the bile acid. Fatty acid synthesis, correct. Acetyl-CoA carboxylase. Glycogen phosphorylase, correct. HMP shunt glucose 6-phosphate dehydrogenase, correct. So guys, always remember the rate limiting enzyme and their regulation. Sites can also be important, especially guys, 3 sites. I told you the mnemonic also HUG. Heme synthesis, urea cycle and the gluconeogenesis. They occurs in both mitochondria plus cytoplasm, right? Okay. And then there are few which occurs in other places like peroxisome, like the omega oxidation occurs in smooth endoplasmic reticulum, and very long chain fatty acid oxidation occurs in peroxisomes. Okay. Which of the following statement is incorrect about isoenzymes? See guys, there is nothing incorrect here because they catalyze the same reaction and they are physically distinct forms of enzymes. They have different kinetics and they may have different primary and quaternary structures. Not always, but yes, they may have different primary and quaternary. So basically all of them are correct. Okay, all of them are correct options. 2-month-old infant was brought to the pediatric OPD with the complaints of abdominal distension. On inspection, jaundice was present and on palpation, hepatomegaly was present. Urine order was typically of boiled cabbage. So guys, I believe urine orders are always important, like in PKU, musty order. In tyrosinemia, right, this is type 1 tyrosinemia, there is a order that is boiled cabbage. Then maple syrup urine disease has a burnt sugar order, right? And cystinuria may have rotten egg order. So orders are always important. Fine. So orders of PKU you must remember. Then tyrosinemia, this is the case. Then maple syrup urine disease and cystinuria. Okay, these names at least you should know. So PKU musty, tyrosinemia boiled cabbage, MSUD burnt sugar, cystinuria boiled, not boiled, rotten egg order. It is rotten egg order. Fine guys. Okay, so that's it for now. So keep revising guys. I wish you all the best for every exam that you are going to give next time. And remember, that there are few topics which are more frequently asked in exams than the others. And like one of them is vitamins and minerals. Okay, and the other is amino acid ureas. Compared to lipids and carbohydrates, amino acids are smaller topics and very important topics in the exam. So don't miss amino acids. Very, very important. Fine, guys. Chalo, see you in the next paper, right? Alright, hi guys. So let's discuss the CBoT questions that was conducted, and the pharma question were pretty easy, I saw, and some of the questions were very straightforward. Some of the questions were clinically integrated with other subjects as well. Let's quickly see and revise and try to make sure that we do not make silly mistake in upcoming examination. Identify the incorrect statement regarding carbapenims. Now, carbapenem is which class of drug, guys? Every one of you should be aware that carbapenem, it is one of the beta-lactam, which happens to be one of the cell wall inhibitor, beta-lactams. Now, among carbapenem, the first ever carbapenem that we know is known as your imipenem. Imipenem, it was given, it was effective for most of the organism like gram-positive, gram-negative, pseudomonas. For everyone, it was effective. But the problem when it was noted that this imipenem, when it was given to the person or the patient, it was not effective. Why? Because it was getting metabolized or inactivated with the help of an enzyme coming from the kidney called renal dehydropeptidase. You see, renal dehydropeptidase is an enzyme that is causing metabolism of imipenem. So what they thought, okay, if we want imipenem to work, we should actually inhibit the metabolism of imipenem. So renal dehydropeptidase inhibitor will be added here, and renal dehydropeptidase inhibitor will be none other than your cilastatin. Cilastatin addition is required with imipenem, which happens to be a prototype carbapenem. Prototype मतलब पहला drug अपनी family का, right? But other newer carbapenem that we have, that is known as your meropenem, है ना? सबके नाम में penem आएगा, meropenem, ertapenem, all of them, they do not require cilastatin because they are intrinsically inherently resistant to renal dehydropeptidase, right? So if you are going to read option, carbapenem work by inhibiting cell wall synthesis, yes, they are cell wall synthesis inhibitor, and of course they are all sidal in nature. Enterococcus faecium is resistant to imipenem, yes. Ertapenem has a longer half-life than imipenem, yes. Imipenem is the prototype one, and the newer one are having better pharmacokinetic property. Cilastatin is administered along with meropenem. See, not with the meropenem. We do not require cilastatin. You have to find out an incorrect statement. No, cilastatin is only added with the imipenem. Let's see the second one. About a 35-year-old patient with the emergency department coming with the confusion, agitation, dry mouth, blurred vision. You guys see, whenever you see dry mouth, it's always anticholinergic side effect because salivation is cholinergic. So dry mouth will be anticholinergic. Okay. Prolonged QT interval on the ECG. Upon further investigation, it will reveal that the patient intentionally ingests a large amount of medication. Okay. Alkalinization with sodium bicarbonate was done. Okay. So sodium bicarbonate is mainly urine alkalinizer, and urinary alkalinizer is done in acidic drug poisoning. Acidic drug poisoning. In this scenario, the drug is also having anticholinergic property. So which drug is having anticholinergic property? Confusion is also there, and so confusion and this blurred vision is also one of the property of this one. Plus QT interval prolongation is also there, है. So which of the following: amphetamine, atropine, imipramine, and morphine? Do remember imipramine, it is one of the tricyclic antidepressant. They are actually associated with the QT prolongation. They are also associated with the metabolic acidosis. This metabolic acidosis, as a remember, it will be associated with the ventricular arrhythmia. They can also cause arrhythmia. Apart from that, remember, they will also be having anticholinergic property. They are also having antihistaminic property. Antihistaminic property will be causing sedation, and cholinergic property will be causing decrease in the secretion, including constipation as well. So in that condition, remember, since they are causing metabolic acidosis, we are supposed to treat them by forced alkaline diuresis. Forced alkaline diuresis can be done by sodium bicarbonate, or we can also utilize carbonic anhydrase inhibitor. The correct answer is imipramine, not morphine, because morphine के लिए we are going to utilize naloxone. All other agents are basic in nature. इनके treatment के लिए we will be mainly utilizing, or atropine के लिए let's say physostigmine. But if let's say physostigmine is not there, or there is a poisoning of amphetamine, then in that case scenario we will be doing forced acidic diuresis, because they themselves are basic one, and we need to do forced acidic diuresis using ammonium chloride or ascorbic acid. Next one. About a 48-year-old male recently been diagnosed with type 2 diabetes. Okay, so there is a diabetic history. Non-compliant towards injection. As soon as they say non-compliant towards injection, that means injectable will immediately be ruled out. है ना? Among the given choices, the only one which is injectable is exenatide. Let's read other part of the question. His medical history includes a previous episode of pancreatitis,
Again, exenatide is one of the agent that is associated with the pancreatitis. They are the GLP-1 analog. GLP-1 analog, they are associated with the pancreatitis. There is a family history of colon cancer also. Additionally, he is taking medication for heart failure. He is taking medication for heart failure as well. That means any other drug that is causing sodium and water retention should not be given. So pioglitazone, it is one of the PPAR gamma agonist. They are actually associated with sodium and water retention. They are associated with sodium and water retention because they are having sodium and water retention. What they will do, because they are having sodium and water retention, they are going to be contraindicated in a patient with the congestive heart failure. They will be contraindicated in congestive heart failure. So this patient who is already taking medication for congestive heart failure, we should not be giving pioglitazone. Now the only option that is left here is the glipizide. They are asking which of the following drug would be suitable. The only one is glipizide. Glipizide, boys and girls, remember, it is one of the second generation sulfonylurea that will be effective. Now, why are we not using teduglutide? See, teduglutide is not a drug of diabetes mainly. It is one of the GLP-2 analog. They are mainly utilized for short bowel syndrome. है ना? Short bowel syndrome. So, GLP-1 analog exenatide we are not giving because they themselves are associated with the pancreatitis and they are injectable in nature. So, if the patient is not comfortable with injectable, exenatide is not the drug that we are going to utilize. The preferred answer is glipizide. Which of the following drug used to treat glaucoma does not impact the drainage of aqueous humor? You see, drainage of aqueous humor can be actually done by two important types. One is the drug that is increasing the trabecular outflow. Another one, the one that is increasing the uveoscleral outflow. दो तरह के outflow हैं, trabecular and uveoscleral outflow. Trabecular outflow, I always used to say P, and uveoscleral I used to say PA. P stand for your pilocarpine. Then this is epinephrine. PA stand for PGF2 alpha analog and alpha 2 agonist. Alpha 2 agonist is going to be apraclonidine brimonidine. Recently we got another one that is known as your nitarsudil. Nitarsudil, it is a drug that is coming as a Rho kinase inhibitor. They are also having trabecular outflow ka increasing property. Now remember, nitarsudil is not given alone. Nitarsudil is always given in a combination with the PGF2 alpha analog. They both are given together. In combination with latanoprost, nitarsudil is given. So one will be having uveoscleral outflow property, that is latano PGF2 alpha analog like latanoprost, and other one will be having trabecular outflow. Okay. So pilocarpine definitely is M3 agonist, epinephrine, sympathomimetic, nitarsudil, Rho kinase inhibitor, PGF2 alpha analog like latanoprost, and alpha 2 agonist, that is apraclonidine or brimonidine. Now among the given choices, the only one that is standing odd man out is known as your timolol. Timolol, which type of drug is? Timolol is a non-selective beta blocker. They actually decrease the aqueous ka production. They do not hamper, they do not affect the uveoscleral or trabecular outflow. Outflow पे इसका कोई role नहीं है. तो which does not impact outflow, that is going to be timolol. They only decrease the production. The next question is, which of the following antifungal drug is correctly matched with its mechanism of action? Correctly matched with its mechanism of action. Echinocandin, beta-1,3-glucan synthase inhibitor, clotrimazole, squalene epoxidase. Squalene epoxidase inhibitor तो drug जो होता है terbinafine. Terbinafine, caspofungin, micafungin, anidulafungin, they are the one that is your cell wall inhibitor. Caspofungin, micafungin, they are the cell wall inhibitor. और ये इकाइनोकैंडिन के ग्रुप में ही आते हैं. इकाइनोकैंडिन इज अ फैमिली, उसके अंदर में कैस्फोफंगिन, मिकाफंगिन, एनिड्यूलाफंगिन आते हैं. दे आर द सेल वॉल इनहिबिटर. सेल मेम्ब्रेन इंटीग्रिटी, उसमें तो आपका आ जाएगा एम्फोटेरिसिन बी, है ना, एम्फोटेरिसिन बी. Amphotericin B cell wall. Amphotericin B does not, inhibit the cell wall. They are the one that create a pore in the cell membrane. So they interfere with the integrity of the cell membrane, create pore in the cell membrane. तो अगर आप देखते हैं तो amphotericin B is incorrect. You have to choose out a correctly matched. है ना, caspofungin, which is cell wall inhibitor, in which we are going to see that they will be targeting beta-1,3-glucan synthase, which is mainly involved in the cell wall synthesis. So caspofungin, micafungin, anidulafungin, they are coming under the family of echinocandins. Echinocandins ही होते हैं which are having the echinocandin is a class, उसके अंडर में आते हैं caspofungin, micafungin, anidulafungin. तो caspofungin cell membrane, it's wrong. They are the cell wall inhibitor. Clotrimazole, squalene epoxidase inhibitor, no. Clotrimazole they are not, है ना. Squalene epoxidase inhibitor will be terbinafine, है ना. clotrimazole, it's also one of the azole that is mainly acting by inhibiting C14 alpha demethylase. Correct answer for this one is A. About a 40-year-old male experiences significant dryness in her mouth and difficulty in swallowing. Dryness, again, there is going to be some anticholinergic. There is also difficulty in swallowing. So again, if there is no saliva, there will be difficulty in swallowing. Now let's read. There is also dry eye indicated by Sherman's test. Immunoassay reveals the presence of anti-ROS-A and LSA-B antibody. They are mainly targeting towards a very specific condition, which I'm pretty sure all of you guys are aware, that is known as your Sjogren syndrome. Sjogren syndrome. Among the available drug, which medication would be the most effective? So we will be Sjogren syndrome. There are autoantibody against the glands. So we will be using M3 agonist. Drugs like your cevimeline happens to be the drug of choice. They are the very specific M3 agonist or cholinergic drug that is acting on the glands. Additionally, we can also use drugs like your bethanicol. Can we also use pilocarpine? The answer is yes. But अगर सबसे effective की बात करेंगे, that is going to be none other than your cevimeline, है ना? Varenicline is an anti-smoking drug. A and B can be utilized, but examiner directly ये पूछ रहा है कि the most effective with the fewer side effect, that is going to be cevimeline. Its का systemic side effect relatively lesser है compared to any other. A 55-year-old female with the overactive bladder presents with an increased frequency of micturition. Which drug is the most effective for managing? See, increased frequency of micturition, that means if this is the bladder of the patient, and the bladder of the patient, let's say there is excessive muscarinic activity, so there are too much stimulation of the bladder or the detrusor muscle. Because of this, too much stimulation की वजह से there is gonna be decrease in overall urine holding capacity of the bladder. In that case scenario, examiner is asking what drug is most effective. So what we are going to utilize, M3 antagonist. Drugs like your solifenacine, oxybutynin, flavoxate, fesoterodine, tolterodine, derifenacin, right? These are the compound that we'll be utilizing as a M3 antagonist. Atropine is not utilized. They're M3 antagonists. They are not selective for the bladder. They're mainly M2 पे ज़्यादा काम करते हैं. Pyrazapine, telanzapine, they are M1 antagonists, mainly utilized in the peptic ulcer disease. Tolterodine, so tolterodine is one of them. Glycopyrrolate is mainly M3 antagonist that is acting at the bronchial smooth muscle or bronchial gland and muscle पे, है ना? तो mainly utilized in COPD, bronchial asthma, plus they are also having pre-anesthetic property. The name of the compound is glycopyrrolate. The good news about glycopyrrolate is that they are quaternary amine. The meaning of quaternary amine is that they do not cross the blood-brain barrier. Okay. What percentage of drug will be left in the body after 4 half-life if the drug is following first order? Very simple question once again. If the drug is following first order kinetic, guys, then simply remember that 50% fraction is going to be constant. So if there is a 100% drug in the very first half-life, it will become 50. Because 50% will be out. If if first order है तो 50% will be out. So it first half life में it will become half life का मतलब क्या हुआ? Time which is required to bring the plasma concentration to half. So it can be 1 hour, 2 hour, 5 or 10 hour depending on the drug, any drug, है ना? So in one half life it should be half. Next half life में it will be another half. Next half life में another half. Then 6.25. So what you saw here is in the very first half life it is becoming 50% of the previous one. Second half life में 25% of the previous initial. Third half life, fourth half life. So examiner is asking here, इसके बाद से क्या होगा? In the fifth half life there will be 3.12. It will keep on happening, है ना? So after 4 half life, how much of the drug is left in the body? So after 4 half-life, the left in the body is 6.25. Very, very easy. How much is excreted? That is somewhere around 93.75 or roughly around 95. Next question is that, which of the following drug can be safely administered in a patient with the acute gout? Now, in a patient with the acute gout, we should try to give NSAIDs. Apart from that, if NSAID is a non-responsive, in that case scenario, what do we give? We try to give steroids. Then apart from that, we will also be using colchicine. But here none of the option is available here. None of the option is available here. So what examiner is asking here is safely administered in patient with gout. That means कौन सा है जो gout को precipitate नहीं करेगा? Furosemide, hydrochlorothiazide, they both are the compound that will actually increase the uric acid level. They inhibit the uric acid excretion, therefore they will be always precipitating the acute gout. You cannot use it safely. The only one that you can use safely is going to be losartan. Now losartan पे कोई contraindication नहीं है भाई, because losartan it increases the uric acid का excretion. They increases the uric acid excretion, therefore they are safely utilized also in the gout patient में तो safely utilize कर सकते हैं. Now metoprolol does not have much action on the gout, but if you have to choose between metoprolol losartan, I would say the losartan will have advantage. मेटोप्रोलॉल का कोई ज़्यादा इफेक्ट नहीं है, बट अगेन उसका कोई एडवांटेज भी तो नहीं आ रहा है, बट अगेन लोसार्टान के साथ तो एडवांटेज भी है. तो द वन दैट कैन बी सेफली कंटिन्यूड इन द गाउट इवन इज गोइंग टू बी लोसार्टान बिकॉज दे आर द यूरिकोस्यूरिक ड्रग. A young boy with sickle cell disease has been experiencing bone pain for the past 6 months and has had multiple blood transfusion. Which of the following drug is not used in this case? Hydroxyurea, voxelotor, L-glutamine. Now, hydroxyurea undoubtedly is the drug of choice in a patient with the sickle cell anemia. Voxelotor and L-glutamine, they can also be utilized in sickle cell anemia. Guys, bebtelovimab, इसके नाम में वायरस आ रहा है, bebtelovimab, they are mainly utilized for the COVID. ये COVID के लिए है bebtelovimab. They have no utilization in sickle cell. This is one of the INI-CET question, right? Last question that we have is going to be not second last, I believe, that 29-year-old female with psychiatry department displaying symptom of hypomania. Okay, she has previous record of manic episode. Presently, she is planning to conceive. What drug due to its significant teratogenic effect on the fetus should be steered clear of her treatment plan? मतलब immediately आप उसको बंद कर दोगे, उसके treatment plan में नहीं रखोगे. That is valproate. They are highly teratogenic drug. They are mainly associated with your spina bifida. Now अब आप बोलोगे सर क्या बाकी सारे के सारे safe हैं? The answer is no drug is 100% safe in pregnancy. But if you have to continue because there is already an episode of mania and hypomania, you need to continue. So in wherever there is a pregnant patient with mania, the preferred treatment is going to be atypical antipsychotic. What is preferred? Atypical antipsychotics are going to be preferred. Atypical antipsychotics are going to be preferred, and atypical antipsychotic is going to be olanzapine. In addition to that, remember lamotrigine is also one of the anti-epileptic drug that can be used in mania, hypomania, bipolar disorder wale patient में we can utilize. Do remember lamotrigine is also having a less teratogenicity. अगर anti-epileptic की बात करें, so the least teratogenic anti-epileptic drug is going to be levetiracetam. Oxcarbazepine is something that can also, I mean, it is also having teratogenic effect, cause neurodestructive effect, but the one that should be 100% cleared up is going to be valproate. तो सबसे ज़्यादा जो बुरा है valproate है. Okay, so let's see the next question. Which of the following statement is true regarding the characteristic of elimination plotted in the orange, right? So they are asking actually about this one, which of the following is true. Now, if you are going to see zero order and first order kinetics, we know few of the important information, first order and zero order. In the zero order, what we know, in the zero order and first order, three important parameters that we always compare, that is rate of elimination, clearance and the T half-life. In the first order kinetics, the rate of elimination that we have, it is going to be directly proportional to plasma concentration. Higher the plasma concentration, higher will be the rate of elimination, right? Apart from that, if you see in here drug concentration, even if the drug concentration is high, the rate of elimination is not increasing, right? You have to find out a true statement. Clearance is going to be constant and the T half-life is also going to be constant. On the other hand, zero order mein, if you are going to see, what will happen to the rate of elimination? It is always going to be constant. No matter what is the plasma concentration, the rate of elimination is going to be constant. Drug concentration increase ho raha hai on the x-axis. Y-axis, if you see, the drug elimination is always going to be constant. There is no increment, okay? So, the rate of elimination is constant. Clearance is going to be inversely proportional. Higher the plasma concentration, lesser amount of the drug will be cleared. That is why zero order is problematic. They are the one that is having higher risk of toxicity. And what happened with the T half-life? T half-life is going to be directly proportional to plasma concentration. Higher the plasma concentration, higher will be the T half-life. At high plasma concentration, the T half-life will also be doubled. Okay. So let's read the option. Option D or D से start करते हैं. Exhibited by drugs such as phenytoin. Phenytoin is a drug that is an example of zero order kinetics. Only few drugs follow zero order kinetics. Phenytoin is one of the very good example. Phenytoin, digoxin, aminoglycoside, lithium, they are all the example of zero order kinetics, है ना? So phenytoin, digoxin that I have told you a couple of times already, aminoglycoside,
lithium, immunosuppressant, all of them are example of zero order. Majority of the drugs will be following first order kinetics. Majority drugs will be following. T half-life remains constant. Now, if you are going to see what about T half-life? T half-life is constant where? In this one, in the first order kinetics. So, this will be an example of first order kinetics. Fixed amount of drug is cleared per unit time, fixed amount of drug. So, if you are going to see in the zero order, right, amount of drug that is cleared, I mean rate of elimination is going to be constant. So, fixed amount of drug is cleared per unit time, that is again an example of zero. उसमें fraction नहीं, amount constant होता है. It shows saturable elimination. So, saturable elimination, that means again the rate of elimination is constant, that is again an example of zero. So, among the given, which of the following is true regarding the इकलौता जो first के लिए है, that is going to be T half-life remains constant, that is going to be option C. So, C is the correct answer for a question like this, right? Last question, in a clinical trial, the drug is found to have therapeutic index of 25. So, mainly I used to say therapeutic index is equal to lethal dose in 50% responder divided by the effective dose in 50% responder. The mnemonic is very, very simple. TILE, therapeutic index is equal to lethal dose divided by the effective dose. Ratio between dose producing lethality in 50% and effect in 50%, lethality in 50% and effect in 50%, that will be the correct answer here. Baki simply will be a wrong answer here. They're simply telling that whether it's a first pass metabolism, ratio between therapeutic dose and maximum lethal dose. No, therapeutic index is a dose that is producing a response in 50% and a dose that is producing lethality in 50%. इन दोनों का ratio जब लेते हैं तो lethality divided by effective dose. TILE is a very, very simple mnemonic, and mainly therapeutic index will be telling you about safety. Therapeutic index is a measure of safety. So, इसमें एक और question आता है that what will happen if there is a narrow therapeutic index. See, if there is a narrow therapeutic index, that means the safety margin is very, very narrow. One dose is causing therapeutic benefit, another dose is causing toxicity, right? So, narrow therapeutic index should not be utilized, and what we know that if you have to use, if you do not have any other option, then it always and always require therapeutic drug monitoring. TDM is going to be required, therapeutic drug monitoring is going to be required, right? So, these were all pharma question that was asked in your computer based offline test. I hope you got all correct, or if you made some silly mistake, I hope you are able to correct it, right? So, with this, I'll take a break here. I'll call it as end. Thank you very much to all of you guys, and keep revising. I'll see you in the next class.
Hello, dear friends. I am Dr. Anupama Chaudhary Devgan, your Physiology faculty, and I will be discussing the physiology questions in the CBoT. So let's have a look at the first question, a very important topic as far as your exams are concerned, and that is the oxygen hemoglobin dissociation curve. The question says all of the following cause a left shift of the curve except. So first, let's have a look at the oxygen hemoglobin dissociation curve. Now, here you have PO2 in millimeters of mercury on the x-axis, and PO2 refers to the dissolved oxygen in plasma. And on the y-axis, you have the percentage saturation of hemoglobin. Now, we know that each molecule of hemoglobin has got 4 heme. When all the 4 heme have an oxygen each, we say that hemoglobin is 100% saturated. When out of the 4, 3 have got an oxygen and 1 does not, then we say that hemoglobin is 75% saturated. So please remember, the saturation of hemoglobin depends on the dissolved oxygen. And this relationship between PO2 and saturation is given by the oxygen hemoglobin dissociation curve. Now, what is the shape of this curve? The shape of the curve, as you can see, is not linear. More the PO2, more the saturation? No, that is not the relationship. The relationship between PO2 and the saturation is a sigmoid-shaped curve. It's not a straight line. It is like the Greek letter sigma. What is the sigmoid shape of the curve due to? This is due to the phenomena of positive cooperativity. Now, what is positive cooperativity? We know that each mole of hemoglobin has got 4 heme. Binding of the first heme with oxygen increases the affinity of the second heme for oxygen, which increases the affinity of the third, which increases the affinity of the fourth. That means the heme which has the least affinity for oxygen is the first one. As oxygen binds with the heme, the affinity of the subsequent heme for oxygen increases. That is why this curve is initially flat. Then there is a sharp slope, steep slope, and then again it becomes flat. That is a sigmoid shaped curve. Now, what is P50? P50 is the partial pressure at which hemoglobin is 50% saturated. And the normal P50, in the case of the adult hemoglobin, this is about 25 to 27 millimeters of mercury, or the better answer, 26 millimeters of mercury. In terms of kilopascals, this is about 3.6 kilopascals. Now, if there is a right shift and there is a left shift of the curve, in a right shift of the curve, there will be an increase in P50. And if there is a left shift of the curve, there is a decrease in P50. Right shift, increase in P50, that means I need a higher PO2 to saturate the hemoglobin to 50%. So right shift means decreased affinity. More P50 is a decreased affinity. A left shift is a decreased P50, which in turn means more affinity. So remember, FDR favors dissociation or delivery shift to right, and FAL favors affinity or association shift to left. Now let us see what are the conditions which cause a shift to right and shift to left. Rightward shift is if there is increase in PCO2, increase in H+, decrease in pH acidosis, increase in temperature, increase in 2,3-BPG. What is 2,3-BPG? It is the byproduct of the glycolytic pathway. What causes increase in 2,3-BPG? Remember, Gita. Whenever there is excess of growth hormone, exercise, thyroid hormone, excess of thyroid hormones will favor glycolysis and therefore increase in 2,3-BPG. Anemia, high altitude, and androgens, Gita, all these conditions will increase 2,3-BPG, and increase in 2,3-BPG means a right shift of the curve. Hemoglobin S is also to the right of the normal oxygen hemoglobin dissociation curve. On the other hand, what is going to cause a left shift? Decrease in PCO2, decrease in H+, alkalosis, hypothermia, decrease in 2,3-BPG, hemoglobin F, and myoglobin. So let's see what are the questions. All of the following cause a left shift of the oxygen hemoglobin dissociation curve, except hypothermia, yes. Increase in pH or alkalosis, yes. Fetal hemoglobin, yes. Anemia causes a right shift of the curve. Why right shift? Because in anemia, there is going to be increase in 2,3-BPG, and 2,3-BPG causes a right shift. All the others are causing a left shift. Now, why does 2,3-BPG cause a right shift? That is because 2,3-BPG and oxygen, they bind on the same place on the beta chain of hemoglobin. So they compete with each other. So if there is increase in 2,3-BPG, less binding with oxygen. If there is less 2,3-BPG, more binding with oxygen. If there is an increase in 2,3-BPG in the conditions which I told you, Gita, this will cause a right shift. Right, so let's have a look at the next question. A soldier got injured in war, resulting in amputation of his left leg. He now presents to the OPD with complaints of feeling pain in the amputated foot. Now, feeling pain in the amputated foot, this is also known as the phantom limb. Now, which of the following is the best explanation for his condition? And this is what is known as the law of projection. Now, what is the law of projection? Now, following an amputation, right? Following an amputation, the femoral nerve of this patient has also been cut. So, the cut end of this femoral nerve is excited by the release of inflammatory chemicals in the stomach. These chemicals will stimulate the femoral nerve, and patient starts complaining of pain in the non-existent foot. So what is law of projection? Law of projection is that if a nerve is stimulated anywhere in its course, the sensation is felt at site of receptor. Amputation के बाद femoral nerve का section हुआ है, femoral nerve कट गया है, cut end of the femoral nerve is being stimulated by the release of inflammatory chemicals. और patient को ऐसे लगता है that the pain is arising from the non-existent foot. Right? If a nerve is stimulated anywhere in its course, the sensation arises from site of receptor. इसको कहते हैं phantom limb. Bell-Magendie law क्या है? Bell-Magendie law is very simple. It says that the dorsal horn of the spinal cord is sensory and ventral horn of the spinal cord is motor. इसका क्या मतलब हुआ कि जितना भी sensory input है into the spinal cord is from the dorsal or the posterior side of the spinal cord, और जितना भी motor output है, जितने भी motor fibers है, वो सब they will emerge from the spinal cord on the anterior side. So this is the Bell-Magendie law. Mueller's doctrine of specific nerve energies. Mueller's doctrine क्या कह रहा है? Mueller's doctrine states that this is also known as the Mueller's doctrine of specific nerve energies. ये कह रहा है that each pathway is specific for a specific sensation. मतलब कि अगर एक nerve है which is carrying touch, it is specific for touch. It will not carry pain. Understood? So each pathway is specific for a specific sensation. तो चाहे आप जो भी स्टिमुलस लेके किसी नर्व को स्टिमुलेट करें, चाहे आप इलेक्ट्रिकल स्टिमुलस लें, केमिकल स्टिमुलस लें, मैकेनिकल स्टिमुलस लें, वही सेंसेशन फील होगी जिसके लिए वो नर्व स्पेसिफिक है. That is the Mueller's doctrine of specific nerve energies. Law of projection आपको क्या कह रहा है कि जब आप किसी नर्व को स्टिमुलेट करोगे, where will you feel the sensation? At the site of receptor. ये कह रहा है कि जब भी आप किसी नर्व को स्टिमुलेट करोगे तो वही सेंसेशन फील होगी जिसके लिए वो नर्व स्पेसिफिक है. Each nerve is specific for a specific sensation. चौथा वाला देखिए. This is the Weber-Fechner law. Weber-Fechner law states that जो भी आप सेंसेशन फील करते हैं, it is proportional to not the strength of stimulus but to the log of intensity of stimulus. Right? This tells you that the sensation felt, Weber-Fechner law क्या कह रहा है कि जो भी आप sensation feel करेंगे, it is proportional to the log of intensity of stimulus. It is not proportional to the intensity but to the log of intensity. In other words, S is equal to K log of I. S is the sensation felt, K is a constant, I is the intensity of stimulus. चलिए अगला क्वेश्चन देखते हैं. Which of the following is a receptor for discriminative touch? Now what is discriminative touch? Now this is not two-point discrimination. Discriminative touch refers to fine and well localized touch. Fine and well localized touch. So let us see which is the receptor which is specific for discriminative touch, and the answer is Meissner's corpuscle. Meissner's corpuscle is most abundant on your fingertips. 60% of the sensory input from fingertips is Meissner's corpuscles. And fingertips are very sensitive to fine touch. Right? So Meissner's corpuscle is the receptor which is specific for fine, well-localized touch, or also called discriminative touch. बाकी options कौन से थे? एक था Pacinian corpuscle, which is meant for fast vibration and deep pressure. Muscle spindle is meant for muscle length, and Golgi tendon organ is meant for muscle tension. थोड़ा सा mesenus corpuscle के बारे में थोड़ी और information. Nerve fiber associated with mesenus corpuscle is a beta. Where do you find the mesenus corpuscles? They are present in the dermal pegs of glabrous skin. Firstly, what is glabrous skin? Glabrous skin is non-hairy skin, like the skin on the palms, lips, nipples, soles of feet. What are dermal pegs? The dermis projects into the epidermis like these finger-like projections. These are called dermal pegs. In dermal pegs में ये elongated encapsulated receptor है, इसका नाम है mesenus corpuscle. लेकिन कहाँ पर है ये limited? On the glabrous skin. और ये है receptor for discriminative touch, fine well localized touch, slow vibration, texture, topognosis, and also in braille. Braille is the script for the visually challenged. वो किस तरह से पढ़ते हैं? अपने fingertips को use करते हैं. They run it on a special paper जिस पे elevations and impressions बने हुए हैं. ये dermal peg में एक mesenus corpuscle. ये एक histology slide है which is showing you the mesenus corpuscle. So the answer to this question becomes pretty simple, and that is the mesenus. बाकी भी options मैं आपके साथ discuss कर चुकी हूँ. ये एक डायग्रामेटिक रिप्रेजेंटेशन है कि कौन से रिसेप्टर कहाँ पर है. ये देखिएगा ग्लैब्रस स्किन के डर्मल पेग्स में आपको मीसनस कॉर्पसल दिखाई दे रहे हैं. Pacinian corpuscle has a deep location. Pacinian corpuscle is meant for fast vibration and for deep pressure. अगला वाला देखिएगा. The Darrow-Yanet diagram for the patient has been plotted as dotted lines. Which of the following conditions does the patient most likely have? Now, Darrow-Yanet diagram के horizontally हम volume represent करते हैं और vertically osmolality. ये basically आपका total body water है. और आपको पता ही है कि 2/3 of the total body water is in the ICF and 1/3 is in the ECF. 2/3 is in the ICF and 1/3 is in the ECF. आप देख रहे हैं कि 2/3 volume मैंने ICF में दिखाया है, 1/3 in the ECF. और ऑस्मोलैलिटी जो वर्टिकली रिप्रेजेंट करते हैं, आप देखिए ECF और ICF की ऑस्मोलैलिटी नॉर्मली बराबर होती है. इट इज द सेम. सो लेट्स सी हियर what happens if there is a loss of isotonic fluid. Now, what is isotonic? Loss of whole blood, hemorrhage, or even in burns. Burns also there is loss of plasma. Now, this causes what is known as isoosmotic dehydration. इसका क्या मतलब हुआ? आप देखें ये जो रेड कलर का जो रेक्टेंगल्स है वो श्रिंक कर गए हैं. So that means there is a decrease in total body water. ICF में कोई चेंज नहीं है. ICF की वॉल्यूम और ICF की ऑस्मोलैलिटी बराबर है. This is unchanged. But as you can see, the ECF volume has decreased, but ECF osmolality unchanged. So that means what has happened over here is loss of isotonic fluids has produced an isoosmotic dehydration. Total body water decrease हुआ है, लेकिन osmolality में कोई change नहीं है, और जो ये loss है वो ECF से है. So this is isoosmotic dehydration. Dehydration मैंने क्यों बोला? क्योंकि total body water कम हो गया है, लेकिन osmolality में कोई change नहीं है. So this is isoosmotic dehydration. So loss of isotonic fluids will produce an isoosmotic dehydration. Then let's see what happens if there is loss of hypotonic fluids. Now, what are hypotonic fluids? जिसमें water ज़्यादा है और solutes कम है. जैसे जब excessive sweating होगा, या जब diarrheal fluid है, severe diarrhea है, या vomiting है, right? और in cases of diabetes insipidus, diabetes insipidus में बहुत ही dilute urine बनता है. So this now causes there is more volume loss rather than loss of solutes. So what do we find? आप देखिए जो red वाले rectangles हैं, this is showing you there is a decrease in total body water, so there is definitely a dehydration. लेकिन osmolality, अब देखिए ICF volume भी कम है, ECF की भी कम है, osmolality दोनों की बढ़ी हुई है. So this is what is known as hyperosmotic dehydration. There is more loss of water, less loss of solutes. So there is going to be what is known as a hyperosmotic dehydration. एक और देखें, supposing there is loss of hypertonic fluids, concentrated fluids, more solutes, less water. जैसे adrenal insufficiency में, Addison's में, mineralocorticoid deficiency है, more sodium loss as compared to water loss in urine. So loss of hypertonic fluids will produce a hypoosmotic dehydration. Dehydration, total body water definitely कम है. अब लेकिन दोनों साइड की osmolality reduce हो गई है because there has been more loss of solutes. So याद रखें, loss of isotonic fluids produces an isoosmotic dehydration. Loss of hypotonic fluids produces hyperosmotic dehydration, and loss of hypertonic fluids produces hypoosmotic dehydration. So let's see what are the options. Adrenal insufficiency mein, this is showing you hyperosmotic dehydration, so loss of hypotonic fluids, which is diabetes insipidus. Adrenal insufficiency mein loss of hypertonic fluids होगा तो hypoosmotic dehydration होगा. Hemorrhage or burns में isoosmotic dehydration होगा. So answer is C. Next. The normal body temperature of the body is 37 degrees Celsius. The temperature of the person increases in the hot environment to 40. Correction by the hypothalamus brought it down to 38. What is the gain of the system? Now, gain of a negative feedback system is correction over the error. यहाँ पे correction कितना हुआ है? Temperature बढ़ गया तो था to 40, it has been lowered to 38. Correction has been by 2 degrees Celsius. But there is an error. Correction was not to 37 but to 38. So there is an error of 1 degree Celsius. And so what is going to be the gain? Gain will be 2. Please remember, the formula for gain is correction over the error. Next, a patient was in treatment with botulinum toxin for achalasia cardia. The patient died of botulinum toxin overdose. Which of the following is the mechanism of action of botulinum toxin? Now, botulinum toxin will inhibit the release of acetylcholine. Right? See what happens at the neuromuscular junction? Sabse pehla point, neuromuscular junction is between the alpha motor neuron and the muscle fiber. And remember, muscle fiber is equal to muscle cell. The membrane of the muscle fiber is known as the sarcolemma, and the part of the sarcolemma which forms a junction with the alpha motor neuron, this is called the motor end plate, and motor end plate has got acetylcholine receptors. These acetylcholine receptors are nothing but ligand-gated sodium and potassium channels. Whenever the impulse reaches the end of the alpha motor neuron, present over here are voltage-gated calcium channels. The action potential reaches these voltage-gated calcium channels, which will open up, and there is an influx of calcium. And once there is an influx of calcium, there will be exocytosis of acetylcholine. अब एक्सोसाइटोसिस के लिए मुझे क्या क्या चाहिए? मुझे चाहिए कैल्शियम, मुझे चाहिए एटीपी, मुझे चाहिए डॉकिंग प्रोटीन्स. आपने देखा जैसे ही एक्शन पोटेंशियल पहुंचता है at the end of the alpha motor neuron, there is influx of calcium, ATP is already present, docking proteins are present. Now, botulinum toxin will inactivate these docking proteins. Which are the docking proteins? Syntaxin, synaptoprevin, SNAP25. And if it inactivates the docking proteins, will there be exocytosis of acetylcholine? No. So it produces a flaccid paralysis. There is going to be flaccid paralysis. ठीक है? तो ये है आपका botulinum toxin का mechanism of action. Next question, which of the following is the stimulus for an increase in aldosterone secretion? Now please remember, as far as aldosterone is concerned, aldosterone is secreted by or synthesized by the zona glomerulosa of the adrenal cortex. And this is under the renin-angiotensin aldosterone system. So anything which increases renin will increase aldosterone. जैसे हेमरेज है, हाइपोवोलीमिया है, ठीक है, डिहाइड्रेशन है, हाइपोनेट्रीमिया है। जब भी ECF की वॉल्यूम कम होगी, जो भी कारण हो, रेनिन बढ़ेगा, रेनिन विल इंक्रीज, विल एक्ट ऑन एंजियोटेंसिनोजन, एंजियोटेंसिन 1 बनता है, फिर एस एंजाइम उसको कन्वर्ट करते हैं टू एंजियोटेंसिन 2 और एंजियोटेंसिन 2 अल्डोस्टेरॉन की सिक्रीशन करेगा। सो मोस्ट इंपॉर्टेंट स्टिमुलस इज द रेनिन एंजियोटेंसिन अल्डोस्टेरॉन सिस्टम। लेकिन एक और डायरेक्ट स्टिमुलस है और वो है इंक्रीज इन प्लाज्मा पोटेशियम लेवल। अब देखिए बहुत ही इंटरेस्टिंग है, अल्डोस्टेरॉन के एक्शंस क्या है? अल्डोस्टेरॉन कलेक्टिंग डक्ट पर एक्ट करेगा, इट विल इंक्रीज सोडियम रीअब्जॉर्प्शन, ये पोटेशियम की सिक्रीशन को बढ़ाता है और एसिड की भी सिक्रीशन को बढ़ाता है। अब देखिए नॉर्मली पोटेशियम लेवल्स कितने होते हैं? नॉर्मली पोटेशियम प्लाज्मा में है 3.5 to 5 मिलीमोल्स पर लीटर। जैसे ही प्लाज्मा पोटेशियम बढ़ा, इट डायरेक्टली कॉजेज इंक्रीज इन अल्डोस्टेरॉन, और अल्डोस्टेरॉन क्या करेगा? कलेक्टिंग डक्ट पर एक्ट करके इट कॉजेज इंक्रीज सिक्रीशन ऑफ पोटेशियम एंड लॉस ऑफ पोटेशियम इन द यूरिन, ताकि प्लाज्मा का पोटेशियम लेवल वापस नॉर्मल पर आ जाए। So this is a very important direct stimulus for increase in secretion of aldosterone. याद रखिए अगर प्लाज्मा सोडियम कम है तो इट विल एक्ट वाया द रेनिन मैकेनिज्म, डायरेक्टली नहीं, डायरेक्टली केवल पोटेशियम एक्ट कर सकता है। सो माय आंसर टू दिस क्वेश्चन विल बी हाइपरकैलेमिया। फिर आते हैं अगले क्वेश्चन पर। यू आर पोस्टेड इन द पीडियाट्रिक वार्ड वेयर यू नोटिस दैट द इन्फेंट डिफिकेट्स एवरी टाइम फॉलोइंग अ मील। इंटरेस्टिंग सा रिफ्लेक्स है, इन्फेंट्स में बहुत प्रोमिनेंट है। जैसे ही फूड गोज इनटू द स्टमक, स्टमक की डिस्टेंशन हुई, देयर इज डिफिकेशन, एंड दैट इज कॉल्ड द गैस्ट्रोकोलिक रिफ्लेक्स। ये अडल्ट्स में नहीं होता है, दिस इज अबॉलिश्ड इन अडल्ट्स, थैंकफुली, राइट? दिस इज प्रोमिनेंट इन इन्फेंट्स। गैस्ट्रोआइलियल क्या है? डिस्टेंशन ऑफ स्टमक, relaxation of the ileocecal sphincter. BER क्या है? BER is the electrical activity in the smooth muscle of the GI tract. There is an oscillation of the membrane potential in the smooth muscle of GI tract, which varies between -40 and -60 millivolts. So that is the BER, basic electrical rhythm. Remember, BER is not responsible for contraction. It is just a variation of the membrane potential. Enterogastric reflex क्या है? When food is present in the duodenum. जब duodenum की distension है, तो gastric activity कम हो जाएगी, gastric motility भी कम होगी और gastric secretions भी कम होंगे। तो enterogastric, enteron में stimulus है, effect is on the stomach. So answer to this question, gastrocolic. Which of the following is a function of parathormone? Parathormone inhibits the activity of 1-alpha hydroxylase? No, in fact, it increases the activity of 1-alpha hydroxylase in the kidney, which in turn acts on 25-hydroxycholic calciferol and converts it into 1,25-dihydroxycholic calciferol, which is the active form of vitamin D. It increases phosphorus reabsorption, PCT? नहीं, ये phosphorus reabsorption को कम करता है, which is called the phosphaturic action of parathormone. It increases calcium reabsorption, DCT, which is true. It acts on its receptors on osteoclasts, increasing bone resorption. इसके receptors osteoclasts पर नहीं है, osteoblasts पर है, लेकिन it does cause a secondary increase in osteoclastic activity. So it does increase the bone resorption. Parathormone के actions को एक बार let's go through them. When does parathormone increase? If there is a decrease in the plasma calcium level or if there is an increase in the plasma phosphorus levels, they will increase the parathormone. Effect of parathormone on the kidney, it increases calcium reabsorption in the DCT, it decreases the inorganic phosphorus reabsorption in DCT, and it also increases the activity of 1-alpha hydroxylase, which helps to convert the vitamin D to its active form. और vitamin D in turn कैल्शियम और फॉस्फोरस की रीअब्जॉर्प्शन बढ़ाता है, बोथ फ्रॉम द इंटेस्टाइन एज वेल एज फ्रॉम द किडनी। एक्शंस ऑफ पैराथॉर्मोन ऑन बोन, पैराथॉर्मोन का रिसेप्टर ऑस्टियोब्लास्ट्स पर है। ऑस्टियोब्लास्ट्स पर ये एक्ट करेगा जहां से देयर इज इंक्रीज सिक्रीशन ऑफ रैंक लाइगेंड, which in turn will increase the monocyte colony stimulating factor, and which in turn will act on the osteoclastic precursor cells and increase the differentiation into mature osteoclasts. So this causes increase in the maturation of osteoclasts. साथ में ये और क्या करता है? It decreases what is known as osteoprotegerin. What is osteoprotegerin? This is a decoy receptor for rank ligand. ये एक रिसेप्टर है जो रैंक लाइगेंड को बाइंड करके उसकी एक्टिविटी कम करता है। तो अगर मैं इसी को कम कर दूंगी तो रैंक लाइगेंड एक्टिविटी बढ़ जाएगी, और जब रैंक लाइगेंड एक्टिविटी बढ़ेगी, आई विल हैव मोर डिफरेंशिएशन ऑफ द ऑस्टियोक्लास्टिक प्रिकर्सर सेल्स टू मैच्योर ऑस्टियोक्लास्ट्स, जिससे बोन रिसॉर्प्शन बढ़ेगा, which in turn will increase the plasma calcium levels. तो ये हो गए आपके पैराथॉर्मोन के एक्शंस। नेक्स्ट, which of the following hormones is responsible for milk production? अब इसको थोड़ा सा ध्यान से देखिएगा। It has said milk production because there are two important hormones, oxytocin and prolactin. लेकिन दोनों के actions अलग हैं. Both are going to be released when the baby is being fed by the mother. The release of prolactin will be from the anterior pituitary, oxytocin from the posterior pituitary. And release of both these hormones is by a positive feedback mechanism. अब oxytocin क्या करता है? Oxytocin will cause contraction of myoepithelial cells around the ducts in the mammary gland, which causes what is known as the milk letdown reflex. लेकिन prolactin क्या करता है? Prolactin will increase the milk proteins, casein and lactalbumin, जिससे मिल्क की सिंथेसिस बढ़ेगी और मिल्क की सिक्रीशन बढ़ेगी। अब क्वेश्चन को अगर आप ध्यान से देखिए, it says which is responsible for milk production, और यहां पर दोनों हैं, ऑक्सीटोसिन भी है और प्रोलैक्टिन भी है, लेकिन मेरा बेटर आंसर हियर विल बिकम प्रोलैक्टिन प्रोडक्शन, सिंथेसिस ऑफ मिल्क प्रोटीन्स को ये बढ़ा रहा है। क्वेश्चन अगर कहता मिल्क रिलीज या मिल्क लेट डाउन, देन आई वुड हैव गॉन फॉर ऑक्सीटोसिन। तो ये हो गए ऑक्सीटोसिन के बारे में। Which of the following will happen when a person suddenly stands up from a supine position? देखिए, when he suddenly stands up from the supine position, so there is an increase in the peripheral pooling of blood. जब peripheral pooling of blood बढ़ेगा, तो that means there is a decrease in venous return, there is a decrease in cardiac output, there is a fall in the mean arterial pressure. अब जब मीन आर्टीरियल प्रेशर गिरेगा तो स्ट्रेच ऑफ द वेसल वॉल कम होगी। अगर स्ट्रेच कम होगी तो फायरिंग रेट ऑफ बैरोरिसेप्टर्स भी कम होगा। बैरोरिसेप्टर्स आपके स्ट्रेच रिसेप्टर्स हैं, अगर स्ट्रेच कम है तो इनकी फायरिंग रेट कम हुई। नाउ देयर आर लेस नंबर ऑफ इंपल्सेस, देयर आर लेस नंबर ऑफ इंपल्सेस गोइंग इनटू द न्यूक्लियस ऑफ ट्रैक्टस सॉलिटेरियस, सो इनकी एक्साइटेशन कम है। न्यूक्लियस ऑफ ट्रैक्टस सॉलिटेरियस से इंपल्सेस जाते हैं टू द CVLM और द कॉर्डल वेंट्रोलैटरल मेडुला, जो एक डिप्रेसर एरिया है। इसे डिप्रेसर एरिया क्यों कहते हैं? क्योंकि ये RVLM जो प्रेशर एरिया है उसको ये इनहिबिट करता है, लेकिन अब CVLM की स्टिमुलेशन कम है तो इसकी इनहिबिटरी एक्टिविटी भी कम होगी। याद रखें, जो CVLM के न्यूरॉन्स हैं वो गाबा सिक्रीट करते हैं। गाबा एक इनहिबिटरी न्यूरोट्रांसमीटर है। अगर CVLM की स्टिमुलेशन कम है तो गाबा भी कम रिलीज होगा, कम इनहिबिशन होगी, तो सिंपैथेटिक एक्टिविटी बढ़ जाएगी। दिस इज योर पैरारिसेप्टर रिफ्लेक्स। जब सिंपैथेटिक एक्टिविटी बढ़ेगी, देयर इज एन इंक्रीज इन हार्ट रेट, देयर इज एन इंक्रीज इन द फोर्स ऑफ कॉन्ट्रैक्शन ऑफ द हार्ट, देयर इज इंक्रीज इन कार्डियक आउटपुट, देयर इज ए पेरिफेरल वेसोकंस्ट्रिक्शन, and there is now going to be an increase in the mean arterial pressure. जब भी ब्लड प्रेशर गिरता है, जब भी बैरोरिसेप्टर्स की स्टिमुलेशन कम है, जब भी इनकी फायरिंग रेट कम है, सिंपैथेटिक आउटफ्लो बढ़ जाएगा। लेकिन पैरासिम्पैथेटिक आउटफ्लो Parasympathetic outflow is controlled by what is known as the cardio-inhibitory center. जब न्यूक्लियस ऑफ ट्रैक्टस सॉलिटेरियस की स्टिमुलेशन कम है तो कार्डियो-इनहिबिटरी सेंटर व्हिच इज आल्सो द पैरासिम्पैथेटिक ये भी कम हो जाएगा. So there is decrease in the parasympathetic outflow to the heart which decreases the heart rate. कहने का मतलब क्या है? When he goes from lying to standing position, decreased venous return, decreased cardiac output, decreased blood pressure causes decreased stretch of the vessel wall, decreased firing rate of the baroreceptors, which in turn increases the sympathetic outflow but reduces the parasympathetic. जिससे heart rate बढ़ेगा, force of contraction बढ़ेगा, cardiac output बढ़ेगा, पेरिफेरल vasoconstriction होगी, mean arterial pressure बढ़ेगा. एक चीज जो आप ध्यान दीजिए, मैंने जहां थोड़ा सा गलती किया था, I said decreased parasympathetic means increased heart rate, not decrease. है ना? जब पैरासिम्पैथेटिक आउटफ्लो बढ़ता है तब हार्ट रेट कम होता है. Here parasympathetic outflow is reducing, so there will be an increase in heart rate. ठीक है? तो अब वापस आ जाए हमारे ऑप्शंस पर. When he suddenly stands up from a supine position, there will be decreased firing rate of baroreceptors, not increased. There will be increased activity of the sympathetic nervous system and a decreased activity of the parasympathetic nervous system, which will bring blood pressure back to normal and which will also cause an increase in heart rate. X descent in JVP is due to which of the following? Atrial contraction is responsible for the A wave, which occurs in the second rapid filling phase. Due to downward pull of the closed tricuspid valve into the right atrium during the ejection phase is responsible for the X descent. Due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction is responsible for the C wave. Due to venous filling of the right atrium just before opening of the tricuspid valve, it is responsible for the V wave. इसको एक बार रिवाइज कर लीजिए. Atrial contraction is responsible for the A wave, which occurs in the second rapid filling phase. C wave is in the isovolumetric contraction due to bulging of the closed tricuspid valve into the right atrium. X descent, downward pull of the closed tricuspid valve during the phase of ejection. V wave is a positive wave. This is due to venous filling of the right atrium just before opening of the tricuspid valve. और जैसे ही tricuspid valve खुलता है, blood जाएगा from the right atrium into the right ventricle, and this is responsible for the Y descent, which occurs in the first rapid filling phase. A wave, second rapid filling phase में, C wave, isovolumetric contraction में, X descent, ejection phase में, V wave is in the isovolumetric relaxation just before opening of the tricuspid valve, and Y descent is in the first rapid filling phase. Which of the following is not true about facilitated diffusion? Is it secondary active transport? Definitely not. It's a passive transport. It follows saturation kinetics? Yes. It is done with the help of a carrier protein? Yes. GLUT is an example of facilitated diffusion? Yes. ये है facilitated diffusion. It is a carrier-mediated transport. A substance which has to be transported will first bind with the carrier protein. Carrier protein का एक conformational change होगा, and then the substance is transported to the other side. और ध्यान दीजिए, जब आप facilitated diffusion के बारे में अगर इसे graphically represent करते हैं, if I have concentration gradient on the x-axis and rate of transport is on the y-axis, more the gradient, more the rate of transport, लेकिन एक point के बाद there is no further increase in the rate of transport. ऐसा क्यों? क्योंकि जो carrier protein है वो saturate कर जाता है. So there will be no further increase in the rate of transport. This is typically seen in all carrier-mediated transports. तो ये सब थे आपके questions in the CBoT. We have covered a number of important topics as far as your exams are concerned. इनको ज़रूर exam से पहले भी revise कीजिएगा. This will help you in answering during the exams as well. So thank you very much and all the best.
Hello, my dear students. Without wasting any time, let's start with pathology discussion. First MCQ. 60-year-old male, 2 weeks history of seizures. लेफ्ट आर्म पे है, प्रोग्रेसिव लेफ्ट लेग, सीजर्स आ रहे हैं. सीटी स्कैन ने लेफ्ट सेरिब्रल हेमिस्फीयर मास दिखाया. बायोप्सी ली गई और बायोप्सी भी आई एम श्योर आप सबने अप्रिशिएट कर लिया होगा. क्या दिख रहा है आपको? दो चीजें. सबसे पहले यू सी सर्पेंटाइन नेक्रोसिस. You see serpentine necrosis, and other thing you see is palisading. दिल मत तोड़ना, palisading because of necrosis है तो इसको क्या बोलोगे? True palisading या pseudo? You see pseudo palisading. तो serpentine necrosis, pseudo palisading, right? फटाफट बता दो कौन सा ट्यूमर है ये? It is glioblastoma. It is glioblastoma. क्वेश्चन पूछा गया which of the following is not true about this tumor. इतनी सारी बातें क्यों पढ़ूं सर? There is not true palisading. Serpentine necrosis की वजह से it has to be pseudo palisading. The first statement, the D statement is a wrong statement. बाकी सब yes, it is the most common primary malignant tumor in adults. Absolutely. मुझे बता सकते हो अगर यहाँ पे children लिखा होता, adult की जगह यहाँ पे अगर children लिखा होता, तो most common malignant tumor क्या होता? Medulloblastoma होता. It is medulloblastoma होता. अगर बच्चों में होता तो yes, most common site is frontal lobe. And you have a gene called as TRT mutation seen in medulloblastoma, glioblastoma. I'm sorry. So glioblastoma, there is no pseudo palisading. There is no true palisading. You see pseudo palisading. इतना भी बता दो जाते जाते. True palisading कहाँ मिलता है सर? True palisading मिलता है दो ट्यूमर्स में. एक का नाम है schwannoma और दूसरे का नाम है basal cell carcinoma. Schwannomas and basal cell carcinoma. इन दोनों में अपने को ट्रू पैलिसेडिंग मिलती है, राइट? बेसल सेल कार्सिनोमा के बारे में अपन जानते हैं. इट इज आल्सो नोन एज रोडेंट अल्सर्स. रोडेंट अल्सर्स, राइट? श्वानोमा के बारे में हम सब जानते हैं. 8th grade in love का ट्यूमर है. इसमें अपने को एंटनी ए और एंटनी बी एरियाज मिलते हैं और एंटनी एरियाज में हमें स्पेशल बॉडीज मिलती हैं जिसका नाम आप सब जानते हो, दैट इज वेरुके बॉडीज. तो ग्लायोब्लास्टोमा में देयर इज नो true palisading, you see pseudo palisading. True palisading is seen in schwannoma and basal cell carcinoma. Next, 45-year-old smoker है, lung mass है. मैं हमेशा बोलता हूँ there has to be a question from breast cancer and lung cancer. Make sure you're very good at these two topics. Lung cancer, sirtuins, breast cancer, GIST, right? तो ध्यान से बॉस. बायोप्सी ली गई. Which of the following is true about this condition? क्या कोई कैरेटिन पल्स दिख रही है? पिंक पल्स दिख रही है? नहीं, तो स्क्वेमस नहीं है. कोई ग्लैंड फॉर्मेशन दिख रही है? नहीं, तो एडिनो भी नहीं है. मुझे स्मॉल राउंड ब्लू सेल्स दिख रहे हैं. स्मॉल राउंड ब्लू सेल्स दिख रहे हैं तो एक बात तो पक्की है सर, ये स्मॉल सेल कैंसर है. जब मुझे कोई पिंक कैरेटिन पल्स ना दिखे, मुझे कोई ग्लैंड फॉर्मेशन ना दिखे, एक ही बनता है, दैट इज स्मॉल राउंड ब्लू सेल्स, स्मॉल सेल कार्सिनोमा. क्वेश्चन पूछा गया व्हिच ऑफ द फॉलोइंग इज ट्रू अबाउट दिस कंडीशन. सो आंसर आई एम श्योर आपको पता लग गया होगा, क्रोमोग्रानिन पॉजिटिव होता है. क्रोमोग्रानिन, नेप्सिन हमने पढ़ा था. नेप्सिन कहा था सर? याद करो, आईएससी को डिस्कस करें. अगर अपन आईएससी को डिस्कस करें, स्क्वैमस की मैंने आपको पी से बताई थी, P40, P63. एडिनो की अपन ने पढ़ा था टैन. एडिनो की अपन ने पढ़ा था टैन आईएससी, TTF1, यस ALKB एंड N से नैप्सिन. सो TTF और नैप्सिन एडिनो के लिए है. और स्मॉल के लिए अगर आपको याद हो हमने डिस्कस की थी आईएससी, BSC, मेन वन आर BSC. आई एम श्योर आप सबको याद है. B से आपको याद आ रहा होगा बॉम्बेसिन, S से आपको याद आ रहा होगा साइनेप्टोफाइसिन. यू हैव टू गो विद साइनेप्टोफाइसिन एंड C इज क्रोमोग्रानिन. C इज क्रोमोग्रानिन. सबकी आईएससी वेरी वेरी इंपॉर्टेंट. तो यहाँ पे स्मॉल सेल है तो क्रोमोग्रानिन विल बी द बेस्ट आंसर. P40, P63 स्क्वैमस के लिए, एडिनो की टैन आईएससी है और स्मॉल की BSC देन आईएससी फॉर स्मॉल सेल कार्सिनोमा. नेक्स्ट, पेशेंट है जिसका ब्लड प्रेशर 190 to 120 है. तो भैया बता दो बेनाइन हाइपरटेंशन है या मैलिग्नेंट हाइपरटेंशन है? सर बिल्कुल मैलिग्नेंट हाइपरटेंशन है. ऑटोप्सी ली गई जहां पे एक इमेज दी गई है. आई होप आपने अप्रिशिएट कर लिया होगा. रेड एंड ब्लैक है, बीच में ब्लैक ब्लैक कलर के स्पॉट्स दिख रहे हैं सर. दिस इज फ्ली बिटन किडनी. दिस इज फ्ली बिटन किडनी. मैलिग्नेंट हाइपरटेंशन है और फ्ली बिटन किडनी दिख रहा है. पूछा गया व्हिच ऑफ द फॉलोइंग इज नॉट ट्रू अबाउट दिस कंडीशन. हाइपरप्लास्टिक मिलता है? बिल्कुल मिलता है. अनियन स्किन अपीयरेंस मिलती है? बिल्कुल मिलती है. फिब्रिनोइड नेक्रोसिस मिलती है? बिल्कुल मिलती है. सर हाइलीन आर्टीरियोस्क्लेरोसिस तो कभी नहीं मिलती, तो दैट वुड बी द करेक्ट स्टेटमेंट। क्यों सर? क्योंकि आप सबको याद है हाइलीन आर्टीरियोस्क्लेरोसिस कौन सी हाइपरटेंशन में मिलती है? बेनाइन हाइपरटेंशन में। इट इज नॉट सीन इन मैलिग्नेंट हाइपरटेंशन। हाइलीन आर्टीरियोस्क्लेरोसिस is seen in benign hypertension. फटाफट मेरे को बता दो, when I talk about arteriosclerosis, yeah, to be precise, arteriolosclerosis yani small size vessels. There are two type of arteriolosclerosis: hyaline type and hyperplastic type. You have hyaline and hyperplastic type. Hyaline type is seen in benign hypertension. Benign hypertension also can be seen in diabetic angiopathy also, but hyaline benign hypertension. और उसमें मुझे vessels क्या मिलेंगे? Vessels में all three layers will be pink in color. बहुत इंपॉर्टेंट इमेजेस होती है when you see all the vessel walls completely pink in color. तो मुझे अगर सब कुछ पिंक 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 दिखे तब मैं जाऊंगा हाइलीन आर्टीरियोस्क्लेरोसिस में। बट हाइपरप्लास्टिक में हम सबको याद है स्पेशल अपीयरेंस मिलता है। पहले तो हाइपरप्लास्टिक कहाँ मिलता है? मैलिग्नेंट हाइपरटेंशन में। इट इज सीन इन मैलिग्नेंट हाइपरटेंशन, हाइपरप्लास्टिक वन। और उसमें क्या फीचर मिलेगा स्पेशल? यू हैव दिस कंसेंट्रिक हाइपरप्लेसिया ऑफ स्मूथ मसल सेल. You have this concentric hyperplasia of smooth muscle cells, which gives them this special onion skin appearance. Which gives them onion skin appearance. So complete pink दिख रहा है तो हाइलीन पे जाएंगे और benign hypertension पे करके आएंगे। और अगर मुझे onion skin appearance दिख रहा है, I'll go with hyperplastic arteriolosclerosis seen in malignant hypertension. I always say this: लड़की से रिश्ता benign हो यानी fresh रिश्ता हो तो तुम्हें वो कहती हाय गौरव हाय। उसी लड़की से तुम मैलिग्नेंट रिश्ता बना लो, लॉन्ग टर्म रिश्ता बना लो तो हर टाइम तुम पे हाइपर रहेगी, गुस्सा करेगी। तो बेनाइन है तो हाय है और मैलिग्नेंट है तो हाइपर लड़की है बॉस। रिश्ता हर टाइम गुस्से में रहती है, चिड़चिड़ करती है, तो हाइपर इज फॉर मैलिग्नेंट हाइपरटेंशन। नेक्स्ट अगर मैं बात करूं मैलिग्नेंट हाइपरटेंशन की, आई एम श्योर ऑल ऑफ यू रिमेंबर इसमें फिब्रिनॉइड नेक्रोसिस भी मिलती है। फिब्रिनॉइड नेक्रोसिस भी सीन इन मैलिग्नेंट हाइपरटेंशन। आई एम श्योर ऑल ऑफ यू रिमेंबर फिब्रिनॉइड नेक्रोसिस का मैंने आपको बताया था निमोनिक एमआरपी। Fibrinoid necrosis is seen in MRP condition. M for malignant hypertension, R for rheumatic heart disease, and P for pan या कोई भी any vasculitis, polyarteritis nodosa, rheumatic heart, malignant hypertension, तो वो भी बिल्कुल करेक्ट स्टेटमेंट है। अगर ग्रॉस की बात करें सर, दोनों के ग्रॉस की, जैसे यहाँ फ्ली बिटन किडनी देखा था, अगर बेनाइन नेफ्रोस्क्लेरोसिस है तो हमें मिलती है लेदर ग्रीन किडनी, लेदर ग्रीन किडनी। तो बेनाइन हाइपरटेंशन में लेदर ग्रीन किडनी है और मैलिग्नेंट में जैसे ये क्वेश्चन में आया था यू हैव फ्ली बिटन किडनीज, यू हैव फ्ली बिटन किडनीज। तो यहाँ पे फर्स्ट लास्ट स्टेटमेंट वाज अ रॉन्ग स्टेटमेंट क्योंकि हाइलीन नहीं मिलती, हेलाइन बेनाइन हाइपरटेंशन मिलती है। यहाँ पेशेंट को मैलिग्नेंट हाइपरटेंशन था, तो बेस्ट आंसर वुड बी दैट इज द रॉन्ग स्टेटमेंट। राइट, मूव टू द थर्ड क्वेश्चन गाइस। ये तो सारे एक क्वेश्चन तो रीनल डिसीज एक या दो दो तीन तीन आने हैं। 14 ईयर ओल्ड गर्ल है, कोला कलर यूरिन है, ब्लड प्रेशर हाई है, तो नेफ्राइटिक सिंड्रोम के फीचर हो गए। कोला कलर यूरिन और हाइपरटेंशन नेफ्राइटिक सिंड्रोम है। बच्चे में नेफ्राइटिक सिंड्रोम, वैसे ही आइडिया लग जाएगा। बच्चे में नेफ्राइटिक सिंड्रोम है तो पीएसजीएन होना चाहिए और बायोप्सी ली गई और इलेक्ट्रो माइक्रोस्कोपी में दी गई है। हम सब पहचान सकते हैं भैया बेसमेंट मेम्ब्रेन के ऊपर है, तो दिस इज कॉल्ड एज सब एपिथेलियल हम्प। दिस इज कॉल्ड एज सब एपिथेलियल हम्प। हमें अच्छे से पता है अगर बेसमेंट मेम्ब्रेन के ऊपर दिखेगा तो सब एपिथेलियल हम्प। अब आगे बताने की जरूरत नहीं है, बच्चा है, नेफ्राइटिक सिंड्रोम है, सब एपिथेलियल हम्प है, तो पीएसजीएन इज द बेस्ट आंसर। करमजलों ने पीएसजीएन ऑप्शन में नहीं दिया, पीएसजीएन का दूसरा नाम दे दिया, दैट इज एक्यूट प्रोलिफरेटिव ग्लोमेरुलोनेफ्राइटिस। acute proliferative glomerulonephritis, that is the best answer for this question, right? Minimal chain disease में nephrotic syndrome होता है, इसलिए that cannot be the answer। RPGN होता तो दो चीजें होती, मैंने आपको पढ़ाया था, R से RPGN, R से rupture of basement membrane दिखना चाहिए और इसमें लाइट माइक्रोस्कोपी पे क्रिसेंट्स मिलते हैं सर। अगर RPGN होता तो rupture of basement membrane दिखता, क्रिसेंट दिखता। membranous nephropathy भी again it is a feature of nephrotic syndrome, जिसमें अगर आपको याद हो स्पाइक एंड डोम अपीयरेंस मिलता है। स्पाइक एंड डोम अपीयरेंस इज सीन इन मेम्ब्रेनस नेफ्रोपैथी। So out of this, the best answer is PSGN का other name, that is acute proliferative glomerulonephritis. Now, which one of the following is the correct statement regarding aging? Right, correct statement regarding aging. The answer is the D1. Right, the D1. Right, यहाँ पे कुछ पॉइंट है, डिस्कस कर लेते हैं सर। व्हेन आई टॉक अबाउट एजिंग, मैंने आपको बता रखा है सर, हम बूढ़े हो रहे हैं। जब हम बूढ़े हो जाते हैं, हमारे दांत खराब हो जाते हैं, तो हमें RCT की जरूरत पड़ती है, रूट कैनाल ट्रांसप्लांट। तो आपको याद होगा एजिंग में ये 3 चीजें कम हो जाती हैं, RCT वाली चीजें। R से आपको याद होगा रिपेयर सिस्टम कम हो जाएगा, रिपेयर सिस्टम कम हो जाएगा। C से चैपरॉन्स का लेवल कम होगा सर, चैपरॉन्स का। और T से टीलोमियर्स की लेंथ कम होगी, टीलोमियर्स की लेंथ कम हो जाएगी। अब आपको मुझे बताना है, अगर रिपेयर सिस्टम काम नहीं करेगा तो फ्री रेडिकल्स बढ़ेंगे, फ्री रेडिकल्स बढ़ेंगे। एंड आई एम श्योर यू ऑल रिमेंबर दिस इज द मोस्ट एक्सेप्टेड थ्योरी फॉर एजिंग, मोस्ट एक्सेप्टेड थ्योरी फॉर एजिंग इज इंक्रीज फ्री रेडिकल्स। फर्स्ट MCQ, हम बूढ़े हो रहे हैं तो फ्री रेडिकल्स का नंबर बढ़ रहा है। चैपरॉन्स का फंक्शन आप सबको याद है, ऑल्सो नोन एज हीट शॉक प्रोटीन्स। इनका काम है प्रोटीन की फोल्डिंग करना, इट कॉज प्रॉपर फोल्डिंग ऑफ प्रोटीन। चैपरॉन में चाप है और चाप हमेशा प्रॉपर्ली फोल्डेड होकर आती है, चैपरॉन इज प्रोटीन फोल्डिंग। और टीलोमियर्स की लेंथ, आई एम श्योर आपको पता है टीलोमियर्स का काम क्या होता है, टू प्रिवेंट फ्यूजन ऑफ एंड्स ऑफ क्रोमोसोम्स। जैसे जैसे एज बढ़ रही है टीलोमियर्स की लेंथ कम हो रही है, टीलोमियर्स की लेंथ कम होगी तो क्या होगा बॉस, टीलोमियर्स की लेंथ कम होगी तो क्रोमोसोम फ्यूज हो जाएंगे और उसके बाद कभी सेल डिवीजन नहीं होगी। और यही साहब हमें पहली बार बताया था हेफ्लिक साहब ने, हेफ्लिक साहब ने हमें कहा था सर, हेफ्लिक लिमिट दे दी गई थी हमको कि हेफ्लिक साहब था एक नॉर्मल सेल्स अपनी लाइफ में सिर्फ 50 to 70 टाइम्स ही डिवाइड कर सकता है सर, 50 to 70 टाइम्स डिवाइड कर सकता है, क्योंकि उसके बाद उसका टीलोमियर्स खत्म हो जाएगा, क्रोमोसोम फ्यूज करेंगे, फिर कभी डिवाइड नहीं हो पाएगा। पहला वेरी पॉपुलर MCQ, हेफ्लिक लिमिट 50 to 70 टाइम्स। फिर क्वेश्चन आता है सर, कुछ सेल्स हेफ्लिक से आपको बोलते हैं सर आप होते कौन हो हमें हमारी औकात बताने वाले, आप कौन हो तो बताने वाले कि तू FMG तेरे बस की बात नहीं है, मैं अपनी औकात में अपनी किस्मत मैं खुद लिखूंगा। क्योंकि उनके पास वो कॉन्फिडेंस होना चाहिए, और कॉन्फिडेंस कौन देता है, टीलोमरेज देता है। तो टीलोमरेज वाले सेल्स हेफ्लिक्स आपकी बात को नहीं मानते, वो सारी जिंदगी डिवाइड कर सकते हैं। अब याद करके बता दो टीलोमरेज एक्टिविटी किसके पास है, यस याद करो, तुम्हें सारी जिंदगी GST पे करना पड़ता है, GST। तो GST वाले सेल्स के पास टीलोमरेज एक्टिविटी है, G से जर्म सेल्स। जैसे तुम्हें मोदी जी को सारी जिंदगी GST देना है कमा कमा के, टीलोमरेज GST वाले सेल्स के पास टीलोमरेज है तो वो सारी जिंदगी डिवाइड कर सकते हैं, स्टेम सेल्स एंड ट्यूमर सेल्स। तो जर्म सेल्स, स्टेम सेल्स, ट्यूमर सेल्स, ये है टेलोमरेज की एक्टिविटी। मैक्सिमम इज सीन इन जर्म सेल, मैक्सिमम टेलोमरेज एक्टिविटी सीन इन जर्म सेल्स। अब टेलोमरेज पे क्वेश्चन था, तो टेलोमरेज आर RNA डिपेंडेंट DNA पॉलीमरेज, दे आर RNA डिपेंडेंट DNA पॉलीमरेज, जो कि ऑप्शन में गलत था, क्योंकि इस ऑप्शन में अगर मैं जाऊं तो सर 50 to 60 20 नहीं सर 50 to 70 होता है, तो ये भी गलत हो गया। टेलोमरेज DNA डिपेंडेंट RNA पॉलीमरेज नहीं है, टेलोमरेज आर RNA डिपेंडेंट DNA पॉलीमरेज। So please remember they are RNA डिपेंडेंट DNA पॉलीमरेज। तो लास्ट में अब एजिंग की बात चल रही है तो कंप्लीट करते हैं। एजिंग को कम करने के लिए द बेस्ट मेथड इज टू डिक्रीज एजिंग, the best method is, yes, I'm sure all of you know, calorie restriction. The best method is calorie restriction. The best method is calorie restriction by 30%. करोगे तो एजिंग के चांसेस बढ़ जाएंगे। क्यों सर? 30% कैलोरी रिस्ट्रिक्शन से क्या होगा, सर्टुइंस बढ़ेगा। और सर्टुइंस का फंक्शन बहुत पॉपुलर है सर। सर्टुइंस का फंक्शन क्या है, मैंने कहा था आपको, सर्टुइंस में सर है, सर 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 यानी मैं, और सर्टुइंस फंक्शन है सर से मांग लो माफी। सर्टुइन में सर छिपा है, सर से मांग लो माफी। सर ये मेटाबॉलिज्म को कम करता है, ये एजिंग को, अपोप्टोसिस को कम करता है, ये फ्री रेडिकल्स को कम करता है, और आई से ये इंक्रीज करता है, किसको इंक्रीज करता है, इंसुलिन सेंसिटिविटी को इंक्रीज करता है। इट इंक्रीज इंसुलिन सेंसिटिविटी, तो सब कुछ कम कर रहा है बट इंसुलिन सेंसिटिविटी को बढ़ा रहा है। सो सर से मांग लो माफी। सो दैट इज द क्वेश्चन। तो इसलिए आपको पता है सर इंसुलिन सेंसिटिविटी को बढ़ाता है, इसलिए हम इसको डायबिटीज मेलाइटस में यूज करते हैं। इट यूज इन द ट्रीटमेंट ऑफ डायबिटीज मेलाइटस, राइट। तो अब इस क्वेश्चन वापस आ जाते हैं। सर टू डिक्रीज इंसुलिन सेंसिटिविटी, नो इट इंक्रीज इंसुलिन सेंसिटिविटी। तो क्वेश्चन क्या हुआ, सर टू एनहांस बीटा सेल इंसुलिन इन सिक्रीशन and is implicated in diabetes. So that is the perfect statement, right? Next, match the following ISC markers with malignancy. फटाफट बता दो सर। CD19, yes sir, Ewing sarcoma. HMB45, melanoma. Desmin, rhabdomyosarcoma. Arginase, हेपेटोसेल्युलर कार्सिनोमा। ISC है, डायरेक्ट क्वेश्चन है, तो क्या आंसर हुआ सर? A3 है, B2 है, C4 है, D1 है। सो दिस इज परफेक्ट ISC। तो आपको पता होनी चाहिए सर। फटाफट मैं याद कर लेता हूं सर। सारी SC की बात करें, कोई एपिथेलियल ओरिजिन है, कोई भी कैंसर एपिथेलियल ओरिजिन से अराइज हुआ है यानी कार्सिनोमा है, दे आर पॉजिटिव फॉर साइटोकैरेटिन। हम यहाँ पे ISC को डिस्कस कर रहे हैं सर। साइटोकैरेटिन, साइटोकैरेटिन अगर मीजनकाइमल ओरिजिन है, मीजनकाइमल ओरिजिन है तो वाइमेंटिन होगा, तो वाइमेंटिन होगा। अगर कैंसर लिम्फॉइड ओरिजिन का है, ISC आई एम श्योर आपको पता है, ISC इज यूज्ड टू कंफर्म द ओरिजिन ऑफ द ट्यूमर सेल्स। लिम्फॉइड CD45 LCA, आप सबको पता है CD45 को अपन LCA बोलते हैं, राइट। फिर जो मेनली पूछा जाता है मेलेनोमा, तो फेवरेट है सर उनका। मेलेनोमा भी हमने पढ़ा है, HMB45, मेलाने एसेंडेंट नॉन स्पेसिफिक नहीं जाते, मेलानोमा HMB45। इविंग्स की बात करेंगे, इविंग सार्कोमा CD99। अगर आपको याद हो, CD99 इज आल्सो सीन इन ग्रैन्युलोसा सेल ट्यूमर ओवरी। इविंग सार्कोमा, ग्रैन्युलोसा सेल ट्यूमर, बोथ आर CD99 पॉजिटिव। और जो उनका फेवरेट है रैप्डोमायोसार्कोमा, मसल ओरिजिन डेस्मिन, इसको मत भूलना बॉस। FMG में इविंग, रैप्डोमायोसार्कोमा, मेलेनोमा ऑल हैव बीन आस्क्ड, सो रिमेंबर। So this important ISC है। मेलेनोमा HMB45 है, इविंग्स CD99 है, ग्रैन्युलोसा सेल ट्यूमर भी CD99 है, एंड rhabdomyosarcoma is for this। नेक्स्ट क्वेश्चन पे आते हैं। 42 ईयर ओल्ड मेल, डिस्निया, पोस्टीरियर मीडियस्टल मास के साथ आया है, बायोप्सी ली गई, यू हैव अ मल्टीन्यूक्लिएटेड सेल विद प्रोमिनेंट न्यूक्लियाई पॉजिटिव फॉर CD15 and lymphocytes and macrophages separated by dense collagenous band। 1530 है सर, 15 लिखा है यहाँ पे, separated by dense collagenous। so कौन सा हॉजकिन है सर? देखो मल्टीन्यूक्लिएटेड जाइंट सेल्स दिख रहे हैं यानी RS सेल्स दिख रहे हैं। RS सेल्स आर पॉजिटिव फॉर CD15, हालांकि 30 यहाँ मिस हो गया, बट यू कैन सी मीडियस्टल मास है, मल्टीन्यूक्लिएटेड RS सेल दिख रहे हैं, CD15 पॉजिटिव है, दे आर सेपरेटेड बाय डेंस कोलाजिनस बैंड। कौन सा वेरिएंट की बात चल रही है सर? कौन से वेरिएंट की बात चल रही है? नोडुलर स्क्लेरोसिंग वेरिएंट की बात चल रही है। दे आर टॉकिंग अबाउट नोडुलर स्क्लेरोसिंग वेरिएंट। अब बता दो सर, हॉजकिन लिम्फोमा का, सी वी ऑल नो स्क्लेरोसिस मींस फाइब्रोसिस, द कोलेजन, ट्यूमर सेल्स आर सेपरेटेड बाय कोलेजन, तो इट इज नोडुलर स्क्लेरोसिंग वेरिएंट। तो कौन सा सेल दिखने चाहिए? यस सर, लैक्यूनार सेल। याद करके बोलो, तुम्हें मैंने पढ़ाया था, नोडुलर स्क्लेरोसिंग में स्क्लेरा छिपा है, स्क्लेरा छिपा है। स्क्लेरा का कलर क्या होता है? व्हाइट। इसलिए इसमें ऐसे सेल्स मिलेंगे जिनका साइटोप्लाज्म बिल्कुल व्हाइट फॉर्म में दिखेगा, यानी कि लैक्यूनार सेल, यानी कि लैक्यूनार सेल। सो प्लीज रिमेंबर, हॉजकिन लिम्फोमा के लैक्यूनार सेल्स हॉजकिन लिम्फोमा के नोडुलर स्क्लेरोसिंग वेरिएंट में मिलते हैं। सो हियर द बेस्ट आंसर इज लैक्यूनार सेल सीन इन द नोडुलर स्क्लेरोसिंग वेरिएंट ऑफ हॉजकिन लिम्फोमा। फटाफट बाकी ऑप्शंस को देख लेते हैं। हिस्टियोसाइट विद बेड ग्रैन्यूल्स, इट इज लैंगरहैंस सेल हिस्टियोसाइटोसिस। डचर बॉडीज आपको याद है मल्टीपल माइलोमा में दिखती हैं। पॉपकॉर्न सेल्स याद करो, बताया था NLPHL, P फॉर पॉपकॉर्न, इट्स अगेन अ नॉन क्लासिकल वेरिएंट ऑफ हॉजकिन लिम्फोमा। ये होता तो हम सबको पता है, जो NLPHL है ये नॉन क्लासिकल वेरिएंट में आता है। और नॉन क्लासिकल का पता कैसे लगता था? क्लासिकल आर 1530 पॉजिटिव और नॉन क्लासिकल आर 2045 पॉजिटिव। क्लासिकल जैसे यहाँ पे दे रखा है 1530 पॉजिटिव होता है, नॉन क्लासिकल इज 2045 पॉजिटिव, राइट। तो पॉपकॉर्न सेल इज सीन इन NLPHL वेरिएंट ऑफ हॉजकिन लिम्फोमा। Guys, which of the following will be found on flow cytometry with 1114 translocation? Come on, 1114। कौन सा लिम्फोमा? मेंटल सेल लिम्फोमा। और मेंटल सेल लिम्फोमा में क्या मिलता है? SOX11 भी मिलता है और साइक्लिन D भी मिलता है। सो ऑप्शन विल बी 1 and 2 only। मेंटल सेल लिम्फोमा इज 1 SOX11 एंड साइक्लिन D। अगर आपको याद है, मैंने अच्छे से कहा था, ये 1 और 1 14 हो गया, यानी ये गर्लफ्रेंड है सर। 1 और 1 11 से, मतलब इन्होंने शादी कर ली, 1 और 1 हो गई है, 1 और 1 हुए। उस लौंडे का नाम क्या है जिसने शादी की थी? CD5। और जिससे शादी की उस लड़की का नाम क्या है? CD23। CD5 ने 1 और 1 करके शादी तो कर ली, और शादी के बाद सबका हाल क्या होता है उसको आपको भी पता है। तो शादी के बाद CD5 को कहा मैं 23 के साथ नहीं रह पाऊंगा, तो 23 को छोड़ के भाग गया घर से। इतनी जल्दी भागनी थी, किस पे भागा? साइकिल पे भागा, और साइकिल पे इतनी तेज भागा कि जूते पहनने भी भूल गया। सिर्फ किस पे भाग गया? सॉक्स पहन के भाग गया। इसलिए इसको हमने मेंटल आदमी बोला सर। क्यों मेंटल हुआ? मेंटल आदमी कौन हुआ? CD5, उसकी बीवी का नाम CD23, बीवी को छोड़ के भागा पागलों की तरह, मेंटल होके भागा, किस पे भागा? साइक्लिन पे, बीवी क्या पहन के? सॉक्स पहन के। सो ऑल दीस आर फीचर ऑफ द मेंटल सेल लिम्फोमा। 5 पॉजिटिव होगा, 23 नेगेटिव होगा, साइक्लिन B पॉजिटिव होगा और सॉक्स 11 पॉजिटिव होगा। सो रिमेंबर दिस वे, एनेक्सिन A1 नहीं हो सकता। एनेक्सिन A1 इज सीन इन हेयरी सेल ल्यूकीमिया, इट इज सीन इन हेयरी सेल ल्यूकीमिया। Annexin A1 is seen in hairy cell leukemia. It is seen in hairy cell leukemia. CD138, 138 is seen in multiple myeloma. Remember, multiple myeloma के plasma cells CD38, CD138 positive होते हैं, right? Done. Move to next question. Fever है, diffuse myalgia है, abdominal pain, peripheral neuropathy है, hypertension है, weight loss है, बहुत सारे नॉन सिम्टम है। आगे चलते हैं। एंजियोग्राफी डेमोस्ट्रेट मल्टीपल एन्यूरिज्म इन द रीनल आर्टरी, तो रीनल आर्टरी इन्वॉल्व हो रही है, पहला पॉइंट। एंड द पास्ट मेडिकल हिस्ट्री ऑफ हेपेटाइटिस बी, यार ये तो बहुत है, आगे भी देख लेते हैं। आगे हमें दिख रहा है ट्रांसम्यूरल नेक्रोटाइजिंग वेस्क्यूलाइटिस विद फिब्रिनॉइड नेक्रोसिस, और कितना बोले साहब, पूरी तो नाम कथा सुना दी उसने। रीनल आर्टरी इन्वॉल्व हो रही है, हेपेटाइटिस बी की हिस्ट्री है और हमें फिब्रिनॉइड नेक्रोसिस दिख रही है। अगर अब भी ना बताए तो पाप लगेगा। इफ दे आर टॉकिंग अबाउट, अभी हमने डिस्कस किया, पैन में फिब्रिनॉइड नेक्रोसिस दिखती है, पॉलीआर्थराइटिस नोडोसा। So which of the following is true about this condition? Come on, prove the condition. The answer is B. The answer is D. Granulomas नहीं मिलते साहब। हमने लास्ट वाले CBoT में डिस्कस किया था, ग्रैनुलोमास कब मिलते हैं? 4 कंडीशन में मिलते हैं। हमने कहा था GT ड्यूरिंग द वर्ल्ड कप, हमने पढ़ा था लास्ट में जायंट सेल आर्थराइटिस, हमने लास्ट वाले में पढ़ा था टाकायासु में ग्रैनुलोमेटस है, वैजनर्स में ग्रैनुलोमेटस है, ग्रैनुलोमास बनते हैं। चर्क स्ट्रॉस सिंड्रोम में भी ग्रैनुलोमास मिलते हैं। भैया पैन में ग्रैनुलोमास नहीं मिलते। जीटी ड्यूरिंग द वर्ल्ड कप किया तो ब्रेन में ग्रैनुलोमास बन जाएंगे, याद करो। सर नहीं सर, लंग्स कभी इन्वॉल्व नहीं होते पैन में, पीएन का बॉडीज कभी नहीं रेस होती। सो राइट, ऑल 3 आर रॉन्ग स्टेटमेंट। पैन के बारे में द ओनली ऑप्शन इज द ऑप्शन डी। गाइस गाइस गाइस, पैन के बारे में आपको 2 चीजें हमेशा याद रखनी है। कम ऑन, पैन स्टैंड्स फॉर पॉलीआर्थराइटिस नोडोसा नहीं, आज के बाद नहीं। आज के बाद पैन विल स्टैंड फॉर पल्मोनरी आर्टरी नॉट इन्वॉल्व, कभी पल्मोनरी आर्टरी इन्वॉल्व नहीं होती, यानी देयर इज नो लंग इन्वॉल्वमेंट। दूसरा, पीएन का इज नेवर या नॉट रेस्ड। प्लीज 2 चीजें याद रख लेना यहाँ पे। पैन के बारे में पल्मोनरी आर्टरी नॉट इन्वॉल्व, नाम में छिपा है साहब, पल्मोनरी आर्टरी नॉट इन्वॉल्व पैन, एंड पीएन का नॉट रेस्ड। दैट इज 2 फीचर्स ऑफ the seen in NPA, not in PAN. So right, PAN में 2 चीजें कभी नहीं मिलती। The last option is acute और chronic inflammation एक साथ दिख सकती है, acute और chronic inflammation एक साथ देख सकते हैं। That's the feature of PAN, right? So answer would be D. Move to the next question, right? 27-year-old male physician के साथ आया sensation of heaviness in the right scrotum for 3 months. Painless testicular enlargement है, तो painful तो नहीं है, तो torsion तो rule out हो गया, painless है। अब लेबोरेटरी में क्या मिला? एचसीजी पॉजिटिव है। सॉरी, देयर इज नॉर्मल लेवल ऑफ एचसीजी एंड अल्फा फेटोप्रोटीन। आप मुझे बताओगे एचसीजी नॉर्मल है तो कोरियोकार्सिनोमा को हम रूल आउट कर सकते हैं। अगर एचसीजी नहीं है तो कोरियोकार्सिनोमा नहीं है, अल्फा फेटोप्रोटीन नहीं है तो यॉर्कशेयर ट्यूमर नहीं है। 2 तो वैसे रूल आउट हो गए। बचा क्या? एलिवेटेड लेवल ऑफ प्लैप इज सीन। प्लैप हमने पढ़ा था साहब किसमें? सेमिनोमा में। सेमिनोमा में याद करके बोलो, whenever I talk about सेमिनोमा, याद रख लेना पहली चीज, हिस्ट्री ऑफ अनडिसेंडेड टेस्टिस दे रखी होती है यूजुअली, क्योंकि अनडिसेंडेड टेस्टिस वाले पेशेंट में सबसे कॉमन सेमिनोमा है। फिर सेमिनोमा की जीन की बात करूं, आप सबको याद है जीन इज सीक्रेट जीन, जीन इज सीक्रेट जीन। फिर मैं बात करूं ग्रॉस की, ग्रॉस में अपने को बिल्कुल ग्रे व्हाइट लॉबुलर मास मिलेगा, ग्रे व्हाइट लॉबुलर मास मिलेगा। इंपॉर्टेंट क्या है? कभी हैमरेज और नेक्रोसिस नहीं मिलती इन सेमिनोमास, हैमरेज और नेक्रोसिस नहीं मिलती सब ग्रॉस में। फिर अगर हम माइक्रोस्कोपी की बात करें, हमने पढ़ा था फ्राइड एग अपीयरेंस मिलता है सर, इसमें पेरीन्यूक्लियर हेलोस मिलेंगे along with the nest of tumor cells separated by fibrous septa, nest of tumor cells which are separated by fibrous septa. The tumor cells are separated by fibrous septa, और fibrous septa में क्या भरा पड़ा है? lymphocytes भरी पड़ी है, lymphocytes भरी पड़ी है। वेरी वेरी इंपॉर्टेंट इमेज सर। कुछ और सामान है जैसे इमेज में दे रखा है, फाइब्रस सेप्टा, पिंक कलर का फाइब्रस सेप्टा जा रहा होगा साहब, और उसके अंदर आपको ब्लू कलर के लिम्फोसाइट्स मिलेंगे, फाइब्रस सेप्टा कंटेनिंग लिम्फोसाइट्स, राइट। तो ये तो हो गया माइक्रोस्कोपिक। सब कुछ भूल जाना सर, इसकी दो चीजें नहीं भूलना, एक तो इसका ट्यूमर मार्कर नहीं भूलना, मैंने आपको कहा था ट्यूमर मार्कर बीपीएल के निमोनिक से याद करो, बीपीएल, आईपीएल नहीं, बीपीएल ऑफ सेमिनोमा। बी से आपको याद आ रहा होगा बीटा एससीजी, ऑल्दो नॉट हाईली पॉजिटिव, इट्स 15% केसेस में। पी से आपको याद आ रहा होगा प्लैप, प्लेसेंटल एल्कलीन फॉस्फेटेस, और एल से तो सबका पिताजी एलडीएच। बीटा एससीजी, प्लैप एंड एलडीएच इज ट्यूमर मार्कर ऑफ सेमिनोमा, ट्यूमर मार्कर ऑफ सेमिनोमा। जाते जाते हम आईएससी की भी बात कर लेते हैं, याद करो बताया था तुमको आईएससी, कलरफुल किट पहन के कौन सी तारीख को, अक्टूबर 3rd 4th को, किससे मिलने गए, नाना जी से। ना जाना नाना जी से मिलने, नहीं तो सेमिनोमा हो जाएगा। सो कलरफुल किट पहन के 3rd 4th अक्टूबर को नाना जी से मिलने नहीं जाना, नहीं तो सेमिनोमा हो जाएगा। So these are the 3 ISC for the seminomas. क्वेश्चन हमेशा टकरा जाता है सेमिनोमा के ऊपर, तो रिमेंबर ऑल दिस फीचर ऑल्सो। लास्ट पॉइंट है, इट इज रेडियो सेंसिटिव। जब इतनी बातें अपन कर रहे हैं तो ट्रीटमेंट की बात कर लेते हैं। सेमिनोमास आर रेडियो सेंसिटिव ट्यूमर, राइट। मूव टू द नेक्स्ट क्वेश्चन। All of the following are the microscopic feature of chronic hepatitis except the answer is ballooning degeneration. बलूनिंग डिजनरेशन क्रॉनिक में नहीं दिखती, बलूनिंग डिजनरेशन एक्यूट हेपेटाइटिस में दिखती है। फटाफट जब हम हेपेटाइटिस की बात कर ही रहे हैं साहब, तो 1 मिनट में हेपेटाइटिस के 4 फीचर याद कर लेते हैं। हेपेटाइटिस के माइक्रोस्कोपिक फीचर, 2 टाइप की हेपेटाइटिस हुई, एक्यूट क्रॉनिक, ए और ई एक्यूट हो गया, बी सी क्रॉनिक हो गया। मैं सिर्फ माइक्रोस्कोपिक फीचर्स की बात कर रहा हूँ साहब। जब मैं एक्यूट के माइक्रोस्कोपिक फीचर की बात करूं तो रिमेंबर बीएससी, बी से आपको याद आ रहा होगा बलूनिंग डिजनरेशन, बी से आपको याद आ रहा होगा बलूनिंग डिजनरेशन, एस से आपको याद आ रहा होगा स्पॉट नेक्रोसिस, और सी से आपको याद आ रहा होगा काउंसिलमैन बॉडीज, सी से आपको याद आ रहा होगा काउंसिलमैन बॉडीज। वेरी वेरी इंपॉर्टेंट, दिस इज फीचर ऑफ एक्यूट हेपेटाइटिस। क्रॉनिक की बात करो तो वो गेम जिसने जीना हराम कर दिया लोगों का, पबजी। क्रॉनिक में यू विल हैव पबजी। सबसे पहले तो पीस मील नेक्रोसिस, दैट इज द नेक्रोसिस ऑफ द लिमिटिंग प्लेट, पीस मील नेक्रोसिस। यू से आपको याद आ रहा होगा अल्ट्रा लिम्फोसिटिक इन्फिल्ट्रेट, यानी बहुत सारा लिम्फोसिटिक इन्फिल्ट्रेट इन द पोर्टल ट्रैक्ट, इन द पोर्टल ट्रैक्ट। बी से आपको याद आ रहा होगा ब्रिजिंग फाइब्रोसिस, बी से ब्रिजिंग फाइब्रोसिस, और सी से सबके पिताजी वाला क्वेश्चन ग्राउंड ग्लास हिपेटोसाइट्स। सी से यू हैव ग्राउंड ग्लास हिपेटोसाइट्स। गाइस सब कुछ भूल जाना, ही मत भूलना। ग्राउंड ग्लास हिपेटोसाइट्स कहाँ मिलते हैं, हेपेटाइटिस बी वायरस इंफेक्शन में। सब कुछ भूल जाना, ये मत भूलना। हेपेटाइटिस में यू हैव ग्राउंड ग्लास हेपेटोसाइट्स। सो पबजी इज द क्लिनिकल फीचर, इज अ माइक्रोस्कोपिक फीचर ऑफ क्रॉनिक हेपेटाइटिस, एंड बीएस इज अ माइक्रोस्कोपिक फीचर ऑफ एक्यूट हेपेटाइटिस। बाकी देख लो सर, पीसमील नेक्रोसिस भी क्रॉनिक में पड़ा, ब्रिजिंग फाइब्रोसिस भी क्रॉनिक में पड़ा, पोर्टल ट्रैक्ट एक्सपेंशन बाय लिम्फोसाइट, दैट इज अल्टरनेटिव लिम्फोसाइट इन्फिल्ट्रेट, ये भी क्रॉनिक में मिला। सो आउट ऑफ दिस द बेस्ट आंसर इज the ballooning degeneration. चलो आइडेंटिफाई द इमेज बिलो। सर टाइम वेस्ट करने का ही नहीं। ट्रू रोजेट्स है या सूडो रोजेट्स है? सर मुझे बिल्कुल व्हाइट कलर का एम्प्टी ल्यूमेन दिख रहा है सर, व्हाइट एम्प्टी ल्यूमेन दिख रहा है, मतलब एक बात तो पक्की है सर, ये ट्रू रोजेट्स है। और मैंने अच्छे से पढ़ा था, ट्रू रोजेट्स का नाम क्या पढ़ा था मैंने, फ्लेक्सनर विंटरस्टीनर रोजेट्स, फ्लेक्सनर विंटरस्टीनर रोजेट्स, जिसको मैंने पढ़ा था। कहाँ पे मिलते हैं बॉस, ये रेटाइनोब्लास्टोमा के पेशेंट्स में मिलते हैं सर। तो अगर यही व्हाइट कलर का एम्प्टी ल्यूमेन दिखे, दे आर ट्रू रोजेट्स, फ्लेक्सनर विंटरस्टीनर रोजेट्स सीन इन रेटाइनोब्लास्टोमा। तब ऑप्शंस देख लेते हैं सर। आई थिंक द बेस्ट आंसर हियर वुड बी रेटाइनोब्लास्टोमा। रेटाइनोब्लास्टोमा बच गए 3। नॉर्मली मेन वाले ट्यूमर्स, नाम ही मेन आ गया सर, मेन वाले ट्यूमर्स में यू विल हैव सूडो रोजेट्स। वहां पे ट्रू नहीं, वहां पे सूडो रोजेट्स मिलते हैं मेन कैंसर्स में, सूडो रोजेट्स। और उन सूडो रोजेट्स को अपन ने क्या नाम दिया, होमेराइड रोजेट्स। इनको हमने नाम दिया होमेराइड। किसी में मिल सकते हैं, मेडुलोब्लास्टोमा में, इविंग्स में, न्यूरोब्लास्टोमा में, बेसिकली मेन ट्यूमर्स में। बट आउट ऑफ दिस जो पूछा गया अभी तक, रिमेंबर मेडुलोब्लास्टोमा। मेडुलोब्लास्टोमा भी नाम मल्टीपल टाइम्स। मेडुलोब्लास्टोमा में सूडो रोजेट्स, और सूडो रोजेट्स का मतलब पी से सूडो, पी से पिंक ल्यूमेन मिलेगा, इसमें सूडो में यू विल हैव पिंक ल्यूमेन, राइट? सो दिस वाज ऑल अबाउट द अभी बचे हैं क्वेश्चन, so let's discuss that also. The next question is, patient was diagnosed with a DNA repair defect, motile hyperpigmentation of skin. DNA repair defect है, motile hyperpigmentation है skin पे, high risk of developing skin cancer, which of the following is a likely enzyme defect? I hope आपने गलत नहीं किया होगा. Answer is nucleotide excision repair defect. Nucleotide excision repair defect. फटाफट डिस्कस कर लेते हैं डीएनए रिपेयर डिफेक्ट को. जब मैं डीएनए रिपेयर डिफेक्ट की बात करता हूं, सब आई एम श्योर आप सबको याद है. सबसे पहले तो वी हैव गॉट द मिसमैच रिपेयर डिफेक्ट्स, देन वी हैव गॉट न्यूक्लियोटाइड एक्सीजन रिपेयर डिफेक्ट्स, एक्सीजन रिपेयर डिफेक्ट, एंड द थर्ड इज रिकॉम्बिनेंट रिपेयर डिफेक्ट. We have got the recombinant DNA repair defect. Everybody, सबको पता है mismatch repair defect से कौन सा disease? HNPCC, also called as Lynch syndrome. अगर आपकी mismatch repair genes काम नहीं कर रही तो HNPCC और Lynch syndrome होगा. अगर आपकी न्यूक्लियोटाइड एक्सीजन रिपेयर जीन्स काम नहीं कर रही तो स्किन लीजन होगी, जिसका नाम हम सब जानते हैं, जीरोडर्मा पिगमेंटोसा, जो इस पर्टिकुलर क्वेश्चन का क्लिनिकल केस था. जीरोडर्मा पिगमेंटोसा के बाद स्क्वैमस सेल कार्सिनोमा के चांसेस बढ़ जाएंगे, राइट? टॉकिंग अबाउट रिकॉम्बिनेंट डीएनए रिपेयर डिफेक्ट, वेरी पॉपुलर एमसीक्यू. कैन यू टेल मी द एग्जांपल ऑफ रिकॉम्बिनेंट डीएनए रिपेयर डिफेक्ट्स? रिमेंबर देयर आर 3 एग्जांपल्स व्हिच वी नो बाय द निमोनिक AFB, that is ataxia telangiectasia. F से Fanconi anemia, F से we remember Fanconi anemia, and B से we remember Bloom syndrome. So please remember guys, ataxia telangiectasia, Fanconi anemia and Bloom syndrome. Bloom syndrome, right? So these are the recombinant DNA repair defect. यहाँ पे साफ-साफ है जीरोडर्मा पिगमेंटोसा का केस है, तो भैया the best answer should be nucleotide excision repair genes, right? Move to the next question. अरे next question तो done हो गया. चलो guys, thank you very much from my side. Keep studying well. अभी हम बहुत बार मिलेंगे. Keep praying for you. अच्छे से मेहनत करते चलो. दिन अपना आएगा, पूरा लम्हा अपना आएगा. All the best guys. Take care man.
Ladies and gentlemen, welcome to the CBoT of Ophthalmology, and guiding you through the questions of ophthalmology, the tough questions, not so tough, I can tell you, is your friendly neighborhood ophthalmologist, Shashwat Ray. Okay, so without wasting further time, let's look at the first question. And this is a patient after vitrectomy a few weeks back, comes to OPD with a collection of fluid as shown in the image. Which of the following correctly describes this? Now this, if you look at the image, it looks very strange, isn't it? It looks like a hypopion, but the surprising thing is that the hypopion is a collection of pus at the bottom of the antechamber. Here, the pus seems to be at the top of the antechamber, and that is why, remember, that is quite right, this is called a reverse hypopion. We also, it does look like hypopion, but it is not. It's called reverse or an inverse. You can use any of the two words, hypopion. Okay, reverse or inverse hypopion. That is correct. But what is this exactly? This reverse inverse hypopion. Let's take a look at that. Is it a perfect coin? I'll say incorrect. Collection of pus in the vitreous, incorrect. This is not pus in the vitreous at all. This is in the antechamber. Collection of emulsified silicon oil in the antechamber is the correct answer. Please remember, it is silicon oil in the antechamber. It is not the fourth choice in the posterior chamber. So what happens here, remember, the answer here is C, that you see, we inject silicon oil in the vitreous cavity when you do vitrectomy to use the silicon oil as a tamponading agent after retinal detachments, okay, after you have a vitreoretinal surgery. So you have settled the retina, but we need to leave a tamponading agent, something which keeps the retina flattened. So because of the specific gravity of silicon oil, it's a heavy oil, it keeps the retina pushed against the two layers of the nucleus RP and keeps it flat. However, if you leave this oil, silicon oil, it may cause a lot of problems, like it may cause cataracts, it may cause glaucoma. So the idea is usually to remove the silicon oil within 2-3 months, is it not? But the silicon oil, it gets emulsified sometimes, and it, because it's lighter than aqueous humor, so it floats up and collects at the top of the antechamber, which looks like a hypopion. Okay, so kindly remember, you have blood in the antechamber as hyphema, you have pus in the antechamber as hypopion. emulsified silicon oil in the top of the antechamber. This is called inverse hypopion or reverse hypopion. Okay, and that is exactly what happens. So, and that is why if you see carefully at the bottom, there's a PI performed here. It's a peripheral iridectomy. This is called as andozyridectomy. Okay, andozyridectomy is performed. It is placed there so that there is no question of a pupillary block. Okay, usually we do LI or a PI at the top of the iris, is it not? Here, because the silicon oil goes to the top, it may obstruct the superior PI. So that's why the PI is performed in the inferior part of the iris to allow the aqueous to get out and not cause a pupillary block glaucoma. So this is emulsified silicon oil. Please remember, this is a very famous MC. A 20-year-old presented with watering redness and foreign body sensation in the past, for 1 month. You have history of wearing contact lens, and that is the trick. What is the most probable diagnosis? If you look at this, these are giant, flat-topped, reddish color nodules on the conjunctiva. And what are they? As you know, these are papillae. And look at the size. They're very big. They're more than 1 millimeter in size. We call them giant papillae. But why are they present there? Let's look at the choice. Acute trachoma, incorrect. That's because acute trachoma does not have papillae. It has follicles, which you call as sago grain follicles. Spring catarrh, incorrect. In spring catarrh, you do have papillae, but you do not have spring catarrh after a history of wearing contact lenses. Spring catarrh, you should identify it by hot weather and young boys. And follicular conjunctivitis, incorrect. This is not follicles at all. This is a papillae. So the answer is D, which is the giant papillary conjunctivitis, where you see these large papillae in response to some stimulus which is causing irritation to the conjunctiva. You see, when you wear contact lenses, the edge of the contact lens keeps hitting against the conjunctiva almost 8,000 times a second. 8,000 times a day. Okay. So now this constant ceaseless hitting of the lens edge on the conjunctiva stimulates development of the papillae, which you call as giant papillary conjunctivitis, okay? Or anything else, anything foreign body, like could be, exposed suture in the conjunctiva. It could be some prosthesis in the eye, which cause irritation and production of the papillae. So this is GPC. Is this, remember, it is the single most common complication of contact lens wear, okay? Okay, remember, when they say, as they've said, foreign body sensation, watering and redness, it means, and after history of contact lens wear, it means that you are talking about GPC. If they mention redness, pain, and loss of vision after history of contact lens wear, then it refers to a question on bacterial keratitis. Okay, so contact lenses, you have two important questions. If it's pain, it's an ulcer, most likely bacterial. If it's no pain, it's conjunctivitis, it's GPC. The answer is giant papillary conjunctivitis. Next question, a 7-day-old neonate. Remember, that's important. It's already a week-old neonate. Born at 28 weeks of gestation, has developed respiratory distress at birth. How many weeks from now can the neonate be screened for retinopathy of prematurity? Remember that we have this condition called as retinopathy of prematurity, which occurs to children who are born less than 34 weeks. Okay, so they are very early children, and instead of the normal 37 to 38, they are born at less than 34 weeks, then the chance of developing a condition called ROP occurs. This is one. Or if you do not know the gestational age of the patient, then you should know. If you are not sure of what is the gestational age of the patient, then you should at least look at the birth weight. If the child is less than 2,000 grams of birth weight, then also the chance of ROP occurs. These are two important criteria when we must screen the child. Okay, less than 34 weeks gestational age, and less than 2,000 grams of birth weight. So the guidelines is that we should see the child at about 4 weeks of gestational age. Okay, 4 weeks of gestational age, or 31 weeks of post-menstrual age, PMA, whichever is later. This is the guideline. And here it is clearly mentioned 4 weeks or 31 weeks of post-menstrual age. So we have already the child is 7-day and 4 weeks gestational age means another 3 weeks. We must check the child for ROP. The answer is A. 3 weeks is the correct answer because this is the first examination of the child at 3 weeks when the child is about 4 months gestational age. It's not easy to examine because we dilate the pupil, which is not an easy task in a very small child. We have to use drugs which do not cause toxicity, like 2.5% phenylephrine to dilate the pupil, and retina has to be examined by a doctor who's trained in screening children for ROP using a ret cam. Is it not? So it's not an easy just thing at all. Next question. A 70-year-old man after cataract surgery presents to the OPD with blurring of central vision with metamorphopsia. Remember, this refers to metamorphopsia means that you have some macular disorder, and because blurring of vision after cataract is typically, this is the cystoid macular edema, which is seen after cataract surgery, which is very famous, known as the Irwin-Gass syndrome. The IGS, you must remember, Irwin-Gass syndrome is the name given to cystoid macular edema after cataract surgery. And so you have Irwin-Gass syndrome here, and that's because it tells you metamorphosis and loss of vision. So you have Irwin-Gass, very well. On top of that, this elevated intraocular pressure was found, so you have secondary glaucoma also, which is actually quite common after cataract surgery. So which anti-glaucoma drug should not be used to control IOP in this post-op patient with macular edema? So remember, here the answer is latanoprost. Why? Because latanoprost is well known to cause cystoid macular edema after. As one of the side effects of latanoprost, and you can see this here, you can see the OCT finding, latanoprost causes cystoid macular edema. It's a well-known side effect of latanoprost. In fact, if you remember the three major side effects of latanoprost, first was that it induces cystoid macular edema, which you can see in the OCT here. You can see the cysts also. You can see the swelling over the macula like this. This is cystoid macular edema. Second, this cystoid macular, it causes a lot of, if you remember side effects of latanoprost, it may cause reactivation of herpes simplex virus. And third important side effect of latanoprost usage is that it causes uveitis also. So it cannot be given to patients who develop uveitic glaucoma. So in this case, since it already has cystoid macular edema after cataract surgery, and if we give latanoprost, it will further cause CME, all of which, both the types of CME will plunge the vision of the patient who has just recovered good vision after cataract surgery. Now, this is unacceptable to the patient. That is why prescribing latanoprost for secondary glaucoma after cataract surgery is not a good idea. And that is the answer, latanoprost. Identify the findings seen on slit lamp examination in the glaucoma patient, and you can see here this typical spindle-shaped thing here, the pigment here is the Krukenberg spindle, isn't it? It's called the Krukenberg spindle, which is seen in pigmentary glaucoma. Pigmentary glaucoma is this classic triad of the Krukenberg spindle, radial transillumination defects of virus, which you can see here, and the pigmentation of trabecular meshwork. You see what happens in pigmentary glaucoma is that because the iris is rubbing against the zonules, the structure, the anatomy of the iris is such that it rubs against the zonules, and as it rubs against the zonules, so it releases the iris pigment. This pigment, it goes and blocks the trabecular meshwork, raising the intraocular pressure, and that is causing the glaucoma. That is causing the glaucoma. So this is the typical presentation of the Krukenberg spindle. Very well. So the answer is Krukenberg spindle. The next question is, which of the following marked layers of retina hard X-rays would be seen? And let's look at that. The hard X-rays, remember, are seen in a layer called the outer plexiform layer. And how to recognize them? Remember, the outer plexiform layers lies between the inner nuclear layer and the outer nuclear layer. You can see the two nuclei here. This is the inner nuclear layer, the purple one, and this is the outer nuclear layer. This layer in between, which is marked as 3. This is the layer of the OPL, the outer plexiform layer, on which the hard X-rays would be seen. Okay, and so the answer here is 3. And let us see, the outer plexiform layer is one of the 10 layers of the retina. The hard X-rays you can see here are the cholesterol deposits on the outer plexiform layer. And the soft X-rays are axoplasmic debris on the nerve fiber layer. Okay, they are on the nerve fiber layer. So these are the two different types of X-rays we have. Okay, and remember, one of hard X-rays are cholesterol deposits, soft X-rays are not cholesterol deposits. These are axoplasmic debris, and they are on different layers, the nerve fiber layer. Okay, so this is the outer plexiform, which you recognize because layer 3, as you can see, lies between the outer nuclear and the inner nuclear layer. Okay, so that answer is layer 3. A newborn presents with symptoms of photophobia and excessive tearing. Upon examination, the tear patches appears normal, but the cornea is visibly enlarged and hazy. What is the probable diagnosis for this condition? And here, remember, is it trachoma incorrect? Okay, Keratoconus does not, newborn infants mostly. Keratoconus incorrect. The answer, because of the conus visibly enlarged and hazy, is ophthalmos or congenital glaucoma, and that is right. As you can see, the enlarged eyeball because of glaucoma in a newborn. So this is, you see, whenever a child comes to us with tearing of the eyes, we have to think of two things. One, if the tearing of the eyes occurs, then first we have to think of first whether it is a congenital nasolacrimal duct obstruction, okay, or it could be a more dangerous diagnosis which is called as ophthalmos, is it not? Now, it is not a nasolacrimal duct obstruction because it stays that the tear patches appear normal, is it not? The con is cloudy and enlarged and hazy, which tells us ophthalmos, because in ophthalmos, the raised intraocular pressure stretches the size of the eyeball, it becomes very large. That is why it's called ophthalmos, which means a bullseye or a cow's eye. Okay, and you can see it here. The answer is very much as ophthalmos. So, can you remember how to distinguish these two conditions on clinical examination? Is that when you have congenital nasolacrimal duct obstruction, so there is the patient does not has any photophobia and does not have any blepharospasm. He has watering alone. But in ophthalmos, you have watering also, you have, which is called lacrimation, you have the photophobia, and you have blepharospasm also. So these are the two ways to differentiate the ophthalmos from the congenital nasolacrimal duct obstruction. Which the following is the correct prescription for the simple myopic astigmatism? Is if the first is incorrect because there's a +2, so it is a simple hypermetropia. Second is incorrect, it's -2, it's simple myopia. Third is -2 diopter cylinder at 180 degrees. The answer, it's simple myopic astigmatism. There's only one single minus sign. And -2, fourth choice with the -2 diopter cylinder. There are two minus signs. This is compound myopic astigmatism. But we are asked for simple myopic astigmatism, which is the -2 at 180, only one sign. So remember, this is called simple myopic astigmatism, where one ray is on the retina, others in front of the retina. This is the simple myopic astigmatism, okay? Like this. And we can write that. How do we write this? Because you see, since one is myopia, so I need 1 minus 2 at, say, -2 diopter cylinder at any axis, say 180 degree, okay? So why minus? Because it's myopia. Why cylinder? Because it's astigmatism. Why 180? I have taken any axis that I choose. Okay. So when you have one minus sign at any particular axis, it becomes simple myopic astigmatism. When you have two minus signs at any particular axis, it becomes compound myopic astigmatism. When you have one plus sign at any particular axis, it becomes simple hypermetropic astigmatism. When you have two plus signs, it becomes compound hypermetropic astigmatism. You have one plus sign and one minus sign, it becomes mixed astigmatism. So that's the way to distinguish. So here the answer is C, is a simple myopic astigmatism which looks like this. And with that, ladies and gentlemen, thank you very much for a patient hearing. I hope you've answered all the questions. They're not very simple, but they're not very difficult also. Thank you very much and all the best.
Hello. So I hope you had a good CBoT exam. There were 5 questions from anesthesia and I'll discuss those questions with you. So first question was about the airway equipment that is on laryngoscope. And the very probable question, airway is one topic from which the questions are very much asked in exam. So question is, you are paired with senior anesthesiologist for a practical intubation practice session for attending a trauma training class. A mannequin simulates an accident victim with a potentially compromised airway. You need to use laryngoscope to accomplish an intubation. Which laryngoscopic blade is most frequently used? Well, the most common laryngoscopic blade which a person is trained on and which is most commonly we are using in most of our practical scenario in an adult is Macintosh laryngoscope. That is the curved blade laryngoscope. So Miller, which is the straight blade laryngoscope, straight blade laryngoscope is mostly used in children, right? It is mostly used in children. The Macintosh, that is curved blade laryngoscope, it is the most common laryngoscope which is used in adult, and this should be the answer, right? So we are mostly trained on Macintosh laryngoscope. This is the commonest laryngoscope which is being used, right? Okay. Now, Wisconsin is another special laryngoscopes used in some special circumstances. And Margle is not a laryngoscope. We have Margle forceps, right, which aids us in intubation during some difficulties. So, answer has to be Macintosh. Okay, next question. You notice a device, so an image of a device has been given for managing anesthesia agent delivery during surgical procedure. Your knowledge of its functionality is tested by attending anesthesiologist. What type of machine is this? So they are asking, there is this. This is one of the earliest anesthesia machine. This is Boyle's apparatus. Boyle's apparatus. Okay. And what anesthesia machine does? That when we start a flow of gases in anesthesia machine, they continuously come out of the outlet of the machine and enter the circuit. So our anesthesia machine is continuous flow machine, right? So what are the options? Continuous flow machine, intermittent flow machine, intermittent at low flows, continuous at high flows, continuous at low flows. Well, answer is continuous flow machine. So all anesthesia machine, once the flow is started, they continuously come out of the machine and enter the circuit. So they are continuous flow machine. Okay, right. Next, the following rhythm was developed in a patient aged 50 who had previously experienced hypertension and diabetes mellitus. In addition to have weak pulse, his blood pressure was 90/40. What will be the management, next move in the management? Well, the patient is having this rhythm and patient has been brought to the emergency. The blood pressure is also decreasing, right? So whatever is this rhythm, we will just recognize the rhythm. It is causing cardiovascular instability. Cardiovascular instability. Well, let us first recognize the rhythm. Now, RR interval is shorted. So this is tachyarrhythmia, right? This is tachyarrhythmia. Now, QRS complex is narrow. So this is narrow QRS complex tachyarrhythmia, right? We cannot see P wave. So I am saying it is arrhythmia, not tachycardia, right? So it is narrow QRS complex tachyarrhythmia, which are of mostly three types: flutter, atrial fibrillation, and PSVT, paroxysmal supraventricular tachyarrhythmia. Now, in atrial flutter and atrial fibrillation, we will see a typical type of P wave. In flutter, we will say instead of P wave, we will see flutter wave, and in fibrillation, we will see instead of P wave, fibrillating waves of atria, which is not seen in this. Okay, here we are not able to see any P wave because of the increased heart rate. The P wave has been, let's say, it is hidden, right? So this is PSVT, paroxysmal supraventricular tachyarrhythmia. Okay, so we have patient who is in PSVT, right? And PSVT can present as stable or unstable. Unstable would be coming with symptoms like decrease in blood pressure, anginal pain, now signs of shock, right? These clinical features will come. So whenever patient comes in unstable PSVT or any unstable tachyarrhythmia, the management of choice is cardioversion. So we go for cardioversion, right? We go for cardioversion, synchronized cardioversion, right? We give a shock synchronized at the peak of R interval, peak of the R, right? So answer would be DC cardioversion, right? If the patient was not developing cardiovascular instability, it was stable PSVT, then we would have gone in the management. Number one, we would have done the vagal maneuver. If patient, the rhythm would not have become sinus rhythm with vagal maneuver, then we would have given IV adenosine, the drug of choice. The dose is 6 milligram. If the first dose is not converting the rhythm into sinus rhythm, we would have increased it to 12 milligram. Okay. And if this would have also not converted into sinus rhythm, we would have just tried to decrease the rate of the heart by giving beta blocker or calcium channel blocker. Okay. So this is how we manage PSVT, the rhythm which is in the image. So answer for this question is DC cardioversion. Next question. A patient in emergency room is having breathing problem. So patient requires oxygen therapy. How much oxygen can a nasal cannula supply at its highest capacity? So they are asking a conventional nasal cannula, what is the maximum percentage of oxygen it can give? So we have talked about nasal cannula, and I told you nasal cannula, the FiO2 can start from 0.22 to 0.45. Okay, so maximum it can give 45%. Maximum it can give 45% oxygen. Okay, so in this options are 100%. Nasal cannula can never give 100%. 90%, no, it's too high. 40%, 10%. So maximum it can give 40%. Maximum 45% would have been a perfect answer, but since 45 is not in the option, we would go for the next maximum below 45, and that is 40%. Okay, so remember, nasal cannula, the conventional nasal cannula, it gives FiO2 between 0.2, what we have written, 0.22 to 0.45. For every 1 liter of flow, 4% oxygen concentration would increase over room air, okay, and we keep the flow between 1 to 6 liters per minute, right? Now, simple face mask is another oxygen delivering device. 6 liter to 10 liter per minute is the flow which we keep, and it can give FiO2 0.33 to 0.60. That is 33% to 60% of oxygen concentration can be delivered by face mask. Then non-rebreathing mask. We keep the flow 10 to 15 liter per minute, and it can give FiO2 0.7 to 0.9. That is 70 to 90% is what it can be given by it. Okay. So this is about the oxygen delivering device. Another very important topic which can be asked in exam. Then the next question. The lead anesthetist advises making sure the patient has enough oxygen while you are preparing the patient for post-op care after an operation. They make reference to avoid certain anesthetic related problem. So we are talking about post-operative hypoxia which can happen in the patient. During anesthesia, when is diffusion hypoxia commonly seen? So what is diffusion hypoxia? It is hypoxia due to after discontinuation of nitrous oxide during recovery due to fast diffusing out of nitrous oxide from blood into the alveoli during reversal of anesthesia. So it is only seen when you are giving patient nitrous oxide plus oxygen combination. So when the patient is recovering from the nitrous oxide anesthesia, nitrous oxide diffuses out of the blood into the alveoli very quickly. It has a low blood gas solubility and dilutes the oxygen concentration of the alveoli and produces something called diffusion hypoxia. So when is diffusion hypoxia seen? With recovery from nitrous oxide. Okay, so I told you, when I'm giving my patient from machine the gas is going into the circuit, into the airway, and it is reaching the alveoli, from alveoli into the blood, and then it is reaching the brain. Okay, so nitrous oxide, when you give continuously, the gradient is from alveoli into the blood, into the CNS, and when you stop giving it, it has a blood gas solubility 0.45, a low blood gas solubility. So it comes out of the blood into the alveoli very quickly, and whatever oxygen present in the alveoli, it dilutes it, producing a hypoxic mixture. And this is what is called diffusion hypoxia. So how do we manage? The management is always 100% oxygen. We give 100% oxygen. So this was the fifth question, and these were the questions which were asked in CBoT. If you have gone through all the lectures of anesthesia and emergency medicine from the app, you may not have missed any of the question, and these are quite expected questions which could be asked in exam. Best of luck for your exam. Thank you.
Hello and welcome to the orthopedics session of this GT6. Hopefully the paper went well. Hopefully you have resonated with the paper, that how the paper language is basically designed for you to mark the answers in the upcoming of the examinations. Let's start with the first question, which is obviously a core clinical question. Normally how the patient projects or presents to you and how you have to mark the correct answer based on what you are going on to the patient. All right, the best decisions that has to be taken in order to manage that patient in particular. A 6-year-old child comes with the 2-day history of fever and chills, was referred for the management. His mother claims that he has been screaming when his left leg is touched and there is a refusal to walk. Now obviously some pathology is there in the leg of the left leg, right, for the last 2 days. Now there is a history of fever, there is a history of chills, and there is tenderness precisely on one location. So possibly we are seeing a patient who might be suffering from either tumor or infection or trauma, right? Now, upon inspection, the medial side of the tibia was found to have a point of tenderness. Investigation turned up the information below. Now, what the investigations were, although it's a miss from our side where these investigations are not given in the questions over here. Hopefully, you have got those investigations as a part of the question. Like HB is 11.9 gram per deciliter, which is absolutely relatively normal. Now, WBC count is almost double the upper limit of the normal. That is 22,000. Then MRI shows intramedullary abscess in the proximal tibia. That means we are sure that we are looking at the patient who is having osteomyelitis. That means collection of the pus inside the tibia intramedularly. Now, which of the following is not a good strategy for management of this child? Now, obviously, what is the first thing that you will do? You will try to immobilize the limb, and that immobilization is achieved by the splinting, because if the persistence of mobilization is carried out, then what will happen? There will be more pain. There will be more discomfort. Imagine if there is a condition the patient is suffering from and this infected limb is continued to move. So, splinting is obviously required. So, step-by-step management, that is splinting is required. So, yes, splinting is required. So, this obviously is not a bad strategy. Then second, you will start giving empirical antibiotics. That means you will start the management by giving the general antibiotics to the patient in order to decrease the load of the organisms. Although specific antibiotics are to be given once the pus culture report is out, but that requires at least 48 to 72 hours for this report to be arrived. Before that, you have to be dependent on the empirical antibiotics. All right. So antibiotics are to be given as early as possible. And then you have to decide whether to go for the drainage or not, because there is a collection of the abscess inside the medullary canal. So obviously you have to go for the surgical drainage. Yes, this is true. So all these things are true. Now, one of the option is vacuum assisted closure. Now, just try to understand what is the meaning of the vacuum assisted closure. You know, vacuum assisted closure means that there are some pipes which are placed where there is a lack of vascularity and the wound is required to be healed. Then in that case, vacuum assisted neovascularization is required. So wherever you need a neovascularization, this vacuum assisted closure is done. Not in the cases of the abscess, where probably we are going to put antibiotic cements, we'll be putting the antibiotic drainage system, we'll be keeping the wound open so that whatever the amount of the abscess which is in future going to be presented inside this tibia can be easily drained out. All right. So vacuum assisted closure has got some specific indications. Particularly, it is helpful in those where the new vascularization, new blood vessels are needed to be created in order the wound to get healthier, and it is easier to close the wound without any subsequent infections. All right. So out of the strategies which are provided over here, the best one obviously is the vacuum assisted closure is not the best one. All right. Hopefully you get the answer right for this particular question. Next is, a construction worker complained of numbness on the outside of his leg after wearing this tight harness for several hours. That means a tight harness for several hours resulting in the numbness. That means the nerve is getting compressed. So the mechanism of compression or the mechanism of any sort of nerve injury over here is basically the compression. All right. Now, he doesn't recall any trauma. There is no trauma or any injury. Which of the following mechanism is likely more for the cause of this condition? Which of the following is more likely a cause for his condition? And answer for that question is straightforward. That is neuropraxia. Already you are aware of the answers or what are the different types of the nerve injuries according to the Seddon system of classification. One is neuropraxia, which is a transient kind of the nerve injury, which is a result of a compression mechanism, right? When the nerve is compressed for a longer duration of time. And this is a transient type of the nerve injury, temporary kind of the nerve injury, which will resolve after some duration of time once the compression is relieved, right? As far as neurotmesis is concerned, it is the complete injury to the nerve. Outermost layer of the nerve, that is the epineurium, is also injured. As far as neurolysis is concerned, it is the lytic activities which are happening inside the nerve. Axonotmesis is concerned, where is the outermost sheath of the nerve, that is epineurium, it remains intact, whereas anything could be structurally injured or discontinued in axonotmetic injury. So obvious answer for this particular question is neuropraxia. Next question, all of the following clinical tests are used for making the diagnosis of anterior dislocation of the shoulder. You know, anterior dislocation of the shoulder, the clinical tests are Dugas test. Yes, it is a test for the anterior dislocation of the shoulder where the patient is not able to touch the opposite shoulder. Inability to touch the opposite shoulder is known as Dugas test positivity. Actually, Dugas test has got two components. One is inability to touch the opposite shoulder, and the second one is inability to bring the elbow in the midline. All right, that is a feature of anterior dislocation of the shoulder joint. Bryant test, yes, you know, these are the inferior axillary fold. Now, in case the right-sided shoulder is dislocated, this sided inferior axillary fold will be lower in comparison to the other one. That is Bryant test positivity. Hamilton ruler test, yes, it is also a feature of anterior dislocation of the shoulder where the acromion process and the lateral epicondyle of the humerus can be touched simultaneously by the rigid ruler in case the shoulder is dislocated anteriorly. So all of them are the tests for anterior dislocation of the shoulder. What we are left with is the lift-off test. Now this lift-off test is also known by the name of GER-BER, that is Gerber test or the Gerby test. Now this test is actually not for anterior dislocation. This test is for the subscapularis. This test specifically is for subscapularis injury. All right. You know, the four tendons in case of rotator cuff, one is supraspinatus, infraspinatus, the teres minor and subscapularis. So what is lift-off test? This is, imagine you are internally rotating the arm and touching the dorsal surface of the hand with your back. Now you try to lift this off the back. You try to lift the hand off the back. Now this thing is possible in case of normal individuals, but in case there is a subscapularis injury, complete tear to the subscapularis tendon, then the patient won't be able to perform this Gerby test, also known by the name of lift-off test. So this obviously is not a test for anterior dislocation of the shoulder, right? So don't worry, this Gerby test actually was asked back in 2007 examination when it was AIMS examination, right? Okay, hopefully you get the answer for this question straight away. Simple. Next question is that which of the following is false about the X-ray findings of scurvy? Now, whenever you get a question related to scurvy, the only thing that they used to ask repeatedly is the X-ray findings of this scurvy. Now, let's talk about option wise. One is a dense line between the metaphysis and the epiphysis cartilage. Now, just try to understand. This is a distal end of the femur, for example, and this is the epiphysis of the distal femur. Now, the zone of provisional calcification in the growth plate, this zone of provisional calcification, which is nearer to the epiphyseal end, it gets denser. And this condition is known as white line of Frankel. And this white line of Frankel is a feature of, this actually is the feature of scurvy. All right. Where there is increase in the concentration, increase in the density of the, or increase in the calcification of the zone of the provisional calcification of the growth plate. Next, so this obviously, yes, it is true. It is a feature of scurvy. Second, a clear bend of rarefaction on the diaphyseal side. You know, on the diaphyseal side, there is actually the subperiosteal resorption as it happens in case of hyperparathyroidism, the similar kind, all right, which results in the pencil-shaped diaphysis. So this also is a feature of scurvy. Then metaphyseal corner fracture. You know, these are the split ends of the metaphyseal end which are fractured. This also is a feature. Apart from this, Pelkan's spur, where there is a pointed conical outpouchings of the bone at the end of the metaphyseal. This is also a feature of scurvy. So as you can see, all the first three ones are the feature of this scurvy. Now here we are having a pelvic brim sign. You know, pelvic brim sign is actually a feature of osteitis deformans. That means Paget disease. It is a feature of Paget disease where there is increase in the density of the iliopectineal line. So what is Paget disease? It is increase in the density of iliopectineal line, and this is known as brim sign, iliopectineal line, right? That is Brim sign for Paget's. So obviously, which of the following is false? So option D is false for the X-rays of the scurvy. Remember, scurvy, vitamin C deficiency, lack of cofactor required for lysine and proline hydroxylation, resulting in scurvy, the defective form of the type 1 collagen formation. And every time you get the question related to scurvy, it is in the form of the X-rays, right? Next question, a long question, clinical question. A 3-month-old girl is brought to the office by her mother for the routine examination, right? Pregnancy was complicated by fetal macrosomia and the patient was born at the term via uncomplicated cesarean delivery. Now she appears well. She is 80 percentile for the length, 90 for the weight. That means within normal limits. Now the patient is placed in the supine position with the hips and the knee flexed. Hopefully you are able to imagine how the patient is laid on the couch. Imagine this is the head, this is the trunk of the patient, and these are the hip joints. So hip joint and the knee joint, they are flexed and the feet are kept on the couch again like this. This is how the patient is placed. Now the feet placed flat on the examination table. Now the left knee is lower than the right knee. Now as you can see that the level ideally should be equal. Both the knees should be equal at the same level if there is no abnormality at the level of knee, thigh or the hip joint. But here what is happening? The left knee is lower compared to the right one. Left knee is lower compared to the right one. Actually, this is what? This is Galeazzi sign positivity. This actually is the Galeazzi sign positive. And all of you know that the Galeazzi sign positive is a feature of developmental dysplasia of the hip joint. The left knee is lower than the right knee. This is Galeazzi sign positive. And this is a feature of developmental dysplasia of the hip joint. Now the feet shows no deformity. Which of the following is the most appropriate next step in the management? Now here, there is a rise in the suspicion that the patient could be suffering from developmental dysplasia of the hip joint. And in case of infants, the best investigation to come up with the answer is the ultrasonography of the left hip. Why ultrasonography? Why not X-rays? Because X-rays, both the acetabulum and the head of the femur at this age of 3 months are cartilaginous. You cannot see them on the X-rays. Why not MRI? Placement of the child in the MRI machine is most difficult. Alright, why do you want to schedule the next routine physical examination despite the fact that you are already suspicious that the patient could be having DDH? So better to diagnose it as early as possible with the findings of alpha and beta angle. Alpha angle less than 60, beta angle more than 55 degrees. If there is an abnormality, it is suggestive of developmental dysplasia of the hip joint. And ultrasonography of the left hip is considered to be the screening investigation of choice. It is the screening investigation of choice in case of a newborn for DDH. Alright, because on X-rays, the cartilaginous acetabulum and cartilaginous head of the femur are not visible. So you cannot conclude it. So hopefully everything is clear related to the session. Hopefully you have enjoyed the session. You have learned something new. Hopefully it gives you much confidence it makes you confident enough for marking the correct answers. It makes you confident enough that you are ready to appear in the next examination. Thank you very much. All the best for your exams.
Okay, doctors. Now we'll continue with obstetric and gynec part of the CBoT 4. Okay. Now first question. The question is on preterm labor. It's a repeat question from INI-CET. A 30-year-old primigravida with 7 months of amenorrhea presents with labor pains. All the following are the diagnostic criteria for preterm labor except. Understand? The question they were asking on diagnostic criteria for preterm labor. So now before coming back to this question, just we'll look into the what is the ACOG criteria for diagnosis of preterm labor and what are the other diagnostic criteria for what preterm labor. We'll look into that. Now, doctor, so now look into this. This preterm labor can be established preterm labor and threatened preterm labor. And you all know, dear doctor, so threatened preterm labor is nothing but, so uterine contractions are perceived in the absence of cervical changes. You got my point, doctor? So uterine contractions are perceived in the absence of cervical changes is nothing but what? Threatened preterm labor. So it can be cervical dilatation of 1 to 2 centimeter or cervical length more than 2 centimeter. Yes, yes, that is threatened preterm labor. Now, what is this established preterm labor? Take down as per ACOG. Take down, dear doctors, as per ACOG. What is this established preterm labor? And as per other criteria, what is this established preterm labor? Now, as per ACOG, it is nothing but regular uterine contraction accompanied by progressive dilatation and effacement of cervix. You got my point, doctor? Take down. So, regular uterine contractions accompanied by, please make a note of it, accompanied by progressive dilatation and what? Effacement of cervix. Accompanied by progressive dilatation. Please make a note of it. Progressive dilatation and effacement of cervix. Effacement of cervix. Yes, yes, this is the one definition as per ACOG. What is the other definition as per ACOG? That is, take down, doctor, regular uterine contraction with dilatation of cervix at least 2 centimeter. You got my point, doctor? Regular uterine contraction with the dilatation of cervix at least 2 centimeter on initial presentation. Take down regular uterine contractions. Yes, regular uterine contractions with dilatation of cervix. With dilatation of cervix of at least 2 centimeter. That is important MCQ on initial presentation. On what, doctors? So, initial presentation. On initial presentation. Yes, yes, this is as per ACOG, But what are the other diagnostic criteria for preterm labor? Yes, that is, take down, doctor, contraction frequency, important MCQ, contraction frequency of, how much? What is the contraction frequency of? That is more than or equal to 4 contractions in 20 minutes. That is very, very important MCQ. More than or equal to 4 contractions in 20 minutes or more than or equal to 8 contractions in 60 minutes. Please make a note of it. Very, very important point. So, more than or equal to 4 contractions in 20 minutes or more than or equal to 8 contractions in 60 minutes with any one of the following. With any one of the following. Yes. What is that any one of the following? That is cervical dilatation more than 3 centimeter. Take down. So, cervical dilatation, cervix dilatation more than 3 centimeter. Yes, more than or equal to 3 centimeter. That is one point. Or cervix length less than 2 centimeters on TVS. Cervix length less than 2 centimeters on TVS. On TVS. You got my point, dear doctors? So, cervical dilatation more than 3 centimeters or more than 2 centimeters also, and cervix length less than 2 centimeters on TVS. If, or another one, if cervix length is 2 to 3 centimeter, we will look for fetal fibronectin positive in cervico-vaginal secretions. You got my point? So, these are all the diagnostic criteria for diagnosis of preterm labor. Understood, doctor? One important thing you should know this, very, very important. That is more than 4 contractions in 20 minutes or more than 8 contractions in 60 minutes with any one of the following. What is it? Any one of the following: cervical dilatation more than 3 centimeter and cervical length less than 2 centimeter on TVS. And if cervical length is 2 to 3 centimeter, we will search for, or we will look for fetal fibronectin in cervicovaginal secretion. We look for fetal fibronectin in cervicovaginal secretion. Yes, yes. Now we'll come back to this question. So what all the thing? So 4 contraction in 20 minutes and 8 contraction in 60 minutes with changes in the cervix. Definitely it's a true statement. Yes. Cervical dilatation more than 2 centimeter. Definitely it's a true statement. And even effacement of cervix 80%. That is another one also. You got my point, doctor? You can add that point also. So that is effacement with any one of the following. That is effacement of 80% also one of the criteria. So definitely that is also true statement. That is also true statement. And cervix posterior in position. Now position of the cervix is definitely not a diagnostic criteria for diagnosis of preterm labor. Definitely it is a false statement. Definitely it is a false statement. I think this is clear, doctor. Yes, yes. So now we'll proceed to the next question. Yes, okay. So now look into this. All of the following are true statements regarding multifetal pregnancies, except that is all DCDA twins are dizygotic, all monochorionic twins are monozygotic. Monozygotic twins can be either dichorionic or monochorionic. All dizygotic twins are dichorionic. Now doctor, you should know first of all what is this zygosity. Please make a note of it. What is this zygosity and what is this chorionicity? You please understood of what is this chorionicity. So just I'll write in the next slide. So first we look into this. What is this zygosity? Yes. And what is this chorionicity? Now dear doctors, zygosity is nothing but type of conception. Please make a note of it. It's a type of conception. Zygosity is nothing but type of conception. Chorionicity is nothing but type of placentation. Type of placentation. So zygosity is type of conception. Chorionicity is type of placentation. Now between zygosity and chorionicity, it is a chorionicity which will decides the prognosis. Which will decides the prognosis. You got my point, okay? It is the chorionicity which will decides the prognosis. And best time to determine chorionicity during pregnancy is 11 to 13 weeks plus 6 days. You got my point, doctor? Best time to determine chorionicity during pregnancy is 11 to 13 weeks plus 6 days. And zygosity can be 2 types. One is dizygosity. Yes. One is dizygosity. Another one is monozygosity. You got my point, doctor? One is dizygosity. Yes. Another one is monozygosity. Please make a note of it. Monozygosity. Now, we look into dizygotic twins and monozygotic twins. Doctor, so dizygosity is nothing but it is fertilization of 2 ova by 2 sperms. You got my point, doctor? It is nothing but fertilization of 2 ova by 2 sperms. Fertilization of 2 ova by 2 sperms. Monozygosity is nothing but it's a splitting of single fertilized ova. Splitting of single fertilized ova. You got my point, doctor? And between dizygotic twins and monozygotic twins, dizygotic twins is the most common variety. So means 2/3 twins are dizygotic and 1/3 twins are monozygotic. Means 70% twins are dizygotic and 30% twins are monozygotic. You got my point, doctor? So dizygosity is nothing but fertilization of 2 ova by 2 sperms. Fertilization of 2 ova by 2 sperms. And monozygosity, it is a splitting of single fertilized ova. Yes. And between zygosity and chorionicity, which will decides prognosis, it is the chorionicity which will decide the prognosis. Yes. Yes. Now we look into this. Now I was telling you, it's a fertilization of 2 ova by 2 sperms. That's why. So dizygotic twins always, that is 100% dichorionic, always 100% dichorionic and diamnionic. You got my point, doctor? Dizygotic twins, yes, 100% dichorionic and diamnionic, that is DCDA. Very, very important MCQ. Now, I was telling you monozygotic twins is nothing but splitting of single fertilized ova. Now, the time, you make a note of it, very, very important, the time at which the fertilized ova will split. I was telling you it is a splitting of single ova is monozygosity. The time at which the fertilized ova will splits will decide the chorionicity. You got my point, doctor? The time at which the fertilized ova splits will decide the chorionicity. Now, if it splits before 3 days, it is dichorionic, diamnionic. You got my point, doctor? If it splits before 3 days, it is dichorionic, diamnionic. If it splits between 4 to 8 days, it is monochorionic, diamnionic. You got my point, doctor? If it splits between 4 to 8 days, it is monochorionic, diamnionic. And if it splits between 8 to 13 days, it is monochorionic, monoamnionic. If it splits between 8 to 13 days, it is monochorionic, monoamnionic. And if it splits more than 13 days, yes, it is conjoined twins. It is conjoined twins. You got my point, doctor? Yes. So, overall most common chorionicity. You got my point, doctor? So, I told you in dizygotic twins, all dizygotic twins are DCDA. You got my point, doctor? All dizygotic twins are DCDA. And come to monozygotic, it is the time at which the fertilized ova splits will decide chorionicity. If it splits before 3 days, it is DCDA. Yes. If it splits between 4 to 8 days, it is MCDA. And if it splits between 8 to 13 days, is MCMA. And more than 13 days is conjoined twins, which is nothing but Siamese twins. And what is the most common chorionicity of monozygotic twins? Most common chorionicity of monozygotic twins is MCDA. And overall most common chorionicity. So, what is the overall most common chorionicity, dear doctors? Yes, it is the DCDA. Why? Because it is the dizygotic twins which is more commoner than monozygotic twins. Yes. So, most common chorionicity of monozygotic twins is MCDA. And overall most common chorionicity is what, doctor? DCDA. And another important point, doctor, so you should remember, that is, so this chorion will be formed by day 8 after fertilization. Please make a note of it. Chorion is formed by day 8 after fertilization, and amnion will formed by, amnion is formed by day 10 after fertilization. Please make a note of it. Chorion is formed by day 8 after fertilization, and amnion is formed by day 10 after fertilization. Now, little more in depth of chorionicity. I was telling you, so this, if the ova, if the fertilized ova splits before 3 days, please make a note of it. This is the ova, yes, which is splitting before 3 days, yes. So, now it is splitting before 3 days. Now, by day 8, each zygote have their own chorion. By day 8, each zygote will have their own chorion, yes. And dear doctors, and by day 10, each zygote will have their own amnion. You got my point, doctor? So, by day 10, so each zygote will have their own amnion. Means, please make a note of it. So, if the zygote splits before, that is, if the fertilized ova splits before 3 days, definitely by day 8, each zygote will have their own chorion. Yes, in the same way, dear doctor. So, and by day 10, yes, each zygote will have their own amnion. Yes, that's why it is DCDA. It is DCD. Yes, yes. Now, if it splits between 4 to 8 days, if it splits between 4 to 8 days, definitely by day 8 already chorion is formed. By day 8 already chorion is formed. Now it is splitting. Now that's why both the zygotes will have a common chorion. Both the zygotes will have a what, doctor? Common chorion. And by day 10 each zygote, by day 10 each zygote, yes, will have their own amnion. By day 10 each zygote will have their own amnion, that is monochorionic and diamnionic. Monochorionic and diamnionic. And if it splits between 8 to 13 days, if it splits between 8 to 13 days, definitely, dear doctors, by day 8, yes, chorion is already formed, yes, and by day 10, amnion is already formed. Now it is splitting. Now it is splitting means, yes, so both the zygotes will have a common chorion and common amnion. Both the zygotes will have a common chorion and what, doctor? Common amnion, that is MCMA, MCMA. Understood, doctor? And if it splits more than 13 days, dear doctors, if it splits more than 13 days, definitely some fetal structure will be formed. So now that is splitting means definitely it leads to what? Conjoined twins. It leads to what, doctor? Conjoined twins. Nothing but Siamese twins. Nothing but Siamese twins. Siamese twins. Yes, yes. Now come back to the question. Dear doctors, come back to the question. All DCDA twins are dizygotic. Please make a note. It is a true statement or false statement? Definitely it is a false statement, because please make a note of it. DCDA twins can be dizygotic also, monozygotic also. That's why it is a false statement. And all monochorionic twins are monozygotic. Definitely it is a true statement. Yes, monochorionicity is always seen in monozygotic twins only. It is not seen in dizygotic twins. That's why monochorionicity always limited to monozygotic twins. Yes, yes, that is also true statement. Monozygotic twins can be either dichorionic or monochorionic. Definitely it is true statement. Yes, so means in monozygotic twins we can see dichorionicity also, monochorionicity also. Definitely it is a true statement. And all dizygotic twins are dichorionic. I was telling you 100%. Yes, 100% dizygotic twins are dichorionic. No doubt at all. No doubt at all. Yes, it is a true statement. And doctor, few golden points on dichorionic, monochorionic and monoamniotic twins. So please make 3 columns. Very, very important MCQ, dear doctors. So they can ask you questions on this. Now I was telling you DCDA. Make 3 columns: DCDA, MCDA, MCMA. And I was telling you DCDM is dichorionic and what, doctor? Diamnionic. Means each zygote will have their own chorion. Will have their what, doctor? Own chorion. Please make a note. Each zygote will have their own chorion and each zygote will have their own amnion. Each zygote will have their own amnion. Now, doctor, here the placenta. This is the placenta. Dear doctor, this placenta will have a triangular projection between the 2 twins. You got my point, doctor? This placenta can have a triangular projection between the 2 fetuses. Now come to MCDA. Now, doctor, in this MCDA, yes, both the zygotes will have a common chorion. Both the zygotes will have a common chorion and so both the zygotes will have their own amnion. Means each zygote will have their own amnion. That is MCDA. And here the placenta won't have triangular projection. Means here the placenta is perpendicular to the fetal surface. Here the placenta is perpendicular to the fetal surface. In MCMA also, dear doctors, so both the zygotes will have a common chorion and common amnion. Common chorion and common amnion. Yes. Yes. So that's why these MCDA twins, they are called as monochorionic twins. MCDA twins, they are called as monochorionic twins. MCMA twins, they are called as monoamniotic twins. Monoamniotic twins. And DCDA, they are called as dichorionic twins. Dichorionic twins. Now on USG, the number of gestational sacs in DCDA is 2. Please make a note of it. On USG, the number of gestational sacs on USG is 2. In monochorionic and monoamniotic, the number of gestational sacs will be 1. Monochorionic and monoamniotic, the number of gestational sacs will be what, doctor? 1. Now, doctor, if you see this, the intertwin membrane, very, very important MCQ. Please make a note of it, intertwin membrane. See, so this is the intertwin membrane. Please make a note of very, very important MCQ. This intertwin membrane will be thick. Yes, that is more than 2 millimeters, more than 2 millimeters. And doctor, please make a note of it. So this is the intertwin membrane. Please make a note of it. This is the intertwin membrane. So here the intertwin membrane will be thin. Intertwin membrane will be thin, that is less than 2 millimeters. And here if you see, there is no intertwin membrane. Intertwin membrane is absent in MCMA. Understood, doctor? Thick intertwin membrane in DCDA, yes. Thin intertwin membrane in MCDA, yes. And no intertwin membrane in MCMA, yes, yes. Now come to number of layers. Please make a note of the number of layers in intertwin membrane in DCDA. You can see how many layers, doctor? This is the 1, this is the 2, 3, 4. So 4 layers. Yes, definitely 4 layers in DCDA, that will be thick, more than 2 millimeters. And number of layers in intertwin membrane in MCDA means we can see only 2 layers. We can see only 2 layers. Means here 4 layers, that is 2 chorion plus 2 amnion. Here only 2 amnion. So now you people will confuse. Sir, MCDA means monochorion, that is 1 layer, and diamnion means 2 layers. So it should be 3 layers. No. Means that's why you should draw the diagram. So here this is an intertwin membrane. So here the intertwin membrane will be only 2 layers. And so only 2 amnions, no chorion. Okay. So that's why it is thin. That's why less than 2 mm. And number of layers, I told you no intertwin membrane in MCME. Definitely that is there. So now fetal sex. Fetal sex, and you all know, dear doctors, dichorionic twins can be either concordant or discordant. Understood? They can have same sex also, but they can have same sex also they can have different sex also. Means they can have concordant sex also, they can have discordant sex also. You got my point, doctor? So dichorionic twins can have same sex also, different sex also. If this come to MCDA and MCMA, they always will have concordant sex. Please make a note of it. They always will have concordant sex, that is same sex. You got my point, doctor? They will always will have concordant sex. What is that? Same sex. But dichorionic twins will have either same sex or different sex. You got my point, doctor? Dichorionic twins will have either same sex or different sex. But monochorionic, that is MCDA or MCMA, they will always have same sex. They will always have same sex. Now, dear doctors, on USG, in DCDA, we can see triangular projection of placental tissue in between 2 fetuses. What is that sign called as? Twin peak sign or lambda sign or delta sign. Twin peak sign or lambda sign or delta sign. What is that twin peak sign or lambda sign or delta sign? That is, take down, doctor, triangular projection. Please make a note of it. Triangular projection of placental tissue. Please make a note of it. Triangular projection of placental tissue between 2 fetuses from placental surface. Between 2 fetuses from placental surface. Between 2 fetuses from placental surface. What is that sign called as? Twin peak sign or lambda sign. Now, if you come to MCDA, here if you see this, there is no triangular projection. Please make a note of it. No triangular projection. Means here the fetal membranes, please make a note of it. Here the fetal membranes are perpendicular to the placental surface. Here the fetal membranes are perpendicular to the what, doctor? Placental surface. What is that sign called as? Yes, it is a T sign. T sign. T sign. Please make a note of it. T sign. That is fetal membranes ending perpendicular to placental surface. Take down, doctor. Fetal membranes ending fetal membranes ending perpendicular to placental surface. Fetal membranes are ending perpendicular to placental surface. Yes, yes, this is T sign, which is diagnostic of MCDA, and here also in MCMA no T sign, no T sign. Now come to number of placenta, and I was telling you, doctor, this DCDA twins can come from dizygotic also, can come from monozygotic also. I was telling you in the beginning of this class. So DCDA twins can come from dizygotic also, yes, monozygotic also. If it comes from dizygotic twins, definitely 2 separate placenta. If it comes from dizygotic twins, yes, definitely it is 2 separate placenta. 2 separate placenta. And if it comes from monozygotic, it is single fused placenta. It is single fused placenta. And MCD and MCMA, definitely it is from single ova, definitely they will have what, doctor? Single placenta, single placenta. And doctor, so come to the complications. There is no specific complications for DCDA. And MCDA, we have got 2 specific complications. One is twin to twin transfusion syndrome, and another one twin reversal arterial perfusion. You got my point, doctor? One is twin to twin transfusion syndrome. Please make a note of it. Twin to twin transfusion syndrome. Twin to twin transfusion syndrome. And another one, twin reversal arterial perfusion. Twin reversal arterial perfusion. Twin reversal arterial perfusion. Yes, yes. And what is the specific complication for MCMA? That is cord entanglement. What is that? The specific complication for MCMA? Cord entanglement, because both fetuses are lying in the single amniotic cavity. That's why one umbilical cord of one twin will entangle with umbilical cord of other twin. Yes, yes. So now another important difference. So this is the one thing we can see this. Dear doctor, we can see this. This is the triangular projection. We can all make it of it. You can all make it of it. This is the triangular projection of placental tissue. Please make a note of it. This is the triangular projection of placental tissue between 2 fetuses from placental surface. Please make a note of it. This is the triangular projection of placental tissue between 2 fetuses from placental surface. What is that sign called as? Twin peak sign, yes, or lambda sign. Twin peak sign or lambda sign or delta sign Yes, yes. Now we'll go to timing of delivery. When you want to deliver this DCDA twins, when you want to deliver this MCDA, and when you want to deliver this MCMA. And DCDA twins, yes, it will be, that is uncomplicated DCDA twins, definitely will plan to deliver around 38 weeks. Please make a note of it. Uncomplicated DCDA twins definitely will plan to deliver around 38 weeks. And uncomplicated MCDA, yes, definitely will plan to deliver around 34 to 37 weeks. Around 34 to 37 weeks. But this MCMA, we will do elective C-section around 32 to 34 weeks. MCMA, we will do elective C-section around 32 to 34 weeks. Elective C-section around 32 to 34 weeks. You got my point, doctor? Uncomplicated DCDA definitely around 38 weeks. Yes. MCDA 34 to 36 weeks. Yes. MCMA definitely elective cesarean section around 32 to 34 weeks. Around 32 to 34 weeks. And vascular communication, that is vascular anastomosis. Yes, definitely vascular anastomosis is the feature of monochorionic twins. Please make a note of it. Vascular anastomosis will be the feature of monochorionic twins. That is deep vascular anastomosis. Deep vascular anastomosis will be seen in MCDA. Yes. And superficial vascular anastomosis. Superficial vascular anastomosis will be seen in MCMA. So you got my point, doctor? Yes, yes, that is deep vascular anastomosis. Most common type of deep vascular anastomosis is nothing but artery to vein, that is umbilical artery to umbilical vein. And most common superficial vascular anastomosis is nothing but artery to artery, artery to artery. That's why deep vascular anastomosis always leads to twin to twin transfusion syndrome. This is very, very important MCQ. Please make a note of it. Make a note of it. Understood, doctor? Deep vascular anastomosis definitely most commonly seen in MCDA. Yes, which is of artery to vein anastomosis, which leads to twin transfusion syndrome. Yes, and superficial vascular anastomosis. Yes, it is artery to artery. That is umbilical artery to umbilical artery. That's why no TTS. No TTS. Yes, yes. Now you can all get doubt. Sir, what is this vascular anastomosis or what is this vascular communication? In simple words, so you all know in monochorionic, that is either MCDA or MCMA, you will have a single placenta. Yes, yes or no? This is a single placenta. In both the types, we'll have a single placenta. Now in single placenta, two umbilical cords will be inserted to single placenta. You got my point, doctor? Two umbilical cords will inserted to what, doctor? Single placenta. Now this umbilical cord will have two umbilical arteries. Yes, two umbilical arteries. So each umbilical cord will have two umbilical arteries. Yes, and one umbilical vein. So each umbilical cord will have two umbilical arteries. Yes, and one umbilical vein. So this is a vein and this is a artery. Now doctor, look into this. So this artery can anastomose with this vein. Yes, this artery can anastomose with this artery, or this artery can anastomose with this vein. Now see, this is the vascular anastomosis. That's why this vascular anastomosis is the feature of what, doctor? Monochorionic. In general, I am telling you. So vascular anastomosis is the feature of monochorionicity. That too, deep vascular anastomosis is the feature of MCDA, and superficial vascular anastomosis is the feature of what, doctor? MCMA. And which vascular anastomosis leads to twin transfusion syndrome? It is a deep vascular anastomosis, that is artery to vein. These are all the MCQs. Yes, yes. Okay, doctors, I think this is enough. Now we'll proceed to the next question. Very nice question. A 28-year-old female presented to the endocrinology clinic with history of recurrent abortion or HSC found to be having septate uterus. What is the best modality of treatment? Definitely it's a straightforward and you can easily answer. Definitely it is a hysteroscopic septoplasty. Hysteroscopic septoplasty. Now doctor, so now before coming back to this question, you all know our Mullerian anomalies, the Mullerian anomalies are numbered or fixed numbered by our American Society of Reproductive Medicine. Yes, ASRM has given fixed number for all the Mullerian anomaly. Now we look into this. What is that number 1 Mullerian anomaly as per ASRM? That is segmental agenesis. Please make a note of it. Segmental agenesis. That is the number 1, segmental agenesis. Yes. So that is this segmental agenesis can be fundal agenesis. Take down fundal agenesis or cervical agenesis or vaginal agenesis. Vaginal agenesis. This is a ASRM number 1 Mullerian anomaly, that is segmental agenesis. Yes. Then number 2, dear doctors. So number 2, yes, it is the unicornuate uterus. Number 2, it is the unicornuate uterus. Number 3, uterus diadelphys. Uterus diadelphys. Number 4, dear doctors, number 4, bicornuate uterus. Number 4, bicornuate uterus. Then number 5, yes, septate uterus. Septate uterus. Number 6, arcuate uterus. Number 7, yes, drug related anomaly, that is DES exposure, diethylstilbestrol exposure. So drug related anomaly. Drug related anomaly. Yes. So, diethyl stilbestrol. Diethyl, yes, stilbestrol. Diethyl stilbestrol exposure. So, these are all the ASRM numbered Mullerian anomaly. Number 1 is segmental agenesis, number 2 is unicornuate, number 3 is diadelphys, number 4 is bicornuate. Always you should remember the number 4, very, very important. So, the number 4 bicornuate, number 5 is septate, number 6 is arcuate, number 7 is drug related. Now come to the management of each anomaly. Now come to unicornuate and bicornuate, definitely no surgery is required. Please make a note of it. Important MCQ, unicornuate and bicornuate, mostly, not definitive treatment, I am telling you, mostly no surgery. Because why no surgeries? Because repeated pregnancies distance the uterine cavity, leads to live viable delivery. And so first time she conceives with unicornuate uterus, she will abort around 10 weeks. Once again, second time she will abort around 22 weeks. Third time she will have a live viable delivery around 29 weeks. Means repeated pregnancies, please make a note of it. Repeated pregnancies, yes, distance the uterine cavity. Repeated pregnancies distance the uterine cavity, leads to live viable delivery. Leads to live viable delivery. Leads to live viable delivery. Understood, doctor? If at all you want to do surgery for bicornuate, you can do one surgery. So, bicornuate means you will have two arms. So, you can unify both the arms. What is that unification of both arms called as? Metroplasty. What is the name given to that metroplasty? Strassmann metroplasty. Take down, doctor. Unification of both arms. What is that unification of both arms called as? Metroplasty. What is the name given to that metroplasty? Strassmann metroplasty. Strassmann metroplasty. Strassmann metroplasty. Yes, this is about unicornuate and bicornuate. Mostly, I am not telling you definitive. So, mostly surgery is not recommended. Yes, because repeated pregnancy definitely, yes, leads to distension of the uterine cavity, finally end up with live viable delivery. Bicornuate, you can go for unification of both arms, that is metroplasty. So, now doctor, septate, definitely we can go for hysteroscopic septal resection. We can go for hysteroscopic, please make a note of it. We can go for hysteroscopic septoplasty or septal resection. Hysteroscopic septal resection. And arcuate uterus, you all know. So, arcuate uterus is more commoner than, yes, uterus diadelphys. Most common Mullerian anomaly will be, which is the most common Mullerian anomaly will be, definitely it is what? Septate. So, arcuate uterus, yes, and followed by uterus diadelphys. Uterus diadelphys, please make a note of it. Arcuate uterus followed by uterus diadelphys, they are all least symptomatic. So, least symptomatic will be arcuate followed by uterus diadelphys. Please make a note of it. They are all the least symptomatic but best reproductive outcome. Best reproductive outcome. Best reproductive outcome. You got my point, doctor? So, which is the least symptomatic Mullerian anomaly? First least is arcuate, second least is uterus diadelphys. Which is the best reproductive outcome anomaly? First best is arcuate, second best is what? Diadelphys. That's why this arcuate and diadelphys, they are all the least symptomatic or best outcome. That's why no surgery. Yes, definitely if any anomaly is symptomatic, then only we are going to do surgery. If these arcuate or diadelphys, definitely they are not symptomatic, means why you want to do surgery? Definitely least symptomatic, best outcome, definitely no surgery is recommended, no surgery. And management for septate uterus is what, doctor? Hysteroscopic septal resection. Hysteroscopic septal resection. Yes. Now come to this question. 28-year-old primigravida came at 32 weeks POG. Yes, what is the period of gestation, doctor, here? Period of gestation is 32 weeks. Yes, so came with history of severe and constant pain and with history of bleeding pain. Bleeding per vaginum means it is painful vaginal bleeding. It is painful vaginal bleeding. Please make a note of it. It is painful vaginal bleeding. On examination, uterus is tender to touch. Mild uterine contractions are present. Means there is tenderness. Tenderness. Fetal heart rate is 155 per minute with variable acceleration, not deceleration. Please look into the question. With variable acceleration and no deceleration. How will you manage this case? Now, definitely it is antepartum hemorrhage. Antepartum hemorrhage. Now, doctor, in this antepartum hemorrhage, you can have three varieties. One is placenta previa, another one is abruption, another one is vasa previa. Understood, doctor? So, among this placenta previa and abruption, so this diagnosis definitely goes to what, doctor? Abruption. Why abruption, doctor? Here in abruption there is painful vaginal bleeding, But in placenta previa it is a painless vaginal bleeding, What is this abruption? It is nothing but premature separation of normally situated placenta. Please, you should understand. That word is very important. So, premature separation of normally situated placenta after viability but before delivery. That is nothing but placental abruption. Please take down that definition. Please, very, very important. What is this? Placental abruption. Very important MCQ. Premature separation of normally situated placenta. Premature separation of normally situated placenta. So, what is the normal location of placenta? Yes, fundus. Normally situated placenta after viability but before delivery. After viability, yes, but before delivery. Yes. Now, just we look into the few golden features of placenta previa and abruption. Yes, take down. So, now I was telling you placenta previa is a painless, causeless, recurrent bleeding. Very, very important MCQ. It is a painless, yes, causeless, recurrent bleeding. But in abruption, it's a painful vaginal bleeding. Definitely there is a cause and definitely it is a recurrent. Please make a note of it. You got my point, doctor? So, in abruption, it is a painful vaginal bleeding. There is a cause. Either it can be a hypertension or either it can be a abruption. So, either it can be a polyhydramnios, that is uterine overdistended. Yes. So, cause is there for abruption and it is not recurrent. You got my point, doctor? So, placenta previa is painless, causeless, recurrent bleeding. But abruption, definitely it's a painful, cause is present, yes, and it is not recurrent. Please, sorry, it is not recurrent. And you all know in concealed variety, doctor, in concealed variety, the blood accumulates behind the placenta. You understood point? So, in concealed type of abruption, the blood accumulates behind the placenta. That is retroplacental clots. What is that called as? RP clots. Retroplacental clots. In concealed, the blood is concealing, that is hiding behind the placenta. The blood is concealing, that is hiding behind the placenta. That is retroplacental clots. Now, doctor, from this retroplacental clots, there is release of two things. One is thromboplastin. Please make a note of it. One is thromboplastin. Another one is thrombin. One is thromboplastin. Another one is thrombin. Doctor, this thromboplastin and thrombin, they are all uterotonics. They are all uterotonics, means they will cause uterine hypertonia and tetanus. Uterotonic. This thromboplastin and thrombin, they are all uterotonics. That is uterine hypertony plus tetany. Uterine hypertony plus what, doctor? Tetany. You got my point, doctor? So, this thromboplastin and thrombin, they will cause uterine hypertony and tetany. That's why the uterus will be tender, tense and rigid. You got my point, doctor? Thromboplastin is there, thrombin is there, yes. So they will increase the tone of the uterus, that is hypertonic and tetanic. So uterus will be tense, tender and rigid. Tense, tender and rigid. And fetal parts are, yes, definitely, so not easily felt. Fetal parts are not easily felt. Why not easily felt? Because definitely, why it is? It's a tense uterus, tensed uterus. Now come to placenta previa. It is a painless, causeless and recurrent. Why it is a painless? Because there is no evidence of thromboplastin or thrombin. Understood, doctor? No evidence of thromboplastin, no evidence of thromboplastin or thrombin. That's why there is painless. That's why uterus is soft and relaxed. Uterus is soft and relaxed, and fetal parts are easily felt. Fetal parts are easily felt, yes. Now this is about the bleeding pattern. So painless, causeless, recurrent, painful, yes, cause is there, not recurrent, that is abruption. Now come to color of the blood. Now doctor, in placenta previa it is a bright red. Placenta previa it is a bright red, yes. So abruption will be dark colored because it's a collected blood which is coming out. It is a dark colored, yes, yes. And warning hemorrhage, definitely it is the feature of placenta previa. You got my point, doctor? So warning hemorrhage, it is the feature of what, doctor? Placenta previa. What is that warning hemorrhage? So prior to the heavy bleeding, there will be small episodes of bleeding. That is warning hemorrhage. Small episodes of bleeding. Please make a note of it. Small episodes of bleeding prior to heavy bleeding. Prior to heavy bleeding. Small episodes of bleeding prior to what, doctor? Heavy bleeding. Understood, doctor? Here in abruption, no history of warning hemorrhage. No history of warning hemorrhage. It's a single bout and continuous. You got my point? It's a single bout and continuous, not recurrent. Understand? But in placenta previa, prior to heavy bleeding, there will be single episodes of bleeding prior to heavy bleeding. But in abruption, it's a single bout, yes, which is a continuous but not recurrent. Which is a continuous but not recurrent. Yes, yes. Now come to this. So now in placenta previa, bleeding is always revealed outside. Whatever the blood inside the uterus, it is coming out. Please make a note of it. So whatever the blood inside the uterus, definitely it is coming out. That's why uterine size corresponds to POG. Please make a note of it. Uterine size corresponds to POG in case of placenta previa. Yes. And pallor, definitely it is proportionate to blood loss. Pallor, it is proportionate to blood loss. Proportionate to blood loss means whatever bleeding which is occurring inside the uterus, it is coming out. It is not concealing. That's why the fundal height corresponds to POG, pallor proportionate to blood loss. But in abruption, you all know the most common variety of abruption is what, doctor? Revealed variety. That's why bleeding mostly revealed. I was telling you, most common type of abruption is revealed. That's why bleeding mostly revealed, but sometimes concealed. But sometimes concealed and mixed. In concealed variety, doctor, concealed variety, the uterine size. In concealed variety, the uterine size is bigger for gestational age. You got my point? So in concealed variety, yes, uterine size is bigger for gestational age, and the pallor, definitely it's a out of proportion, and pallor, definitely it's a out of proportion. Yes, yes, this is about uterine size and pallor. Now come to presenting part. Now I was telling you, dear doctor, in placenta previa, dear doctor, in placenta previa, yes, the placenta will be covering the lower uterine segment. Definitely fetal head cannot descend into the pelvis. That's why presenting part will be mobile. Presenting part will be mobile and high. The presenting part will be mobile and high means the presenting part will have unstable lie. And this unstable lie definitely leads to, malpresentation. This unstable lie leads to malpresentation, and most common malpresentation in placenta previa you can see is transverse slide. Most common malpresentation is transverse slide followed by breach. Transverse slide followed by breach. That's why most common cause of transverse slide at a term is placenta previa. That is important MCQ. Please make a note of it. Most common cause of transverse slide. Most common cause of transverse slide. Take down doctor. Most common cause of transverse lie at a term. Most common cause of transverse lie at a term is placenta previa. Why? Because, dear doctor, the presenting part will be high and mobile, which is unstable lie, which leads to what, doctor? Malpresentation. Most common malpresentation will be what, doctor? Transverse lie. Most common malpresentation will be transverse lie. That's the most common cause of transverse lie at a term is placenta previa. Now come to abruption. Definitely most women in abruption they are in labor. Please make a note of it. Most women in abruption they are in labor. That's why the presenting part, please make a note of it, the presenting part will be fixed and engaged. Fixed and engaged. That's why malpresentations are uncommon. Malpresentations are uncommon. Yes, yes. Now come to fetal heart rate or fetal heart sound. Definitely fetal heart sounds are normal and easy to auscultate. Why easy to auscultate, doctors? Because it's a relaxed uterus. It's a relaxed uterus. But in abruption, definitely fetal distress will be there. Definitely fetal distress will be there. That is IUFD can happen. And doctor, fetal heart sounds are difficulty to auscultate. Fetal heart sounds are difficult to auscultate. Fetal heart sounds are difficulty to auscultate because it is a tense tender uterus. And features of preeclampsia definitely will be present in abruption and will be absent in what, doctor? Preeclampsia. Features of preeclampsia will be present in what, doctor? Abruption will be and absent in what, doctor? Placenta previa. And doctor, USG. What will be the USG findings in placenta previa? Definitely placenta will be in the lower uterine segment. Placenta in the lower uterine segment. Placenta in the lower uterine segment. In abruption, definitely on USG, placenta occupies. Where, doctor? That is placenta in the upper segment. Placenta in the upper segment. Yes, yes. And how will you diagnose this placenta previa? Definitely imaging modalities. Definitely what it is? Imaging modalities. How will you diagnose placenta previa? It is imaging modalities. And how will you diagnose abruption? Yes, it is the clinical diagnosis. How will you diagnose abruption? It is the clinical diagnosis. Now, in which type? You can see features of DIC and acute kidney injury. That is, doctor, you all know, definitely features of DIC, yes, and acute kidney injury very commonly seen in abruption. Features of DIC and acute kidney injury very commonly seen in where, doctor? Yes, in abruption. Why? How? Because you all know, doctor, in concealed type of abruption, there is RP clots. What is RP clots? Retroplacental clot. So, in concealed type of abruption, there is RP clots. This RP clots releases two things. One is thromboplastin. Another one is thrombin. Another one is thrombin. Now, doctor, this thromboplastin and thrombin, yes, they will consume clotting factors. Yes. So, when they consume clotting factors, which leads to activation of coagulation cascade. So, this coagulation cascade leads to what, doctor? DIC. That is nothing but consumptive coagulopathy. Yes, definitely this abruption leads to what, doctor? Consumptive coagulopathy. Leads to consumptive coagulopathy. Please make a note of it. This abruption leads to what, doctor? Consumptive coagulopathy. That's why most common cause of DIC in obstetrics is abruption. That is another important MCQ. Take down, doctor. Most common cause of DIC in obstetrics. Important MCQ. Most common cause of DIC in obstetrics, definitely it is abruption. Most common cause of DIC in obstetrics is what, doctor? Abruption. Yes, yes. Now come to management. So management means definitely when to deliver and how to deliver. The safest mode of delivery in placenta previa is elective LACS. Important MCQ. Please make a note of it. Safest delivery of placenta previa is elective LACS. And if she is in labor, definitely will go for emergency. You got my point, doctor? In placenta previa, we will prefer to do elective LACS. If she comes in labor, definitely we'll go for emergency LACS. And doctor, maximum gestational age able to wait in placenta previa, if no complications, definitely till 37 weeks. Please make a note of it. Maximum gestational age able to wait in placenta previa, if no complication, that is 37 weeks. 37 weeks. Now come to management of abruption. See, if it is live fetus, yes, if it is live fetus and mother is in labor, that is if delivery is impending or imminent, we'll go for trial of vaginal delivery or operative vaginal delivery. If not in labor, that is not immediate, we'll go for cesarean section. If it is dead fetus, no brisk bleeding, we'll go for vaginal delivery. If there is brisk bleeding, we'll go for cesarean section. You got my point, doctor? Live fetus, yes, if mother is in labor, that is delivery is immediate, we'll go for trial of vaginal delivery or operative vaginal delivery. If not in labor, if the delivery is not immediate, definitely we'll go for cesarean section. If it is dead fetus with brisk bleeding, we'll go for cesarean. Dead fetus with no brisk bleeding, go for vaginal delivery. Yes, yes. Last but not the least, yes, mode of delivery in abruption, that is what all the indications for vaginal delivery, yes, and what all the indications for cesarean section. Very, very important, doctor. So these are all the golden indications for vaginal delivery in abruption and golden indications for cesarean section in abruption. That is live fetus with reassuring fetal heart rate or dead fetus with stable mother and mild to moderate bleeding. You got my point, doctor? Live fetus with reassuring fetal heart rate. Understood, doctor? Dead fetus with stable mother. You got my point? Live fetus with stable fetus. Yes, you got my understood. Live fetus with stable fetal heart rate. That is the one thing. And dead fetus with stable mother. They are all the indications for vaginal delivery. Cesarean section, non-reassuring fetal heart rate, that is fetal distress, definitely will go for cesarean section. Associated maternal complications like acute kidney injury or a DIC, definitely go for cesarean section. And severe persistent bleeding, definitely go for cesarean section. So these are all the mode of delivery indications. You got my point, doctor? And doctor, another one important regimen in placenta previa, that is McAfee and Johnson regimen, that is expectant management. Please make a note of it. McAfee and Johnson regimen is for expectant management. Please make a note of it. So McAfee and Johnson regimen is for expectant management. What all the indications for McAfee and Johnson? That is gestational age less than 37 weeks. Yes. No active bleeding. Gestational age less than 37 weeks. No active bleeding. Hemodynamically stable mother. Hemodynamically, yes, stable mother. Hemodynamically stable mother. And yes, this NST or CTG should be reactive. You got my point, doctor? Gestational age less than 37 weeks, no active bleeding, hemodynamically stable mother, NST or CTG reactive. Definitely we will go for what, doctor? Expectant management. Definitely we will go for expectant management. Understood? Now, dear doctors, if gestational age more than 37 weeks, yes, active bleeding present. Please make a note of it. Gestational age more than 37 weeks, active bleeding present. Unstable mother, yes, and what, doctor? Reactive fetus, that is fetal, sorry, non-reactive fetus, that is fetal distress. Here we won't go for expectant, we will go for active management, that is we will plan for delivery. We will do active management, that is plan for delivery. Plan for delivery. Yes, yes. Now dear doctors, so we will go back to this question. Here POG is 32 weeks, painful vaginal bleeding. Yes, fetal heart rate is 155 with variable accelerations. Means it is live fetus with reassuring fetal heart rate. Live fetus with reassuring fetal heart rate. We'll go for what? Definitely we'll go for vaginal delivery. That is immediate induction of labor. Immediate induction of labor. Is it clear, doctor? Yes. Yes or no? Yes, doctors? Yes. Very good. Next question. Yes. Very good. A 26-year-old nulliparous woman is being evaluated for endometriosis. Yes. So what is the most common clinical presentation does this woman present to the clinic? Dear doctor, so you all know, as a NEET PG aspirant, you should know, yes, what is this endometriotic triad? We have got 3 symptoms for endometriotic triad. So take down, doctor, what is it? Endometriotic triad, that is dysmenorrhea, yes, dyspareunia and infertility. And most common symptom of endometriosis is dysmenorrhea. Means it can be triple dysmenorrhea, that is pain before menses, during menses and after menses. That is triple dysmenorrhea or congestive dysmenorrhea. That is important MCQ, dear doctors. Yes. And another important MCQ, symptoms do not depend on the size and extent of lesion. It always depends upon 3 things. Please make a note of it. Symptoms do not depend on size and extent of lesion. It always depends upon the depth. Yes, very good. Definitely it always depends upon the depth of the lesion. If it is more than 5 millimeters, yes, they can present with dysmenorrhea or dyspareunia or chronic pelvic pain. Yes, and even this non-pigmented lesions are painful. Non-pigmented lesions are what, doctor? Painful. You got my point, doctor? So symptoms do not depend upon size and extent of lesion. It always depends upon the depth and site of lesion. If it involves ovary, definitely presents with heavy menstrual bleeding or premenstrual spotting. If it involves urinary, definitely they will have what, doctor? Dysuria or back pain or hematuria. If it involves sigmoid, colon or rectum, they will have diarrhea or dysphagia or constipation or melena. Or if it involves lungs, they will have hemoptysis, or if it involves scars, there will be bleeding or pain from the scars. Understood, doctor? The most common symptom of endometriosis is what, doctor? It is dysmenorrhea. What type of dysmenorrhea? It can be triple or congestive. And symptoms, you got my point, doctor, do not depend upon size and extent of lesion. It always depends upon depth of lesion or site of lesion. Please make a note of it. So symptoms do not depend upon what, doctor? Size and extent of lesion. It always depends upon depth and site of lesion. If it is more than 5 millimeters, yes, it can have presence with dysmenorrhea or dyspareunia or chronic pelvic pain. If it involves the site, definitely these can be taken. Understood, doctor? And this is the important golden line. Yes, endometriosis should be suspected in women with infertility, dysmenorrhea, dyspareunia and chronic pelvic pain. But the disease can be asymptomatic even in advanced cases. Even in 25% of women with advanced stage of endometriosis will be asymptomatic. This is golden line taken from the Bible of Gynecology. You got my point, doctor? So endometriosis should be suspected in all women with infertility, dysmenorrhea, dyspareunia and chronic pelvic pain. Understood, doctor? And even in women with advanced stages, this endometriosis is asymptomatic in 25% of the cases. Yes. And what is this vicarious menstruation, doctor? Bleeding from nasal mucosa during menses. And there is one syndrome called as Yusuf syndrome, that is hematuria during periods. What are the causes for Yusuf syndrome? One, endometriosis of the bladder. Another one is uterovesical fistula. Uterovesical fistula. Now, what is the answer? Most common presentation of endometriosis, yes, definitely they will present with what, doctor? Dysmenorrhea. And what all the examination findings? So this is all the symptomatology. Examination findings, you should remember the pelvic examination findings, very, very important. It's a fixed retroverted uterus with adnexal mass. Please make a note of it. It's a fixed retroverted uterus with adnexal mass. What is that adnexal mass? Nothing but chocolate cyst or endometriotic cyst. Understood, doctor? What is that adnexal mass, doctor? It is chocolate cyst or what, doctor? Endometriotic cyst. That is tender fixed mass. It is retroverted uterus, not antiverted. It's a fixed uterus, not freely mobile. Please make a note of it. If you compare adenomyotic uterus and endometriotic uterus, in adenomyotic uterus, most of the uterus will be antiverted, and it's a free mobile uterus in adenomyosis. But in endometriosis, it's a retroverted and fixed with adnexal mass. What is that adnexal mass? There will be chocolate cyst, that is fixed tender mass, and there will be tender uterosacral ligament, Yes, yes, this is a pelvic examination findings, Okay, doctors, next question. All of the following events in girls are attributed to estrogen except. Definitely estrogen leads to menstruation. Yes, estrogen leads to vaginal epithelialization, that is vaginal cornification. Yes, and estrogen also reaching the adult height. But this axillary and pubic hair, they are all due to androgens. Please make a note of it. This axillary and pubic hairs, are due to androgens, not due to estrogen. Yes, estrogen leads to menstruation, definitely. Yes, proliferative phase of the menstrual cycle, yes, especially is by estrogen. Vaginal cornification, yes, by estrogen. Yes, height, the stature, definitely estrogen. But this axillary and pubic hair, definitely by androgens. Axillary and pubic hair is by what, doctor? Androgens. So this is an important MCQ. Now come to next question. True labor pain is associated with all except. And so doctor, just as a NEET PG aspirant, you should know the features of true labor pains and false labor pains. Very, very important. Take down. So true labor pains and false labor pains. Doctor, true labor pains, yes, definitely occurs at regular intervals. Yes. False labor pain occurs at irregular intervals. True labor pains occurs at regular. Yes, false labor pains occurs at what, doctor? Irregular intervals. And doctor, this true labor pains, they are all progressive increase in frequency, progressive increase in duration, progressive increase in intensity. Please make a note of it. True labor pains, they are all progressive in nature. Very, very important. They are all progressive in nature. Means there will be progressive increase in frequency, progressive increase in duration, progressive increase in what, doctor? Intensity. But here this false labor pains, not progressive in nature. Yes, there is no progressive increase in frequency, duration and intensity. Means not progressive in nature. Very, very important. Yes, yes. And doctor, true labor pains are radiating in nature, that is from back to front. Radiating in nature. Take down, doctors. True labor pains are radiating in nature, that is back to front. Radiating in nature, that is back to front. This is not radiating, means they confine to lower abdomen. Not radiating, confined to lower abdomen or groin. Confined to lower abdomen or groin. And show is the feature of true labor pains. Show is the feature of what, doctor? True labor pains. What is this show? Nothing but blood-stained cervical mucus plug. Blood-stained cervix mucus. Show is the feature of what, doctor? True labor pains. Yes. And doctor, so cervical dilatation and effacement, yes, definitely the feature of true labor pains. And no cervical dilatation or no effacement or minimal cervical dilatation or minimal effacement. Yes, and descent of presenting part is the feature of true labor pains. Yes, and no descent of presenting part is the feature of false labor pain. Show, yes, show cervical changes, effacement of cervix, descent of presenting part, progressive in nature, radiating in nature, occurring at regular intervals? Definitely true labor pains, true labor pains. Yes, and doctor, so in true labor pains, it is fixed between the pains, and in false labor pains, it remains free, it remains free. On sedation, true labor pains not relieved. Very, very important MCQ. On sedation, true labor pains not relieved. Definitely false labor pains definitely relieved on sedation. False labor pains definitely relieved on sedation. Very, very important MCQ. Very, very important MCQ. On emptying of bowel, in case of true labor pains, no relief of symptoms. Please make a note of it. On emptying of bowel, in case of true labor pains, no relief of symptoms. And definitely on emptying of bowel, definitely if there is relief of symptoms, definitely it is false labor pains. And doctor, interval between contraction gradually shortens in case of what? True labor pains, and remains longer in case of what? False labor pains. Yes, come back to this MCQ, dear doctors. True labor pains is associated with all except. Associated with show, definitely true statement. Associated with cervical effacement, true statement. Relieved on sedation, definitely true labor pains not relieved on sedation, false statement. False statement. And radiating to lower back, yes, definitely it is a radiating in nature, radiating in nature. It's a true statement, true statement. Yes. Next question. Yes, 32-year-old female is undergoing hysteroscopy for removal of submucosal fibroid. For this procedure, 3% sorbitol is used as a distension medium. The procedure should terminate it if a fluid deficit of X ml is present. Yes, your excess definitely is a direct question. 3% sorbitol, definitely if a 1000 ml deficit. Yes, any hysteroscopic procedure, 1000 ml deficit, definitely we have to terminate the procedure. We have to terminate. It's a direct thing. Understood, doctor? So, any hysteroscopic procedure, understood? If they are using the distension media, yes, if there is a fluid deficit of more than 1000 ml or around 1000 ml, definitely we are going to stop the procedure. Definitely we are going to stop the procedure. Yes, yes. Next question, doctor. Wonderful question. Interpret the following photograph. The correct statement is, yes, contractions are adequate. Fetal head is not descending, so a cesarean section is indicated. As a fetal heart rate is decelerating, cesarean section is indicated. Cervix is not dilating adequately. Understood, doctor? Here they are given two photographs. One is, understood, it is a modified photograph only, and it is not an old photograph. So, why it is a modified photograph? Because here there is no latent phase. Yes, that is the one thing. And active phase starts from 4 centimeter. Please make a note of it. Here there is no latent phase. Active phase starts from 4 centimeter. That's why it's a modified WHO photograph, not a old photograph. So, what all the options? Here our contractions are adequate. Yes. Yes, fetal head is not descending. So, cesarean section is indicated. Or as a fetal heart rate is decelerating, cesarean section is indicated. Cervix is not dilating adequately. Now, doctor, before coming back to this question, we will have a basic knowledge on the photograph. Now, look into this. Yes, this is a new photograph, that is a WHO modified photograph. Here it has got topmost part which has got patient details and obstetric history. Yes, middlemost part which is related to the labor related. Yes, and lowermost part, it is a maternal part. For exam's sake, I divided this photograph into three parts: topmost part, middle part, and lowermost part. Topmost part is, it is totally related to patient details and obstetric history. Yes, and middlemost part is labor, and lowermost part is what? It is a mother related, that is maternal. Now come to topmost part. Yes, it is a patient details and obstetric history. What all the patient details? Name of the patient, yes, gravida, parity, hospital number, date of admission, time of admission, ruptured membranes, yes, and what is the duration of hours of rupture of membranes also mentioned. Understood, doctor? And this is the fetal heart rate. Please make a note of it. This is the what, doctor? Fetal heart rate. Normal fetal heart rate is 110 to 160 beats per minute, and this is the amniotic fluid, and this is the molding. You got my point, doctor? This is amniotic fluid and molding. And fetal heart rate is represented by dot. Please make a note of it. Fetal heart rate is represented by what, doctor? Dot. One is patient details. Understood, doctor? Another one is obstetric history. Obstetric history may they include gravida, parity. Yes, that is the one thing. Next is fetal heart rate, followed by amniotic fluid, followed by molding. Yes, normal fetal heart rate is how much? 110 to 160 beats per minute. Now come to middlemost part. Yes, middlemost part, this is the cervical dilatation. Very, very important. Cervical dilatation is on y-axis, and time So time in hours in x-axis. Please make a note of it. Very, very important. So that is middlemost part. Dear doctors, middlemost part. So cervical dilatation in y-axis, that is, so 0 to 10 centimeter. 0 to 10 centimeter. Yes. Time in hours in x-axis, that is 1 to 12 hours. 1 to 12 hours. Next is a uterine contraction. Then oxytocin. Oxytocin, that is how many units per liter or how many drops per minute, and drugs and IV fluids. Drugs and IV fluids. If the patient is on magnesium sulfate, we can write magnesium sulfate like this, or if the patient is on some antihypertensive like Labetal, we can write that. And another important MCQ, doctor, plotting always begins from active phase, that is 4 centimeter cervical dilatation. Please make a note of it. When you will start plotting a photograph, doctor, when you will start plotting a photograph, yes, 4 centimeter cervical dilatation. Please make a note of when you start plotting a photograph, it is a 4 centimeter cervical dilatation. Cutoff cervical dilatation to start plotting a photograph is 4 centimeter. 4 centimeter. This is the middlemost part. Understood, doctor? So one is cervical dilatation from 0 to 10 centimeters in y-axis, yes, and time in hours in x-axis, that is from 1 to 12 hours, yes. And another one thing, uterine contractions in 10 minutes. Uterine contractions in 10 minutes. Then oxytocin, that is units per liter or drops per minute. Then drugs and IV fluids. This is the middlemost part. And lowermost part, dear doctor, lowermost part. So this is the lowermost part. Please make a note of it. This is the lowermost part. That is maternal pulse every 30 minutes. And every 4th hourly, we'll look for BP, temperature, urine for 3 things: protein, acetone and volume. Please make a note of it. Lowermost part, yes, pulse every 30 minutes, every 4th hourly BP and temperature, and urine for protein, acetone and volume. These are the 3 things you look for urine. Yes, yes. Now, doctor, look into these are all the MCQs. Very, very important MCQ. Now, cervicograph. What is this cervicograph? Cervical dilatation in y-axis, time in duration, time in hours in x-axis. You got my point, doctor? Cervical dilatation in what, doctor? What axis? Y-axis, and time in duration, that is time in hours in x-axis. Now, doctor, look into this. So, this is a cervical dilatation. Now, doctor, so in this cervical dilatation, yes, look into this, each square, this is a each square, please make a note of it. This is a each square on y-axis corresponds to the dilatation of cervix. Means each square corresponds to how much centimeter dilatation? 1 centimeter. And even each square on x-axis corresponds to time in hours, and each square corresponds to how many hours? 1 hour. Please make a note of it. So this is a cervicograph. They will ask you, what is a cervicograph, doctor? Cervicograph is nothing but, yes, cervical dilatation in y-axis and time in hours in x-axis. And each square corresponds to 1 centimeter dilatation in y-axis and 1 hour in what, doctor? X-axis. Please make a note of it. Cervical dilatation in which axis? Y-axis. Time in hours in which axis? X-axis. Each square in y-axis corresponds to 1 centimeter dilatation, and each square in x-axis corresponds to 1 hour. Corresponds to what, doctor? 1 hour. Yes? Yes. Now, doctor, so there are 2 lines in cervical dilatation area. One is alert line, another one is action line. You got my point, doctor? There are 2 lines in cervical dilatation area. One is alert line, another one is action line. And the time gap between alert and action line is 4 hours. That is important MCQ. Please make a note of it. Time gap between alert and action line is how many hours? 4 hours. Alert line is plotted based on the principle that in active phase, the minimum dilatation of cervix will be 1 centimeter per hour. Please make a note of it. Yes, alert line plotted based on the principle that minimum dilatation of cervix will be 1 centimeter per hour, and per vaginal examination in labor done every 4th hourly and plotted over a photograph. Yes, the time gap between alert and action line is how many hours? 4 hours. What is the principle of marking alert line? That is minimum dilatation of cervix will be how much? 1 centimeter per hour, and every 4th hour we will do PV and will mark a photograph. Yes, yes. Next, doctor, first marking should always be on the alert line. Important MCQ. Please make a note of it. First marking should always be on the alert line. If the progress of labor lies over the alert line or towards the left of the alert line, always it is normal progress of labor. When you will say it is the labor is progressing normally, the photograph should be always on the alert line or left of the alert line. If it crosses the alert line, means if it comes to the right of the alert line, it is slow progress of labor. Please make a note of it. If it crosses the alert line, that is, if it comes to the what right of the alert line, definitely it is slow progress of labor. Or if it crosses the action line, always action is needed. Always action is needed. Yes, yes. If the progress of labor is between alert and action, that is right of the alert line, always it is slow progress of labor. And if the patient is in what doctor, primary health center, refer to higher center. Or if patient is already in higher center, keep monitoring, keep monitoring. And if the progress of labor crosses the action line or right of the crosses the action line or right of the action line, yes, definitely action is needed, not always cesarean section. Yes, yes. Doctor, understood? No, what is the cutoff cervical dilatation to plot a pantograph? 4 centimeter, 4 centimeter. And what is the basic principle of plotting a alert line? 1 centimeter per hour cervical dilatation. Yes, understood, doctor? The first marking should always be on the alert line. It should not be on the left or right of the alert line. It should always be on the alert line, on the alert line. And if the progress of labor is on the alert line or left of the alert line, it is a normal progress of labor. If it comes between the alert and action, it is a slow progress of labor. If it crosses the action, some action is needed. Some action is needed. Yes, yes. Now, doctor, another important MCQ. So, in the partograph, we are not marking the vaginal method of descent of fetal head. Please make a note of it. You got my point, doctor? So, in the partograph, we are not marking the vaginal method of descent of head. Normally, we will do pervaginal examination. We will compare the fetal head with the ischial spine. If the head is above ischial spine, if it is definitely it is a minus station. If the head is below ischial spine, it is a plus station. And so this is not marked in case of what, doctor? It is in the case of partograph. In partograph, it is abdominal method of descent. What is this abdominal method of descent? That is Christian's 5th rule. What is this abdominal method of descent, doctor? It is Christian's 5th rule. Please make a note. What is this abdominal method of descent? It is the Christian's 5th rule. What is this Christian's 5th rule? We will keep all width of the 5 fingers of hand over the lower abdomen. Please make a note of it. So, in partograph, we are not marking vaginal method of descent of head. We are marking only per abdomen method of assessment of head. What is that rule called as? Christian's rule. So, what is this Christian's rule? Just will keep width of 5 fingers over the lower abdomen. Just see, this is the width of 5 fingers of lower abdomen. If width of 5 fingers of lower abdomen is occupied by the fetal head, it is 5/5. If all width of 5 fingers occupies the lower abdomen or all width of 5 fingers occupies the fetal head, definitely it is 5/5. If it occupies 4/5 of the width, 4/5. If it is 3/5, 3/5. Yes, understood, doctor? So, from 3/5 to 5/5, it is unengaged head. And from 2/5 to 0/5, it is engaged head. Is it clear, doctor? Is it clear? Doctor, in partograph, it is not the vaginal method of descent of head is marked. It is a abdominal method of assessment of head is done, then it is marked. It is abdominal method of descent of head is done and it is marked. What is that rule called as? Christian's rule. What is this Christian's rule? Just will keep 5 fingers, that just will keep width of 5 fingers over the lower abdomen. If fetal head occupies all 5 finger width, it is 5/5. Yeah, if fetal head occupies only 4 finger width, it is 4/5. Or if fetal head occupies only 3 finger width, it is 3/5. Or if fetal head occupies only 2 finger width, it is 2/5. Is it clear, doctor? This rule, what is that rule called as? Christian's 5th rule. Christian's 5th rule. It is not the vaginal method of descent. It is the, what, doctor? Abdominal method of descent. It is the abdominal method of descent. Yes, yes. Now come to uterine contraction. Please make a note of it. If it is dots, doctor, if it is dots, definitely less than 20 seconds. If it is diagonal lines, 20 to 40, and dark shading, darkened completely, it is more than 40, Yes, yes. Now, doctor, look into this. Contractions which are all happening in the uterus are marked here for how many minutes, doctor? 10 minutes. So, counting and marking of contraction is done by placing a hand on the fundus of uterus after every 30 minutes for 10 minutes. Just for every 30 minutes, we'll keep hand over the fundus of the uterus and we'll count for how many minutes? 10 minutes. You got my point, doctor? We'll keep hand over the fundus of the uterus every 30 minutes, but we will count for only 10 minutes. For 10 minutes, how many contraction? If it is a dots, less than 20. If it is a diagonal lines, 20 to 40. If it is a completely darkened, definitely it is What doctor? Completely darkened. Definitely it is more than 40 seconds. And finally, dear doctor, so last but not the least, we'll list the topmost part, middlemost part and lowermost part. So overall, just list down the topmost part. I told you, yes, the patient details. Take down, doctor. Patient details. Yes. Obstetric history of the patient. Obstetric history of patient. Obstetric history of patient. And 3 fetal conditions. 3 fetal conditions. What are the 3 fetal conditions, doctor? One is fetal heart rate. Yes. Another one is amniotic fluid status. Amniotic fluid status. Another one is molding. Another one is molding. This is the topmost part. Topmost part. Now come to middle part. It is related to labor. Middle part related to labor. That is, one is cervicograph. Cervicograph. What is this cervicograph? That is cervical dilatation in y-axis and time in hours in x-axis. Cervical dilatation. Take down cervical dilatation in y-axis and time in hours in x-axis. Time in hours in x-axis. Then you, what are the other components in the middle part? That is labor related. Uterine contractions in 10 minutes. Uterine contractions in 10 minutes. And will also oxytocin and drugs and IV fluids. And lowermost part, which is maternal condition indicated, that is pulse, BP and temperature. Pulse, BP and temperature. Pulse every 30 minutes, BP and temperature every 4th hourly. And we urine for 3 things. What is the urine we look for? One is protein, acetone and volume. Protein, acetone and volume. Protein, acetone and volume. So these are all the components of what doctor patograph. Now we will come back to the question. Let us see. Yes. Now Mrs. S. So first we will go from top to bottom. That is the topmost part, fetal heart rate. Yes, it is starts with the 120. Dear doctor, look into this. It is starts with 120. Then it goes to 130. Yes. Once again 120. Once again next 140. Yes, next 120, 120, yes, it is going like this. It is not decelerating. And you should know, the fetal heart rate is not decelerating. Definitely, this is false statement. This is false statement. Understood, doctor? So now amniotic fluid, C means clear. Amniotic fluid, C means clear, and there is no molding. No molding. Now, if you come to the cervicograph, that is cervical dilatation is marked as X. Very simple to solve the exercises. Cervical dilatation is marked as X. Descent of head is marked as O. Cervical dilatation is marked as X. Descent is marked as what, doctor? O. Now, doctor, look into this. Here the, what doctor, look into this. Here the partograph curve, that is the progress of labor, is on the alert of line. Please make a note of it. Here the partogram curve, that is the progress of labor, is on the alert line. Now tell me, doctor, if the progress of labor is on the alert line, it is a normal partograph curve or abnormal partograph curve? Definitely it is normal partograph curve. Yes, yes, definitely it is normal partograph curve. Yes, yes. So now doctor, look into this. So cervix is not dilating adequately. This is also false statement, because here the progress of labor, see, so at admission it is 5 centimeter. After 4 hours it is 10 centimeter. So hourly it is 1 centimeter per dilatation. So it is adequate dilatation. Adequate dilatation. Why? Because it is the partograph curve is on the alert line. On the alert line. Yes, yes. Now doctor, next, here also it is 3/5 palpable. Yes, then it is 0/5 palpable. It is engaged. So here also fetal head descent is also adequate. So fetal head is not descending, so cesarean section is indicated. This is also false statement. Now come to contractions. Now doctor, it is completely darkened. Please make a note of it, completely darkened. Means look into this. So I was telling you, so we will count and mark the contractions by placing our hand over the fundus of the uterus every 30 minutes for 10 minutes. Please make a note of it. Every 30 minutes, we'll keep our hand over the fundus of the uterus and we'll count for only 10 minutes. You got my point, doctor? Every 30 minutes, we'll keep the hand over the fundus of the uterus. Yes, and we'll count for only 10 minutes. Now, doctor, so this is the, look into this. This is a 10 minutes duration. This is also 10 minutes duration. And this is also 10 minutes duration. Look into this. Here, this is the one square. This is another. So, here 4 squares. Means here means how many contractions? This one. So, this one. Here 4 contractions. 4 contractions. Yes. Lasting for more than 40 seconds. Means it is darkened. Completely darkened. You got my point, doctor? Here completely darkened. How many squares are completely darkened? 4 squares are completely darkened. Means it is 4 contractions for how many seconds, doctor? It is more than 40 seconds. And you all know 3 to 5 contractions. 3 to 5 contractions per 10 minutes. Per 10 minutes. Each contraction lasting for 60 to 70 seconds. Yes, definitely it is adequate contraction. Please make a note of it. When you will say it is adequate contraction, 3 to 5 contractions per how many minutes, doctor? 10 minutes. 3 to 5 contractions per how many minutes? 10 minutes. Each contraction lasting for 60 to 70 seconds is adequate. So, what is the option? Definitely here contractions are adequate. Yes, it's a true statement. It's a true statement. Yes, yes. Okay, dear doctors, is it clear? So, these are all the partograph points. Yes. Now, we'll go to next question. A 58-year-old postmenopausal woman visits to oncology clinic with history of spotting PV for 2 days. Means postmenopausal bleeding. On workup with endometrial sampling and hysteroscopy, guided biopsy reveals atypical hyperplasia. What is the best modality of treatment? 58-year-old atypical hyperplasia. What more you want? Definitely surgery. Surgery. Now, dear doctor, just few golden points on endometrial hyperplasia. There is an older classification, yes, and there is a newer classification. Please make a note of it. There is an older classification and newer classification. So, in this older classification, we have got 2 varieties. One is simple hyperplasia and complex hyperplasia. Complex hyperplasia. We have got simple hyperplasia and complex hyperplasia. Now, this simple hyperplasia once again divided into without atypia, and with atypia. Here complex hyperplasia also, dear doctors, without atypia and with atypia. Without atypia and with atypia. Now, this is the older classification. So, simple hyperplasia without atypia, with atypia. Complex hyperplasia without atypia, with atypia. This is older classification. Now, doctor, newer, there is no concept of simple and complex. Only 2 varieties. One is without atypia. We have got only 2 varieties. One is without atypia. Another one is atypical hyperplasia. Atypical hyperplasia. One is without atypia. Another one is atypical hyperplasia. Yes, doctor. So, without atypia and atypical hyperplasia. So, that is without atypia means non-atypical hyperplasia. Non-atypical hyperplasia. Yes, yes. Now, doctor, look into this. We'll go to the management. So, first one is non-atypical hyperplasia. First one is non-atypical hyperplasia. Non-atypical hyperplasia means that is without atypia. Non-atypical hyperplasia means without atypia. Means, doctor, very important, that is, take down, doctor. So, non-atypical hyperplasia, yes, it will have regression of more than 80% in 28 years. Understood, doctor? So, regression, very, very important MCQ, regression of more than 80% in 20 years. Means we have to do wait and watch, expectant management for non-atypical hyperplasia, because over 20 years definitely it will regress over more than 80%. So, regression of more than 80% in 20 years. Yes, means you should observe for spontaneous regression. Observe for spontaneous regression. Take down, doctor. Observe for spontaneous regression means we should do follow up. So, take down, doctor. We should do what? Follow up. Or we will do follow up. We will do follow up with endometrial biopsy at 3 to 6 months. So, we will do follow up, that is endometrial biopsy with 3 to 6 months, that is until 2 consecutive negative samples, until 2 consecutive negative samples, 2 consecutive negative samples. Yes, yes. So, during follow up, there is no regression or progression to atypia. There is no regression, or progression to atypia. No regression or progression to atypia, definitely will go for hysterectomy. Definitely will go for what, doctor? Hysterectomy. So, please make a note of it. So, no regression or progression to atypia will go for hysterectomy. Yes, yes. So, if there is regression, definitely will go for long term follow up. If there is regression, definitely will go for long term follow up. Long term follow up. Yes, yes. So, understood, doctor. So, non-atypical hyperplasia, regression more than 80% in 20 years. That's why wait for spontaneous regression. That is what, doctor? Follow up with endometrial biopsy until 2 negative consecutive samples. So, no regression or progression to atypia, go for hysterectomy. Yes. If there is regression, definitely you do long term follow up. This is one modality. Another modality, we can go for medical treatment also. We can go for medical treatment. So, here in this medical treatment, yes, the first line is always LNG-IUS. First line is always LNG-IUS. And second line, yes, we can go for medroxyprogesterone acetate. We can go for medroxyprogesterone acetate. This is about non-atypical hyperplasia. Understood? So, final take home message, non-atypical hyperplasia, yes, regression more than 80% in 20 years. That's why, yes, wait for spontaneous regression. How will you wait? That is follow up with endometrial biopsy every 3 to 6 months. Understood? Until 2 negative consecutive samples. Otherwise, we can go for medical management. The first line is LNG-IUS. The second line is medroxyprogesterone acetate. Next, the atypical hyperplasia. Atypical hyperplasia. Definitely atypical hyperplasia. Yes. So, premenopausal. Please make a note of it. Premenopausal. Yes. Premenopausal and postmenopausal. Definitely postmenopausal. Postmenopausal. Yes. We can go for hysterectomy. Postmenopausal. We can go for hysterectomy. In premenopausal, we look for, yes, we look for fertility preservation. We will look for what, doctor? Fertility preservation. Premenopausal, we look for fertility preservation. Yes, if a fertility preservation is not needed, we can go for hysterectomy. Not needed, we can go for hysterectomy. If fertility preservation is required, yes, definitely we will go for medical drugs. Medical drugs. That is the first line LNG-IUS, second line medroxyprogesterone acetate. Yes, yes. This is a what, doctor? Overall view of management of hyperplasia. This is the overall view of management of hyperplasia. What is the answer for this? 58-year postmenopausal bleeding, endometrial biopsy reveals atypical hyperplasia, definitely will go for surgery. Yes, yes. And doctor, there is a new FIGO staging of endometrial carcinoma. Please make a note of it. This is updated staging of endometrial carcinoma. Please look into the My OBG app in NExT. Yes, yes. Yes, false statement about the below presentation. Definitely, this is the face presentation. Phase presentation. Phase presentation. Yes, here the head is completely extended. True statement. Yes, the denominator is sensiput. Definitely in phase presentation, denominator is not the sensiput, denominator is always the mentum. Denominator is always the mentum. This is a false statement. And phase presentation most commonly seen in platypeloid type of pelvis. What is this platypeloid what is this platypeloid type of pelvis? That is, yes, transverse diameter. Please make a note of it. Transverse diameter is more compared to antero-posterior diameter. Yes, this is a true statement. And engaging diameter is submentobrachmatic. Engaging diameter is submentobrachmatic, 9.5 centimeters. 9.5 centimeters. Definitely true statement. Definitely true statement. You got my point, doctor? This is a phase presentation most commonly seen in what, doctor? Platypeloid type of pelvis where transverse diameter is more. Transverse diameter is more. And denominator is what, doctor? Mentum. Mentum. Yes. So, following cells that are found in bacterial vaginosis are called clue cells. Definitely, it's a repeat question. What is this clue cells? That is nothing but the epithelial cells covered by bacteria. They are all the epithelial cells covered by bacteria. They are all the epithelial cells covered by bacteria. Clue cells, characteristic of bacterial vaginosis. Characteristic of what, doctor? Bacterial vaginosis. There is one criteria in bacterial vaginosis. What is that? Amsel's criteria. What is this Amsel's criteria? pH more than 4.5. Yes, that is the one thing. Then clue cells. Yes, that is the one thing. And whiff test positive. Whiff test positive. What is this whiff test? That is fishy odor on addition of what, doctor? KOH. Fishy odor. Take down the whiff test positive. So, fishy odor, yes, on KOH application. Fishy odor on KOH application. Yes, yes. Now come to this question. True statement regarding the given device. Doctor, this is manual vacuum aspiration. Manual vacuum aspiration. Yes. This device can be used to evacuate the content of uterus till 12 weeks. Yes. This has got double valve syringe. This has got double valve syringe. And the capacity of this MVA syringe is 60 ml. And the pressure is 660 millimeters of mercury. 660 millimeters of mercury. Yes. So, this is a false statement. That is 660. Capacity is 60 ml. This is also false statement. It's a double valve syringe. Yes, false statement. Yes, this device can be used for evacuation of contents of uterus till how many weeks? Yes, till 12 weeks. This is a true statement. This is a true statement. Yes, yes. So, now come to this. Diagnose the following condition. It's a very simple question. Look into this. This is the vagina. This is the rectum. Definitely, this is recto-vaginal fistula. Recto-vaginal fistula. Understood? What is this fistula, doctor? This is the recto-vaginal fistula. Recto-vaginal fistula. Yes, yes. A 23-year-old female primigravida admitted to the antenatal ward at 35 weeks, found to have BP 160-110 mm. Her urine does not contain albumin. Which of the following should not be used for her management? Doctor, definitely this is severe variety of preeclampsia. So, severe variety of preeclampsia. For acute emergency, what is the antihypertensive of choice? Definitely IV labetalol. IV labetalol. For acute emergencies, definitely IV labetalol can be used. Or we can go for nifedipine, that is tablet nifedipine also we can use. Definitely nifedipine. Or we can also use methyl dopa, but not furosemide. Understood, doctor? So, severe preeclampsia, antihypertensive of choice is IV labetalol. IV labetalol. Is it clear, doctor? Yes. What are the other antihypertensive that can be used? Yes, IV hydralazine. Yes, that can also be used. IV sodium nitroprusside. Yes, that can also be used. But antihypertensive of choice, always IV labetalol. IV labetalol. Yes. A female has an obstetric score of Gravida 3, Para 1, Abortion 1 and Living 1. Now, doctor, parity means it's nothing but previous viable pregnancies. Previous viable pregnancies. Previous viable pregnancies. Yes, yes. Means yes. So gravida 3 means currently pregnant. Definitely she is currently pregnant. Yes. Then she had one pregnancy that has crossed the period of viability. Yes. Parity 1 means she has got one previous pregnancy which has crossed the period of viability. That is 2. That is true statement. Yes. That is the one thing. And she had lost one pregnancy before period of viability. So this is the abortion 1 means pregnancy loss before period of viability. Before period of pregnancy loss before period of viability, definitely it is true statement. And she had lost one pregnancy after period of viability. No. So this is a false statement. You got my point, doctor? Final take home message. See, gravida means nothing but total pregnancies. Gravida nothing but what, doctor? Total pregnancies irrespective of POG. Irrespective of POG or irrespective of outcome. Irrespective of outcome. Irrespective of POG or irrespective of outcome. What is this parity? Previous viable pregnancies. Means previous pregnancy that have gone beyond period of viability. Understood, doctor? So gravida 3, para 1, abortion 1, living 1 means one pregnancy that have crossed the period of viability, one pregnancy before period of viability, and she is currently pregnant. Yes? Yes. I think this is clear, doctor. CTG of a 27-year-old lady is given below. False statement about this. Doctor, this is the what, doctor? Sinusoidal pattern of heart rate. Sinusoidal pattern of heart rate. Very, very important MCQ. In this sinusoidal pattern of heart rate, the pattern of heart rate will be sine wave pattern and beat to beat variability will be absent. Beat to beat variability will be absent. Yes, this is a false statement and usually seen in fetal anemia. Where all you will see fetal anemia? Rupture of vasa previa. Yes, twin to twin transfusion syndrome, RH isoimmunization. Understood, doctor? So take down. So fetal anemia conditions. In fetal anemia conditions, we will see sinusoidal pattern of fetal heart rate. What are all the conditions? 1. Rupture of vasa previa. Rupture of vasa previa. Yes. Then twin to twin transfusion syndrome. Then RH isoimmunization. RH isoimmunization. Yes, can be seen in fetal anemia. True statement. Isolation is absent. True statement. Is it clear, doctor? Yes. Yes, this is the one characteristic. What is this? Sinusoidal pattern, sine wave pattern seen in fetal anemia condition. Yes, yes. Okay, doctors. So these are all the set of OBG questions in CBoT 4, and definitely I think you all enjoyed the session. Thank you.
Hello friends, welcome today to the CBoT discussion, and I am Dr. Dipali Gupta, your pediatrics faculty from NExT, and today we are going to discuss the questions from pediatrics which have come today in CBoT. So शुरू करते हैं जल्दी जल्दी the easy questions which had come from pediatrics. So first of all, an intern posted in the pediatrics department was told to do anthropometry measurements with the instrument given in the image. Which of the following colors is interpreted as no malnutrition? So again, a very, very important topic from which this has come. We know the malnutrition, assessment of malnutrition, we should be very thoroughly updated about, and so is this question from the topic which has come from. Now, this what is shown over here, we should know what is this instrument. This is called as Charcot's tape. We know this, and Charcot's tape is used to assess what? It is used to assess mid-upper arm circumference. We all know this. Now, in this question, they have just asked you what is the interpretation of the various colors shown in the Charcot's tape. So we know about it, that there are 3 colors shown over here, very evident: red, yellow, and green. And as is the convention, green usually means no problem. So green would stand for no malnutrition. Remember this. Then the yellow stands for malnutrition, and then so basically it is it is an indication that the child needs some or the other kind of intervention to correct his malnutrition. And of course, red stands for severe malnutrition. So this is as far as the interpretation on the basis of colors go on the Shakir's tape. One more very important information which you should be updated about is that once upon a time, the mid upper arm circumference, always remember the mid upper arm circumference was specifically stated as age independent criteria. Remember this, and this was few years back, but nowadays please remember no longer this kind of thing exists. Now it is considered both as age as well as gender dependent criteria. Remember that. So that means we have separate charts to interpret the mid upper arm circumference for boys and for girls also. So no longer it is age independent and it is not even gender independent. But once upon a time, this was considered as a age independent criteria. And if we go by the Shakir's tape, there are 3 zones which are mentioned over here. You should be knowing this. Severe malnutrition, this stands for, let us say, this stands for less than mid upper arm circumference, which is less than 11.5 centimeters. And yellow color stands for the mid upper arm circumference, which is lying between 11.5 to 12.5 centimeters, and no malnutrition is anything more than 12.5 centimeters. So this is as per the indices which you should be knowing. Sometimes, directly they would ask you, when do you classify mid upper arm circumference in severe malnutrition? Then you should know it is less than 11.5 centimeters. If the centimeters is not given, then they can even ask you in millimeters. So just convert it, it would be 115 millimeter, right? So this you should be knowing. So in this, what would be the answer be? No malnutrition. So which color? Yes, definitely the answer is going to be the green color. So we would go for the option C as the correct option. So very straightforward question, and a question which is expected to come because it is a very, very high yield topic, right? Okay, so let us move further. Let us come to the next question. Which of the following is incorrect for kangaroo mother care? Can be done for hemodynamically unstable baby, can be done by father also. Exclusive breastfeeding is a part and parcel of, kangaroo mother care, and it is continued till 37 weeks or until the weight of the baby is 2.5 kg. That is what is asked in the question. Which of the following is incorrect? First of all, let us see. They are asking us about incorrect. So if I want to straight away give you the answer, yes, I know you all know this answer because it's a very evident kind of question, very easy kind of question. So the answer is the A option. Never ever KMC is done in hemodynamically unstable baby. The baby has to be hemodynamically stable. Then only you can perform a kangaroo mother care. So few words about kangaroo mother care, if we just have to discuss this. Always remember KMC, as it is called in short. This was given by Dr. Edgar Ray, and this was given somewhere around, as far as I remember, 1973, or in fact 1978, in Colombia. So this person, Dr. Edgar Ray, he was a doctor working in Bogota, Colombia, the capital of Colombia, and there he advocated that this can be started in babies as early as when they are around more than 1800 grams of weight, right? And can be initiated in birthing facility as well as in the home facility, and the breastfeeding can be done simultaneously, and the KMC can be given 24 hours in a day, and it is not necessarily that it is given only by the mother. Either of the parents or both the parents, like either of the parents can participate in this KMC. It is not necessarily that you only have to entrust this responsibility on the mother. And very importantly, even the fathers can perform the kangaroo mother care. And what is important is there should be skin to skin contact with the baby. That means, whether it is the father or the mother who's doing KMC, the anterior part of the body, that is the chest portion, should be, totally devoid of clothes. And of course, that for the baby also. And then there should be skin to skin contact between the baby and the caregiver, and that caregiver can be anybody, including the father. Now this is stopped when, as it is very correctly mentioned over here, it is stopped until the weight of 2.5 kg is reached, or if the baby's gestation is more than 37 weeks. Can we stop KMC before that? Of course, KMC can be stopped even before these criteria, what is mentioned over here, if the baby is, no longer tolerating it. And how do we know the baby is no longer tolerating it? That means if there is excessive sweating occurring in the baby, or if the baby is refusing to stay in the KMC position, then it is better that you stop the KMC. But of course, if the child is almost near this point, or it is totally unbearable by the child, he is constantly irritable in the KMC position, then you can stop giving KMC, right? And very importantly, this also evolved the concept of, this is associated with the concept of exclusive breastfeeding if the caregiver is the mother. Now, what are the advantages of KMC? Everybody needs to remember the advantages of KMC. Remember what has been asked in your exams in the previous years is, does it prevent hyperbilirubinemia? Definitely, our answer is going to be no. So there is no effect on the hyperbilirubinemia. So I'm writing it like this over here so that you remember that this question has been constantly asked in the past. But of course, there are many other important advantages of KMC. First of all, it protects against protection against, let us see that it protects against hypothermia, right? And it also protects against, in fact, not protection, it improves the weight gain, it improves the milk production in the mother because of the constant skin to skin contact. So that will lead to more production of breast milk because of the release of the lactating hormones, namely the prolactin and oxytocin. As we know, especially the oxytocin part, the oxytocin hormone is totally, controlled by the emotions of the mother. So if the mother is, giving KMC, then her oxytocin production shoots up, and that leads to greater production of the breast milk. Of course, it also reduces the incidence of the respiratory tract infections and also the nosocomial infections. So that is but obvious. Nosocomial means hospital acquired infections. It also improves the emotional bonding between the infant and the mother, and overall it results in earlier discharge from the hospital. Remember that. So it decreases the hospital stay of the prematurely born or the low birth weight babies considerably. And in fact, one more thing very importantly, what has been observed with KMC is that it improves the sleep patterns. And you will be also amazed to know that it also improves the oxygenation in the baby. But please remember, that means that baby has to be stable. Okay, you cannot start KMC in a hemodynamically unstable baby. So going to the question again, it is but obvious. The other points have been covered by me, that it is done by father also. Exclusive breastfeeding is a part and parcel, and it is continued till the baby is of 37 weeks gestation or the weight crosses 2.5 kg. Obviously, yes, I told you it can be stopped early if it is no longer being tolerated by the baby, right? Okay, now let us move forward to the third question. Which of the following, okay. So a 3-year-old child with history of rickets reports back to the OPD after completing 3 months of daily vitamin D therapy. On conducting a repeat X-ray wrist, you fail to find a line of healing, right? So that is a very important information we are getting over here. So there is no line of healing. Lab investigation reveals serum calcium of 9 mg per deciliter, serum phosphate levels of 1.5, ABG is normal, and PTH level, that is the parathyroid hormone levels, is also normal, right? And which of the following is a correct diagnosis? See, first of all, one should know that when there is no line of healing, always think about what rickets? Yes, we are dealing with refractory rickets. So in the past, it was recommended that if on the first instance, since we were using, we had a choice between oral and IM injections, and we considered that if we have given orally vitamin D in the past and then the line of healing is not found, then you repeat the second dose of vitamin D by giving IM injections. But the latest books have omitted this part of, evaluation. If you are not getting line of healing after after ensuring that the child has been given vitamin D with due diligence and total compliance of vitamin D therapy is seen in the child, and still the line of healing is not there after 4 weeks of treatment. Here what we are seeing is no line of healing even after 12 weeks. But even after 4 weeks of treatment, if the line of healing is absent, we have to consider this child as a case of refractory rickets. Now the question arises, how do you evaluate refractory rickets? This flow chart, what you are seeing, bacha, this is very, very important, and you need to keep in mind how to go about. So first of all, we have to get a serum phosphate done. That is the first, investigation to be done when you are dealing with refractory rickets. So if the serum phosphate comes out to be high, straight away your diagnosis becomes chronic kidney disease, and you start evaluating and start thinking on the lines of CKD. If the serum phosphate comes out to be low or normal, so we don't know right now whether it's low or normal, let us move forward. We do a blood pH. You have seen in the question also they did a blood pH, that means ABG was done, arterial blood gas analysis, and that was normal. So in ABG, if it is low, then straight away the diagnosis becomes renal tubular acidosis. Rickets is associated both with distal RTA as well as proximal RTA. Then if it is normal, that means if the blood pH is also normal, then you go for serum PTH and calcium. In our question, if you remember, the parathyroid hormone levels as well as the serum calcium levels were totally normal. Of course, if they come out to be, somewhat problematic, that is high PTH because of low calcium, then you start thinking about vitamin D dependent rickets. And if there are both normal PTH and normal calcium, then you think about hypophosphatemic rickets. So that's what we have to think over here also. If we go back to the question, our calcium level, the child's calcium level is normal, and the PTH is also normal. And as you can see, the child has not responded to a vitamin D therapy. So that means we have to think about hypophosphatemic rickets, right? So straight away the diagnosis here becomes hypophosphatemic rickets. But anyways, let us read some things about hypophosphatemic rickets. So this I would like to show you the picture. So why does it occur? So as we know, hypophosphatemic rickets is mainly X-linked dominant. You are not supposed to forget the inheritance pattern of hypophosphatic rickets. Very, very important, X-linked dominant. And this picture, tells you lots of information. First of all, the mother is shown over here. She is the mother, and this is the male child, and this is the female child, you can see. So both male and female children, they are affected. That this shows this is a X-linked dominant kind of disease, and the mother is also affected. And what you can see very strikingly is that it is the lower limb deformities that are just striking at your face. So these lower limb deformities, they are the hallmark of hypophosphatemic rickets. A mother may have bowing of the legs, which is very clear over here, and short stature, and even the children are showing over here the lower limb deformities in form of genu valgum. Other deformities may be coxa vara, genu varus, or the short stature. And apart from the lower limb deformities, there may be abnormalities of the maxillofacial region, right? So maxillofacial region abnormalities might be seen. Apart from this, what we see is premature fusion of cranial sutures, and because of which you may have abnormal skull shape. Right, so premature fusion of cranial sutures, that is another abnormality which is very important. And very, very importantly, these children have dental abnormalities. I would like to highlight over here. So in any question, if the dental abnormalities in form of intraglobular dentin is present, intraglobular dentine is present, or if there is presence of frequent occurrence of dental abscesses. Why I am telling you this all? Because this has come in your previous year questions. So this will again give you a clue that you are dealing with hypophosphatemic rickets. Remember, in no other rickets you get to see these kind of dental abnormalities, right? And symptoms of hypocalcemia like tetany or the muscle weakness are these symptoms are classically absent. Why? Because you have just seen in question that serum calcium levels are normal in this child, so you will not find features of hypocalcemia. Now, why do rickets occur in such children is because, as we know, that phosphate is also very, very important for the mineralization of the cartilage. And in these children, there is a problem with a gene. So, which is that gene? Let us see. That gene goes by the name of PHEX gene, phosphate regulating gene, phosphate regulating gene. linked to endopeptidases. E is for endopeptidases. Peptidases on X chromosome. So that is the full form of phosphate regulating gene linked to endopeptidases on X chromosome. So this FEX gene is defective, and because of which what happens, there is deficiency of endopeptidases. Now, because of the deficiency of this enzyme, what happens is there is increase in the level of fibroblast growth factor 23. Now, what does FGF23 normally does? Let us see that. So, see what happens is this FGF23 normally it inhibits. You can see this dotted line indicates inhibits. So, this inhibits the activity of, you can see, 1-alpha hydroxylase. I'll just show you 1-alpha hydroxylase. This is 1-alpha hydroxylase, and what is 1-alpha hydroxylase? Involved in conversion of 25-hydroxy vitamin D to 1,25-hydroxy vitamin D. So this activity is inhibited by the FGF23. Now what happens is endopeptidases normally it destroys FGF23, it cleaves FGF23 and it causes inactivation of FGF23. Now if endopeptidases is deficient, so if this is deficient, then there is increase in the level of FGF23, and this will lead to decrease in activity of 1-alpha hydroxylase, and because of which there would be deficiency of 125 dihydroxy vitamin D3, which we all know is the active form of vitamin D, number one. Number two, another feature of increased activity of FGF23 is it causes phosphate wasting or excretion in the urine, and that results in the child developing phosphaturia. And I have just opened the discussion with a simple line that phosphate deposition or the deposition of phosphate in the cartilage, growing cartilage, is also important for adequate mineralization of the growing bone. So if the phosphate is deficient, the child lands up with features of rickets. And this increased phosphate loss, this familial hypophosphatemic rickets is not only associated with phosphaturia, but it is also associated with the deficiency of active form of vitamin D, right? So that means when we treat this child, in the treatment I would like to give both phosphate supplementation as well as the vitamin D supplementation. That is important. And which vitamin D? Definitely I am going to supplement this child with 1-alpha hydroxy vitamin D, because 1-alpha hydroxylase enzyme is not doing its work. Why it is not doing its work? Because of the FGF23 action, right? So the treatment involves giving oral phosphate, and oral phosphate is adequately being given in Joule's solution. Remember that Joule's solution is in fact we call it Julie's solution. Julie's solution is there, and that usually supplies 30.4 milligram of per 100 ml. This 30.4 milligram of phosphate is there in 100 milliliter of Julie's solution, and the target phosphate concentration, serum phosphate concentration, is somewhere between 3.0 to 3.2 milligram per deciliter, right? So this has to be supplemented. And secondly, vitamin D supplementation has to be given at the rate of, usually not at the rate, the dose is not that much important. What is important is that vitamin D supplementation, which form has to be given is 1-alpha hydroxy vitamin D. And if you know this is popularly known as alpha calcidol. So you have to give alpha calcidol plus Julie's solution. These two are to be supplemented in children with familial hypophosphatemic rickets, and this is how the family would look like, right? So this is all about familial hypophosphatemic rickets. We know we want to see the question again. So definitely now you'll be able to answer this question, that when there is everything normal, but what is glaring at you is the low serum phosphate level and the child behaving like a case of refractory rickets. Always go for the diagnosis of familial hypophosphatemic rickets. You know, in this case, at least they have given you lots of investigations. Sometimes the investigations would not be mentioned. They would just tell you that yes, the mother is also of short stature, mother is also having bowing of legs, and the children are also showing features of rickets, and both male and the female child are having the features, and moreover they are having frequent dental abscesses. They are also having intraglobular dentin, and they are having limb deformities. So, and the features of hypocalcemia are classically absent. Now tell me the diagnosis. Remember, this is familial hypophosphatemic rickets, right? Okay, now let us move on to the next question. Calculate the APGAR score for a neonate with a pulse of 90 per minute and slow and irregular breathing. He has a pink body with blue extremities, is noticed to have some flexion of his limbs, also has a minimal response to stimulation. What is the APGAR score? So I can very well give a APGAR score. You know, if you see the pulse, this 90 minutes pulse, this is a score of 1, right? And slow irregular breathing, this is again a score of 1. Then pink body with blue extremities is again a score of 1, and some flexion of his limbs is score of 1 again, and minimal response to stimulation is again a score of 1. So if you add up all these scores, they come out to be 5. So the correct answer over here is the C option. So a quick revision of the APGAR scoring system asked in every exam. One scoring system you should be thoroughly updated about. So A stands for activity, that means the muscle tone. If it is absent, 0. If it is flexion of the limbs, like in this question, 1 point. And if this active movement, then we assign 2 points. Pulse is absent, then 0. Less than 100, our child was having 90, so less than 100 is 1 point, and more than 100 is 2 points. Grimace, totally floppy, then that is 0 point. If there's minimal response to stimulation, when you insert a feeding tube, then that is 1 point, and this prompt response to stimulation, that is 2 points. Appearance, if the child is totally blue and pale, then 0 points. If there's pink body but the blue extremity, sometimes this is also referred to as acrocyanosis. Acro means the extremities. So if there's cyanosis or there's blueness of the extremities while the body is pink, then you give 1 point, and if there's pink body, then this is 2 points. Respiration if absent, then it is 0 point, and if it is slow and irregular, then it is 1 point, and of course the child is having vigorous cry, then it is 2 points. In our child, the child was in fact having all these features, so therefore it came out to be a score of 5. Right, so that is the correct answer. Let us move to the next question. A 32-week-old premature male infant develops respiratory distress shortly after birth. He is tachypneic with nasal flaring, grunting, and intercostal retractions. The mother has received no antenatal corticosteroids. The chest X-ray image is given below. Which of the following is the most likely diagnosis? So let us try to rule out all other. See, first of all, if you see the chest X-ray, it is a total white outline. Sometimes we are not aware of the chest X-rays, we are not able to interpret the chest X-ray. Let us see, is there a history of meconium, passage of meconium? Is there a history of intrauterine some kind of fetal hypoxia? No, it is not there. So why should we think about meconium aspiration syndrome? So this is totally out, right? Now, transient tachypnea of the newborn. Let us come to the third option. So, transient tachypnea of the newborn, occurs usually when the child is born through cesarean section in term babies, and there is, without any distress, the child has just a rapid respiration which just requires minimal oxygen, a maximum FiO2 of not more than 40%, and the breathing pattern in the coming 24 to 48 hours slowly normalizes. So that is transient tachypnea of the newborn. Again, a very non-malignant kind of condition, one does not have to be worried about. Then is the congenital diaphragmatic hernia, where of course there is herniation of the stomach and the other intestinal loops into the chest cavity, usually seen more on the left side of the chest, and because of this you can see that the child might develop even the pulmonary hypoplasia, which is a very important prognostic factor. Do we get, and in this case, what do we see in the chest X-ray is there would be multiple air fluid levels in the chest cavity, suggesting the presence of the herniated intestinal loops, right? Do we see anything like this over here? No. So even this is out, right? Now, what is left is the hyaline membrane disease. And what are the pointers towards hyaline membrane diseases? See, it is a premature 32-week-old infant. We know hyaline membrane disease is seen in with preterm babies because of the deficiency of surfactant. We know, as per our knowledge from physiology, the surfactant production peaks at 35 weeks of gestation, and this child is already born at 32 weeks of gestation, so definitely he is going to suffer from surfactant deficiency. Other thing is developing, he's tachypnic with nasal flaring, grunting and intercostal retractions. So this tells you the child is definitely in respiratory distress. So this is just not tachypnea. The child is also having respiratory distress. That means using his accessory muscles of respiration. Then the mother has received no antenatal steroids. So this is a big giveaway. So this should alert you, because antenatal steroids, they help in the maturation of the lungs. They induce the production of surfactant, and that is how they not only prevent the child from developing HMD, they are also protective against the development of IVH in preterms and also necrotizing enterocolitis. So these are the advantages of giving antenatal corticosteroids. You can give either dexamethasone or betamethasone, but the important thing is at least we need a 24-hour of period between the last administration of steroids and then the final birth of the baby, so that the steroids have an adequate and they get adequate time to exert their effect, right? So anyways, these three are the important disorders which are prevented by giving antenatal steroids, and just this line gives you a big giveaway. This is actually this tells you that you are dealing with hyaline membrane disease. The chest X-ray, of course, that shows a whiteout lung, totally whiteout lung. That again shows you a low capacity lung, and that is what tells you that you are dealing with hyaline membrane disease, or this is also known as respiratory distress syndrome. So therefore our answer becomes nothing but HMD, that is the B option over here. So a lot of hints were there in the question, and this should not confuse you anytime. Okay, now let us move on to the next question. A 3-year-old child presents with abnormal movements that come in volleys. The doctor made a diagnosis of West syndrome. Which of the following is the first line treatment? So as you can see, over here, the child is having a diagnosis of West syndrome. So what is West syndrome is? West syndrome is when you have a triad of infantile spasms. I hope you know this. Infantile spasms is there, along with mental retardation, along with, hips arrhythmia kind of pattern on EEG. So this triad is referred to as West syndrome. What is important over here is that infantile spasms and hips arrhythmia will always go hand in hand. What is important is MR. Now, nowadays we don't refer to as MR. We just call it developmental delay. So developmental delay occurring in a child with infantile spasms would be referred to as the child having West syndrome. This is named after its discoverer, H.G. West, whose the only child had this syndrome. So that is why it is known as West syndrome. Now the question arises, what do we give? Of course, the diagnosis, the treatment of choice is ACTH over here. That has to be given. Now the question arises, why not valproate? Remember, first of all, valproate IV would be given in the management of status epilepticus, not as a regular treatment. Of course, valproate does find its place in the management of infantile spasms, but not as the drug of choice. It is to be added later if the infantile spasms continue even after giving the a course of ACTH. Usually we give either a 14-day course of ACTH or a 28-day course of ACTH. Both are acceptable in different institutes, right? Each institute has its own protocol of giving ACTH. So ACTH is one, this is not a regular anti-epileptic, but it is only used for the treatment of infantile spasms. Another thing over here is is the use of vigabatrin. Where does vigabatrin come over here? Remember, if you have, everybody knows this, but still I would like to, point out over here. So because your exams are coming near, you should be very much aware of this. So if you have infantile spasms occurring in a child who's also suffering from tuberous sclerosis, right, then the drug of choice is not ACTH. I will write down and then cut it over here like this. It is not ACTH, then the drug of choice becomes vigabatrin. Very, very important, bacho. Please remember this. Very commonly and very frequently asked question, right? So, but over here, there are no features of tuberous sclerosis in this child. What features are we expecting? Either the child would be having something like ash leaf macules or a shagreen patch or adenoma sebaceum. So these are the common, skin related stigmata which are associated with a tuberous sclerosis. If that is there in a child and also having infantile spasms, then we will go for vigabatrin. Otherwise, for this question, our answer is the ACTH, right? Okay, now let us move on to the next question. Identify this congenital malformation shown in the image. So, is it gastroschisis? Is it ectopia vesicae? Is it, omphalocele, or is it Hirschsprung's disease? So, this is the abnormality which is shown over here, and we are told to diagnose this. Now, first of all, let us see other kind of malformation. So, you should know what is the difference between omphalocele and gastroschisis. Very commonly asked in your exam. So, omphalocele would be when there is a sac in which the liver and the intestines, you can see this protruding through a abdominal wall defect. So, this kind of sac is there which may contain the liver as well as the intestines. Liver may or may not be present, but it may, along with the intestinal loops. So, this is protruding out, and usually what happens is it protrudes out into the base of the umbilical cord, and it is midline in position. It is covered by a sac. That sac is nothing but this is the peritoneal covering. Very important. The sac is actually the peritoneum or the peritoneal covering. While vis-a-vis, there is gastroschisis. Gastroschisis, there is no presence of sac, as you can see the difference. And what is there is that there is just, herniation of the intestinal loops. And very importantly, remember, in gastroschisis, the intestinal loops are not coming out for the base of the umbilicus. It is actually an abdominal wall defect which is separate from the umbilical base, and usually it is associated on the right side of the body. It is lateral in position, usually on the right side of the body. And thus, there is just, the intestines are there which are lying outside the body cavity. Usually, the liver is not involved over here. It's only and only the intestines, right? So, that is the difference, and there is no covering of the sac. That means there is no protrusion of the peritoneal sac or the peritoneum over here. So, that is the difference between gastroschisis and omphalocele. So, do we see something like this over here? No. So, definitely this is not our answer. Right. Now, what about the Hirschsprung disease? We should know that Hirschsprung is the commonest gut motility disorder which is seen in children. It is the most common cause of intestinal obstruction in neonates, and usually it is characterized by the lack of ganglionic cells in the submucosal and the myenteric plexus of the distal intestine, starting from the anal region and extending proximally to a variable length, right? And usually, what we get to see, there can be total colonic aganglionosis. That means total colon is, not having the ganglion. As I was telling you, submucosal and the myenteric plexus is absent in the entire colon, or there can be a short segment disease. Remember, the male, it is Hirschsprung disease is more commonly seen in males. So, for 4:1 and 2:1, that you have to remember. So, for a short segment disease, the male to female ratio is 4:1. That is more common in the males. And again, this is also the total colonic aganglionosis, which is more common in males, but not that much as the short segment disease. So, in this case, you can see the male to female ratio is 2:1. So, that is the difference. And there's increased familial incidence in total colonic aganglionosis, right? So you should be knowing this. Now, in this case, what happens is the distal rectum is aganglionic, and this aganglionosis extends proximally from anus to a variable length in the colon. And this leads to decrease in intestinal motility, and usually the presenting feature would be delayed passage of meconium soon after birth, or even if it is missed, then later on the child will present with constipation. Down syndrome is a very important associated malformation. So this kind of information, is this given over here? No, it is not given. Moreover, there is no external abnormality in case of Hirschsprung's. So even Hirschsprung's is ruled out over here. What is left over here is, sorry, I have ruled out the answer also over here. Sorry. So initially we had ruled out gastroschisis and omphalocele. So what is the correct answer over here? By ruling out, we know the answer is ectopia vesicae. Now the question arises, what is ectopia vesicae? So ectopia vesicae, as we know, we should, if we have to discuss over here, what is ectopia vesicae? So here in ectopia vesicae, what we get to see are two varieties of ectopia vesicae in which there is complete ventral defect of the urogenital sinus and the overlying, skeletal system. So there's failure or development of the abdominal wall as well as the anterior wall of the urinary bladder. What you are seeing over here is the posterior wall of the urinary bladder. The anterior wall of the urinary bladder as well as the anterior abdominal wall is totally deficient. Now there are two varieties, complete and incomplete. In the complete ectopia vesicae, remember, pubic symphysis is not formed. That is your complete ectopia vesicae. In the incomplete variety, obviously the other variety is going to be called incomplete variety. In this case, incomplete variety, you can see that either the pubic symphysis or the penis or the clitoris, either of these can be totally normal. So that is it. And usually, what we get to see in this kind of ectopia vesicae is that the penis can be rudimentary. The posterior bladder wall is seen in the lower abdomen. As you can see, this is the bladder wall what we are seeing. We can see recurrent UTIs. You can also see, constant dribbling of the urine because, the bladder is herniated out because there is no storage capacity in the body itself. So this is how the child would present to you like. So this is nothing but ectopia vesicae that you should be able to answer over here, right? Okay, now let us move on to the next question. Which of the following is the best for screening of congenital adrenal hyperplasia? So congenital adrenal hyperplasia, we know, is a autosomal recessive disorder of cortisol synthesis. If you remember the pathway, this is the pathway for you, If you can remember it, very good. If you cannot remember it, just remember the commonest enzymatic deficiency leading to congenital adrenal hyperplasia is 21-hydroxylase deficiency, right? And if you have to see where does 21-hydroxylase, see it is over here and it is over here. So this is not being formed and this is not being formed. And as I told you, the definition of CAH is autosomal recessive disorder of cortisol synthesis, right? So this is CAH for you. Now you can see that cortisol is not being formed, but even aldosterone is not being formed, right? And because of this, there could be varied presentation in the male and female. Males would usually be having a normal genitalia, but they would present with salt wasting and circulatory collapse in the by day 15 of life. In females, what happens is because the sex steroids are in excess, they would present to you with female pseudohermaphrodite, and of course the salt wasting would be there, and both sexes would present to you by day 15 of life. But of course, the genitalia of the male child are going to be normal. Now the question is, what is the most important marker? Remember, more than 90% cases of CAH, remember this, are caused by 21-hydroxylase deficiency. So the most important marker would be something which is elevated in the blood because of 21-hydroxylase deficiency, and that marker over here is going to be, yes, that marker is going to be 17-hydroxyprogesterone. You can see from the pathway, because this is not working over here, this will get converted to this. Again, because there is a block over here, this is going to be very, very elevated, and hence 17-OHP serves as a very useful marker for the diagnosis of of 21 hydroxylase deficiency. So our answer is going to be 17 hydroxyprogesterone. So this is the correct answer. So that was it. We have concluded the pediatric questions. Keep MCQing and I'm sure you will get your desired result. Thank you. This is Dr. Dipali Gupta signing off as pediatric faculty from the NExT.